excited to have her with us. She's going to be speaking on some research she's done on physician burnout, and this is a big and important topic. We already, and I don't want to steal your thunder here. You're going to tell us, but we're already facing a physician shortage in this country, as you know, and physician burnout definitely decreases physician access, physician efficacy, and anything we can do to address this issue, I think, is really important. But from my perspective, advocacy is a big part of this. And as CAG is an advocacy organization, it is a big part of this. And so, occasionally, fortunately, my staff takes care of a lot of this, but occasionally I have to get on the phone with an insurance company. And it is infuriating, right? I mean, my blood pressure, I don't want to even check my blood pressure after I get on the phone with these people. Half the time, it's because the person on the phone with has no clue what they're talking about. But when I hang up that phone, I don't just kind of sit in despair. I say, that gives me an idea for a new law. We're going to change that law. They're not going to be allowed to deny that anymore. And that's exactly what we've done. And that's exactly what the nearly 50 physicians who make up the CAGLE Scientific Advisory Board have done over and over and over. And when we come each year and say, what are your ideas for new laws and new legislation, that's where they come from. And that's empowerment. And so rather than despair and burnout, we're using those interactions where we're fighting for our patients to fuel change, to fuel real change, because the power lies with healthcare professionals. It doesn't lie with the insurance companies, because we don't need insurance companies to take care of patients in this country. We gotta have healthcare professionals, right? And so, I hope you enjoyed Dr. Rahman's presentation, and without further ado, have her come talk with us.
Good morning, everyone. Dr. Matrana, thank you so much for that introduction. As mentioned, I'm presenting research called UroWeb, and I am a urology resident. I'm a PGY2 at Ochsner Clinic Foundation. And so UroWeb stands for Urology Resident Optimization of Wellness and Burnout Using Biofeedback. It's a pilot study, but a good portion of today is how I can apply this to oncology. As mentioned, this is Dr. Rose's research that I did with him, and he gives his regards from somewhere else. I have no disclosures to make. I think the most frustrating part about burnout is that we talk about it really vaguely. We reference it as something you feel, maybe I'm burnt out, I think I'm burnt out. And on top of that, it's an extremely personalized experience, so how I would experience burnout may not be how you experience burnout. But contrary to those statements, it's actually a very objective thing, and there are objective measures. You just may not be using those to describe it at this moment in time. And whether we agree or not that burnout is objective versus subjective, the downstream effects of burnout are very much objective. So as mentioned, attrition, physicians leaving the field, that's a literal brain drain, the financial aspect of it, the medical errors that are unfortunately made when you're extremely tired, maternal morbidity and mortality amongst female physicians and surgeons are all very real and tangible outcomes of burnout. So part of this will be urology focused, but I promise we will expand. Surgeons, we're a little self-centered, so we think we're the most burnt out people out there. Urology residents have a very high burnout rate. It ranges between 38 and 48% throughout residency, up to 70% during second year, so I am on the cusp of finishing that. For a practicing urologist, it's about 36% of people, and this is higher in women. Not that this is a competition, but I will say hematology oncologists do have us beat. Around 45 to 60% of you all are burnt out as compared to the urologists. And this isn't just the physician, but also ancillary staff, mid-level providers you all count within this statistic. It is not a new concept within we can see this has been being studied for the better part of 12 years. And so the field itself has a lot of data, which I cannot say is true for urology. You all are doing the research, quantifying it, thinking about ways you can impact burnout. And so I just want to give a kudos to you there. You are definitely leading the forefront. And I think that touches on what CAGLA is all about, which is getting information, gathering evidence, channeling it into empowerment and advocacy and change. I can't say all of medicine really channels that power, and so I'm really impressed with the group we have here today, already doing something about a lot of the things that are being discussed today. When I looked at oncology specifically, I wanted to see what are the risk factors that make hematologists, oncologists the second most burnt out group of physicians. And some of these are obvious. There's a lot of patient and family suffering that you may be talking about on a day-to-day. There's high expectations to solve very, very big problems and to alleviate this distress. It may feel that all the decisions you are making are life or death decisions. There's increasing demands on you by all people, your nursing staff, your administrators, your hospitals, you name it. And you're being held responsible for some poor outcomes, which may feel unfair sometimes. On top of that, you are losing patients that you care about deeply, and there are fiscal and administrative tasks on top of it. And with all that being said, I think there are two sides of every coin, so maybe the first half of my talk focuses a little bit on the negatives of burnout, but I promise it will get a little lighter. I was impressed to see that your governing bodies actually impact burnout on various levels, on a national stage, institutional, on a training level, and personal. There are guidelines and recommendations on what you can do. And it's not just ASCO, but it's also the American Society of Hematology, the American Psychological Oncology Society, the American Oncology Social Work Society, the National Comprehensive Cancer Network. They all have panels and task force and support programs. And I just really want to reiterate, the rest of us do not have this. So this is incredible. Urology is just out here trying our best. And at this point, I just want to survey the audience. Raise your hand if you know at some point you have felt or are burnt out. Fair enough. Now raise your hand, keep it raised, if you know what you can do to help yourself in that moment. I want to say it's like 20% of the audience that told me that was burnt out in the first place actually knows something they can do about it. UroWeb touches on that exact portion of people that I'm missing, something very tangible that you can do about it. So in between that personal and trainee level, not all of us are trainees, I myself am. So what UroWeb is giving a wearable feedback device, and again targeted towards veterans, to quantify our sleep, our recovery, our body strain, and to harness this into improving wellness and burnout metrics. We use something called a Whoop band. It's similar to an Apple Watch. It's similar to the Oura Ring. We use a Whoop band because when we're operating, we can't have things within the sterile field. The Whoop band you can move up to your arm, and so it can track your daily strain, how your heart rate changes. One of our goals was to see how stressed we are while we're on call or while we're operating, or who we're operating with. It's a very subjective, objective measure there. But you can also do calories burned in your recovery index. And most importantly for us, when we're on call and working these very long hours that we are not often honest with, sleep metrics and how they lead to our performance. We wore these day in and day out. The charge was pretty decent with it, but you can also charge it while you're wearing it, so that was awesome. And like I mentioned, I wore this in the operating room. The study had 3 phases to it. So the first 4 weeks, our participants were blinded, so we did not have access to our own data. We were just collecting information on ourselves. At the same time, we did a survey that measured our baseline burnout and our baseline wellness. So 2 contrary sides of that spectrum. The second 4 weeks, we were able to get feedback from our device on an app, the Whoop app, and we were able to see, like, I had a 98% strain and 10% recovery because I was on call and I had tough days both days. That sucks. And it also tells you your sleep debt, which, as we know, is hard to compensate from. The last 4 weeks, we were given wellness targets. These are guideline-based wellness targets from the American Heart Association, from the CDC, and we were told to do our best to meet these targets while monitoring the change of our data in the app, and then adjust yourself to meet these targets. These are the wellness targets I was just referencing. So getting about 300 minutes of moderate intensity exercise. If you're a resident, you get that from just rounding in the hospital. We're very blessed in that way. We're not blessed in our sleep category or our diet, but the goal was to have 2 to 3 cups of vegetables every day and 2 cups of fruit, minimizing alcohol intake, and maximizing your time in nature if possible. This was done in the fall, so the weather was still good. And then some form of mild mindfulness, whatever that means to you. This is where we started. So there were 14 of us, 2 of us withdrew. But our baseline, our wellness score was 13.5. And just so we all know, below 13 is signs of clinical distress, warranting further exploration of depression and burnout. So baseline, we're not doing so well. Our Maslach burnout inventory, which was scores that were also referenced in the previous research I had shown you in Hem-Onc. Our emotional exhaustion was low, that was good. Our depersonalization was high. I think we become cynical, unfortunately, as we practice perhaps medicine or perhaps go through the nature of residency, so our depersonalization is higher than desired. But our personal accomplishment was moderate, so we do feel good about what we're doing. These are our scores as the project went on, so block 1, 2, and 3. As you can see, we don't sleep more. That's unfortunate. We don't change our call schedules. That's a part of residency. We weren't going to change that. But interestingly enough, the days we felt rested doubled. From block 1 to block 3, our perception of how well or how rested we were statistically significantly improved, which is amazing. The contrary thing to that is we worked the same amount and we slept the same amount. So there must be something else that's there. When we look at our WHO-5 score, that number I said, like 13 is concerning, that went up to 15. So we were trending in the right direction. Unfortunately, that was not statistically significant. When you look at the MBI, we talked a little bit about the emotional exhaustion, depersonalization, and the personal accomplishment. Not much change across the 3 groups, but our emotional exhaustion decreased, again in block 3 when we had those wellness targets. The point being here, residents are burnt out. This is a nationwide problem. Physicians are burnt out, also a nationwide problem. I think what this study really touches on is physicians and surgeons are outcomes-based individuals. I think oncology can really relate to that. You want to see change, you want to have guidelines, you want to have something to work towards and feel good when you reach that goal. I think that's part of the human condition, especially when you're a very high-performing individual. There are a role of wellness targets, and there is a role for wearable device technology. And the other part of this is we do so much as providers, and I'm sure you all do so much as providers in oncology for the people around you, for the families that you work with. You give a lot of yourself, and sometimes at the sacrifice of yourself and the sacrifice of your locus of control. Having a device that tells you, hey Farah, you only slept 5 hours. You probably should most likely go to bed very early tonight. I think it's a reality check of how you're actually feeling in comparison to that to-do list and the expectations you have for yourself. This is a way to objectify burnout. So it goes away from being just a feeling or maybe just an idea to objective data points. So in conclusion, wearable devices and targeted outcomes are the way physicians can actually tangibly improve their wellness and their well-being, and there is a role in this in hematology and oncology. And as you go and advocate for various things, I do think advocate for yourself and your wellness in the process. We do hope to expand this. We're looking to expand this to different specialties within Ochsner, as well as practicing physicians. So if you are interested, please email Dr. Kyle Rose. He is more than happy to involve you. And with that, any further questions? Sure.
For the enrollees, whenever you're enrolling participants, do y'all supply the fans and?
Yeah. I should have mentioned that this is an internally funded study, and so it came with 15 Whoop bands, enough for our residents, which are a class of 15. But there is a role of getting more grants outside of Ochsner as well and expanding it. This is a pilot study, and I do think it did make strong waves at Ochsner. But if you enroll, we would give you the Whoop band, and you do get to keep it. Alrighty. Well, thank you.
Thank you very much. That was excellent and a really important topic. I'm very happy to introduce our next speaker, Dr. Andy Delvisio. If any of you have had a leukemic patient present in the emergency room in the middle of the night, you've probably called Dr. Delvisio at some point to talk about what to do. He's an exceptional and renowned hematologist. He trained at Rush in Chicago, a phenomenal program. And he practiced with me at Ochsner for a number of years. He and his family are kind of Ochsner royalty. His dad's been there for as long as I think just about anybody can remember. And his sister's been there for a long time too, I think longer than me. And he moved a couple of years ago to Mary Bird Perkins, where he's building great things out there. He and his family are also huge Tulane fans, so yeah, check that off. Check that box off for sure. Tulane alum as well. And he's here to talk about CAR T therapy. So without further ado, I'll have Andy come up.
Let me see if I get my slides. Oh, okay. Yeah.
Make your life easier.
All right, we're all set. Thanks for the introduction, Mark. And first, I want to thank CAGLA, Chad. CAGLA is a great organization, really advocating for patients and even providers in the state of Louisiana. So, a very important organization. Thanks for the talk about burnout. I think it's important. I think we need a whoop band for parenting. But no, great talks so far. So today I'm going to give kind of a brief talk that I've titled No Patient Left Behind, Improving Access to Cellular Therapy for Patients in Louisiana with Heme Malignancies. And I think what I'm hoping for is it's a short talk, but I hope it's kind of a call to arms for all of us, health systems, community cancer centers, pharma, insurers, to really come together to understand the incoming need for these treatments. And so hopefully you can come away with some potential marching orders for you and your organizations. So I always find this map to be incredibly sobering. Obviously, this is a meeting about cancer in Louisiana. And so if you actually look at CDC data about incidence of cancer in the United States and outcomes with cancer, Louisiana remains kind of at the bottom of the barrel. Top 10 incidents, top 10 worst outcomes, and then you kind of hone in even closer to the river parishes where a lot of us call home, and what you're seeing is some of the highest incidence of cancer in the United States. And unfortunately, we've gotten a lot of press in CBS, 60 Minutes, about this, and there's very factors why this happens, but I think it just points to the fact that advocating for our patients is incredibly important in the state of Louisiana. Included in these numbers are the blood cancers that we treat CAR T therapy with. So very close to home for us. And then I can tell you, having practiced here, the amount of this cancer that we see in the state and in young patients is really breathtaking. When we talk about CAR T therapy, we know that this has been traditionally limited to large urban areas academic medical centers, FACT-accredited centers, where these initial clinical trials first took place. If you look at the first CAR-T approval that came in 2017, really it was limited to a small amount of cities. Over the subsequent 5 years, it did expand to a number of other cities, but now we're really at a point now where we need to start thinking about expanding this to smaller community centers, smaller community hospitals, and the reason being is that we know that only about 1 in 5 patients who meet the indication for this even receive a referral. And so these aren't drugs that are just, we can buy them a few months. These are potentially curative treatments. And so really it's important that we get this 20% up, moving forward. A couple other factors that make the accessibility to CAR-T therapy incredibly important for the state of Louisiana is we have an aging population. There's a number of factors here that play into this, but if you look at from 1980 to 2020, the number of patients over the age of 65 has increased by almost 5%. And we also know that the incidence of lymphoma and multiple myeloma increases as we age, and these are the two leading indications for CAR-T therapy. So as you can tell, from a simple demographic perspective, the need for these therapies is only going to increase. Another important part about this with CAR-T is if you look at the indications that CAR-T are going to be for. Right now we have indications for a number of different leukemias, lymphomas, and multiple myeloma. But right now there are dozens of trials. I think I counted over 80 on clinicaltrials.gov looking at CAR-T therapy in solid tumor malignancies. There's some early trials showing some success in those spaces. I still think there's a lot of work to go, but I think we'd be foolish to think that these are not going to be coming down the pike pretty quickly and even become standard of care. Additionally, in autoimmune diseases, we've seen some very impressive trials in diseases like multiple sclerosis, lupus, particularly very tough to treat refractory cases. And so we know that these lymphoma CAR-Ts that have been repurposed for autoimmune diseases also are likely to be approved in the coming years. So the number of indications is going to improve. Currently, these CAR-T programs, or CAR-T products, are only indicated for relapsed disease, so your lymphoma or your myeloma that's come back. But currently, there's a number of first-line trials ongoing. We've already gotten some early readouts from these trials that look to be positive in the first-line setting. And so I would expect in the coming years, probably in the next 5 years, we're going to start getting first-line indications for CAR-T therapy. So this is going to be standard of care for first-line treatment. So take all these factors together, an aging population, higher cancer incidence in the state, more approvals in earlier lines of therapy, new approvals in solid tumors and autoimmune diseases, and frankly, an inadequate number of centers offering cellular therapy, we're looking at a big, big problem. And this is not 10, 20 years down the road. This is probably in the next 5 years that we're going to see this massive tidal wave of need. So how do we fix it? So I think there's a few topics I wanted to touch on. One is removing regulatory hurdles. Second is reducing payer friction. And then third is increasing the number of centers and practices offering cellular therapy. And this comes down to kind of, I think, two big factors, which is identifying and hiring cell therapy physician and administrative champions, and then also building outpatient delivery models that make these drugs more accessible. So with regard to removing regulatory hurdles, I'd like to give a big kind of prop to pharma, because traditionally, CAR-T had been limited to FACT-accredited centers that had run the initial clinical trials. I think the companies came to understand that if they stuck to this model, that not only would their businesses not grow, but also patients that desperately needed these therapies would not get them. So what they've done is actually granted what's called Authorized Treatment Center a designation, so you don't need FACT accreditation. Now, this still requires rigorous confirmation of infrastructure and expertise to safely administer these therapies, and as somebody that's just been through this, it is not a kind of a just sign off and go process. Like, you do have to prove a lot of things that you can do this safely. And I found the environment to be highly supportive and collaborative. It was not adversarial at all with the companies, and it didn't cost anything. And we stood up our program in about 11 months. So it took us less than a year and freezed our first patient last week. So you can do this. The FACT, I think traditionally, FACT accreditation, which is a foundation of the accreditation for cellular therapy, this is our kind of governing body that grants kind of the stamp of approval. They also came to realize that they could not limit this to just large academic centers. So they actually created a standalone accreditation for just CAR-T, so you didn't have to apply for autologous transplant or allogeneic transplant confirmation. And this removed a lot of the unneeded burden for centers not pursuing stem cell transplant, i.e. you didn't have to have an HLA lab, You didn't need to have stem cell mobilization, collection, storage that you typically have to have for like autologous or allogeneic transplants. This still requires fees, and it does have stringent documentation and staffing requirements. They actually released the standards for this just in the last year. This is actually free online. So you can take a look at this to see kind of what checkboxes you would have to make at your center if you wanted to take on these projects. They actually do have consulting services. They're an arm of FACT, as well as other private companies that will offer you consulting services. It's not cheap, but they can certainly hold your hand through this process. So kind of getting to the crux of all this, and I think what causes a lot of the obstruction here is the cost of CAR T. So we're looking at probably about, on average, $500,000 for a CAR T product. Now, the majority of this comes from the actual product itself, but all the supportive care that required to do CAR T, apheresis, lymphodepletion, the facility fees, toxicity management, monitoring, you can see the breakdown here. Now, the three kind of models that have been used traditionally for administering CAR T have been strictly inpatient, a hybrid model where patients are admitted maybe just during the high-risk period, or a fully outpatient model. And you can see here, based on the cost, that clearly the cost benefit is with outpatient models, or as much as outpatient as you can keep these patients. So given that cost, we've seen a lot of insurance kind of push back in the state of Louisiana. Now, the American Society for Transplant and Cellular Therapy, they published a paper back in 2023 that took a number of metrics to say what's a state that's friendly for CAR T administration based on their insurance coverage. And we got a wonderful unreasonable rating. So there's a number of factors that play into that. My former colleague, Clark Alsfeld, who's a transplanter at Ochsner, he has done a tremendous amount of work both at the federal level, going to the Capitol Hill, meeting with our senators and state House representatives, as well as on the state level, to get Medicaid coverage for this. And they actually got a bill passed in 2023, House Bill 435, that dictated Louisiana Medicaid had to pay or cover CAR T. But then the asterisk came. So what Louisiana Medicaid said was, well, okay, we'll reimburse this, but they posted rates that basically made it untenable for any kind of health systems to offer coverage for this. And so if you look at whether it was the acquisition of the product, the hospitalization, complication management, the apheresis, the post-infusion monitoring, essentially it was either a wash or a loss when they got Medicaid reimbursement. So even now, if you were to offer a Medicaid transplant, the estimated loss would be between $200,000 and $400,000 for a health system. Not really tenable in today's environment, right? So I think there's a lot that needs to be done on that end, and I think that needs to come from health systems, physicians, patient advocacy groups about getting better coverage for CAR T therapy for our patients, because we know a lot of patients have Medicaid, and as Medicaid's getting squeezed more and more, as you see in the news, I think this is only going to become more important. So not to say that commercial insurance is the easiest to deal with either. Particularly in the adoption of community centers, which is what we want to do, expand these therapies to community centers and meet people where they are. There's still a lot of financial barriers. We see high upfront CAR T acquisition cost, bundled payment negotiations favor large health systems, large hospitals capture inpatient and outpatient revenue, community programs are often excluded from preferred payment models. With regard to contracting barriers, centers of excellence favor large academic hospitals, existing system-wide payer contracts, and long credentialing timelines for new CAR T programs. And then we have limited payer familiarity with community programs. I can tell you, having started to deal with this, we really have to kind of battle for every single case agreement. It takes multiple red lines, and a lot of times this is when patients with aggressive cancers are waiting to get the all go ahead for this. So this can really be anxiety provoking for the patient, the physician, and then you can do all this work, say a patient's eligible, and then the insurance can turn around and say, well, we're going to cover the X, Y, Z on this amount, and actually operate at a loss. So we really need to figure this out, especially insurance companies and health systems, about how we can make this tenable for everyone. There's also a lot of perception barriers, I think, with community cancer centers. Assumption of toxicity management requires academic centers. I think this is not necessarily true. Perceived infrastructure advantages, travel programs that steer patients to contracted sites, and then community outcomes often are under-recognized. So basically what we get from all these things is an impact on access to states like Louisiana. So ways to help this. So one, I would say, a main thing people need to do is, or programs or systems need to do, is identify a physician championship for cell therapy. So you have to have a clinical leader. You have to have a cheerleader, somebody that's going to come in there and kind of, like I said, knock heads, beat on the table, get things done. So you want to identify that CAR T clinical lead. They need protected time. The adjustment of SOPs, meetings. It's a very time-consuming process that has to be taken outside of direct patient care. So that needs to be recognized. And then it needs to be a physician-known program. It can help build a referral base, educating regional oncologists. It can promote early CAR T referral, which we know is imperative to good outcomes, and then provider outreach. And then as a program driver, it helps develop program protocols, coordinate care, and guide FACT accreditation. So I would say it's the single most important factor in successfully launching a community cellular therapy program. I would tell all my colleagues at either centers that are starting or thinking about this, start identifying a person now. These programs are essentially at every major academic center now where our fellows are coming from. And so really every fellow you're going to get now is going to have some experience. And so if you're hiring new doctors, start focusing on fellows that are interested in this or willing to take this on, because it's going to be important. And I do think that CAR T therapy is going to be the standard of care in coming years and may be necessary for your survival as a practice financially. If you can't offer a standard of care, people are going to go elsewhere. So important to start thinking about this now. So another thing that we've really focused on at Mary Bird, and the experience has been, is really administering in the outpatient setting. Planning to only admit patients when they need to, rather than the traditional kind of 10 to 14-day admission. We know that outpatient CAR T therapy means increased access. It's increased treatment capacity. It reduces the dependence on limited inpatient oncology beds. It allows more patients to be treated simultaneously. This enables treatment at community cancer centers. It can be delivered in an ambulatory setting, avoids referrals to distant academic hospitals, i.e. meeting the patients where they are. It reduces patient travel burden, so they can be closer to their home and their loved ones. And again, this is particularly important for rural and underserved regions. It also shortens times to therapy, avoids inpatient bed delays that postpone infusion, and we get faster transition from apheresis to lymphodepletion to infusion. And it also lowers the cost, as I showed earlier, sometimes substantially by up to half. This avoids high inpatient episode costs, and it makes CAR T more financially viable for community cancer programs. So a little bit about our experience. I came on back in January. In about a year, it took us to kind of get activated for CAR T. Again, I think they did a wonderful job of identifying a physician champion. I would recommend that you contact pharma companies early. They are wonderful partners in this, and they want you to succeed very much. So one of the first things I did was send emails out immediately to pharma saying, hey, let's start talking, let's get this conversation going. And really, they have a ton of resources to help get this off the ground, and they are very interested in helping community sites. You want to identify a partner hospital. I know for smaller community cancer centers that are mainly outpatient, you do need to identify a partner hospital. Look, as much as we try to keep these patients out of the hospital, we know about half of CAR T patients will get admitted during their initial 14 days, but that means half won't. But again, you want to be able to identify a hospital that has adequate ICU care, specialist coverage, neurology, cardiology, infectious disease, GI. Again, most large community cancer centers will have this. And I did make a point to kind of reach out to those subspecialists right when I came on, saying, hey, we're going to need a champion in each of these subspecialists to kind of help us should a patient get admitted. And I found people to be more than interested. And frankly, a lot of the younger kind of subspecialists who are coming out of these academic centers have experience dealing with these complications in their own fellowship. So it's not like they were like, what is this? We don't know. You do need to identify an apheresis partner. Kind of large health systems have typically have in-house apheresis. But right now, companies like Fresenius, Red Cross, they can offer these, and you can contract with them, and they can actually even come to your site, collect these cells, and ship them off. And so these actually are in place. And they often have their own SOPs and things like that really make it easy. You want to get practice, leadership, and legal and financial teams started on contracts early. Because of the cost of these, there's tons of back and forth and redlining. And so you really want to have somebody that's experienced from the legal and financial side of negotiating these contracts. And again, start building your team early. You'll need APPs, pharmacists, nurse coordinators, quality program directors, financial counselors, benefits managers, and you need to be patient. This process can take a year, even longer. But again, if you're dedicated and start putting these feelers out, it's definitely something you can achieve. I would say focusing on outpatient administration is really important. You know, one easy way to start this process is to start with bispecific antibody outpatient administration. It's a great way to get your feet wet before rolling into CAR T. We've adopted an outpatient-only ramp-up program at Mary Bird. So with myeloma bites, there's actually a lot of evidence now. They've had large group studies out of Mayo, Emory, showing that this can be safely done with minimal admission risk to patients. You know, obviously we like to see patients with a reasonable disease burden, acceptable comorbidities, compliance, and a caretaker before we can kind of sign off on outpatient administration. We have routinely started giving prophylactic tocilizumab as a standard pre-medication 30 minutes before step-up dose 1. And what we found is that has decreased the CRS rates from over 70% to less than 10%, and in some small studies with certain bispecific agents, 0% CRS. And so I think that really this is the wave of the future to keep patients out. One of the things I'd often hear is, well, I'm not going to get reimbursed for my tocilizumab. I would tell you to look for biosimilars. Some of the biosimilar TOSI agents now are actually very cheap, and it's much cheaper even just cover the cost of that. We've even had some luck getting reimbursed. So that's something you want to look into. And actually, it's included in NCCN guidelines now. So we've heard a couple saying, well, this is off-label. It's in NCCN now. They use the word consider, which is always tricky, but you know, that's in there. Again, we have evidence-based you know, protocols you can quote now. We provide home monitoring kits to patients, so basically a blood pressure cuff, a pulse oximeter, a thermometer, that they take their vitals twice a day. We educate the caretakers and the patients to notify us immediately if anything develops that's of concern. We provide a patient what we call our pocket dex, so a 10 milligram dexamethasone dose that they can take at home with instructions to kind of recheck their vitals immediately after, and obviously they worsen, they come on into the ER. And then we do MD APP visits the day of injections, and then nurse phone visits with modified phone I scores, basic CRS, ICANN screener questions, and that gets escalated to the MD if it's abnormal. And we have clear escalation pathways for presentation to the emergency room with our partner hospital and for admission to the floor of the ICU. With regard to the lymphoma bites, you know, we see a lot less CRS than we do with the myeloma bites, and so we still do the same thing of the same day appointment and then telehealth visits as with the myeloma bites. Again, generally a lower CRS rate and severity than with myeloma bites. We prefer epcoritamab given the CRS rates versus Glofit, and then we follow standard pre-medications you know, prior to the dose 1. And we don't use prophylactic tocilizumab unless they're deemed high risk by the provider, so elderly, high disease burden, or comorbidities. With regard to our CAR T program, you know, before we even tell a patient they can do this outpatient, we have criteria that they must meet. So we actually use the modified E6 score, which is a combination of some laboratory tests we punch in, and it gives you a risk for the patients. If they're low to intermediate, we say that they're eligible for outpatient. They have to have an acceptable comorbidity profile, acceptable caretaker support and compliance, acceptable disease burden, and then the weekend clinics. So they do Monday through Friday clinics, and then on weekends we have an APP-MD covered clinic on the weekends. Same home monitoring vital kits that we provide with our bispecifics, and then day 0 to 10, or to day 10 to 14, depending on kind of how the patient's doing. We do Q4 to 6 vitals while awake at home, and then temperature, and then three times a day vitals, and then we do a twice ice score home. They do a daily visit in the morning, and then we do a APP phone visit in the afternoon, and then we have clear escalation pathways for presentation to the ER and rapid tocilizumab or steroid administration. So a little bit about the E6 score. I found this to be very helpful. This is a simple tool that's been validated. So you take a patient's LDH times a creatinine divided by platelets, and this is calculated between day 5 and 0. And based off of their number, you're able to get a prediction of grade 3. Grade 3 or higher CRS. And so for our kind of high or very high patients, we've actually have a plan in place to where we may prophylactically admit those patients, you know, following administration of their cells. So take-home points, the oncology community in Louisiana has an obligation to our patients to make these treatments available close to home. They need these therapies, the need for these therapies is only going to increase. We need to start investing in personnel and infrastructure now, and cell therapy will likely become the standard of care in many disease states in the post-chemotherapy world, and it may be a matter of financial viability for community oncology practices to adopt this. And we now have evidence that evidence-based practices to safely administer these treatments in the outpatient setting. And next-generation cellular therapies, risk prediction tools, and prophylactic interventions will make administering these in the community easier, I truly believe. Thank you. Any questions? Thank you. All right.
That was terrific. Really appreciate it. For those of you standing up, there's plenty of seats over here. On this side, please don't feel like you have to stand in the back. Chad did want me to remind everyone that we're going to be raffling off those David Yurman bracelets at lunch today. There'll be time for you to visit the booths to get more tickets if you haven't done so already. So please make sure to do that. That was tremendous, Andy. Thank you so much. And I think it's an extremely important topic. It's an extremely complex topic, but we've got to figure out how to bring these therapies to our patients. And obviously, it takes a lot of work, but it can be done. It can be done, and it has to be done because it's the right thing to do for our patients. Shifting gears a little bit, we're going to come to one of the most important aspects of our conference is our poster session. Our annual poster session and our annual abstract competition. We received almost 150 abstract submissions this year, and this morning you're going to hear from the top 3, those who were selected as the top 3. Can we bring up those slides, please? All right. All right. So the first award winner, and these folks know that they've won an award, but they don't know if it's first, second, or third place, and they will find out this evening at our crawfish boil. And you know, these come with big cash prizes. We're one of the only conference in the country that gives cash prizes to trainees for abstract awards. So make sure to come to the crawfish boil to see which are selected for which award. The first is a really important topic. As you all know, CAGLA has been very, very active in passing laws to promote genetic testing, precision medicine, biomarkers, and so on and so forth. But insurance companies don't always follow the law. And the analogy I like to use is if I walk down the street punching people in the face, I'm probably going to get arrested at some point. And if I look at the cop and say, sorry, I didn't know that was illegal, or I haven't had time to update my policy on punching people in the face, I only do that every 2 years when the committee meets. It's not much of an excuse, but those are the exact excuses insurance companies use to break the law each and every day. And our insurance commissioner holds these people accountable. Recently, the insurance commissioner, Tim Temple in Louisiana, published probably the strongest worded letter I've ever seen from any insurance commissioner about following this particular law, and basically told the insurance companies there's no getting around it. There's absolutely have to follow the law. There are no exceptions. But the research we're about to hear from Joshua Cybecker, who is a third-year medical student at LSU Shreveport, and I hope Joshua's here. Great, glad to have you. Come on up. Is about just this. How was the law impacted? Did the insurance companies actually follow the law, and did it change genetic testing? So I'm anxious to hear it. Thank you.
Thank you, Dr. Matrana, for that introduction. I liked your analogy. So, good morning, everyone. My name is Josh Siebeneicher, and I'm a third-year medical student at LSU Health Shreveport. I'm honored to be here today and have the opportunity to present the findings from my summer research project. I will be discussing how Louisiana Senate Bill 84 influenced access to next-generation sequencing for our patients at Feisweiler Cancer Center in Shreveport. I think we can all agree that as precision medicine becomes increasingly central to oncology, ensuring equitable access to genomic testing is no longer optional. It is essential. Okay, so next-generation sequencing, also known as NGS, enables the simultaneous DNA and RNA sequencing of hundreds of genes up to the whole human genome. This is so important because we know that most tumors harbor multiple genetic mutations, and traditionally, identifying these mutations required multiple separate molecular tests. However, with the advent of NGS, we're now allowed to have a single assay approach. We can detect multiple variants and multiple mutations with one assay. In oncology, targeted NGS panels can be selected based on disease type, and the results of these panels are routinely used to guide diagnostic classification of disease, the selection of targeted therapies, and then also prognostic assessment for the patient. Despite the clear clinical value of NGS, access has historically been limited by inconsistent insurance coverage and variable prior authorization requirements. We know that coverage policies differ widely among payers, and this often results in delays and even outright denials that postpone critical treatment decisions. In response to these challenges, our state enacted Louisiana Senate Bill 84, effective in January of 2022. Senate Bill 84 mandates insurance coverage for next-generation sequencing and genetic testing when ordered by a treating oncologist or hematologist. The passage of Senate Bill 84 was strongly supported by efforts from the Cancer Advocacy Group of Louisiana, and I know many members of the audience here today played an integral role in advancing this legislation in Baton Rouge. The intent of this legislation was to standardize approval processes, reduce delays to testing, and expand overall access for patients in our state. We wanted to see how Senate Bill 84 influenced our population up in Shreveport. Our objective was to evaluate the impact of this mandated coverage on insurance approvals, NGS utilization, and overall survival outcomes for patients seen at Feisweiler Cancer Center with NGS orders from Feisweiler Cancer Center Genomics Lab. Each year, our lab processes roughly 300 NGS orders, giving us the adequate sample size for this pilot study. I'd also like to include a little background information about our lab. We were established in 2017, and we are currently accredited by both the College of American Pathologists and the Clinical Laboratory Improvement Amendments. Our laboratory currently utilizes the Illumina TrueSight Oncology 500 pan-cancer panel. And this panel allows for comprehensive genomic profiling, including assessment of tumor mutational burden and microsatellite instability. I'd also like to add that this study coincides with an important transition period for our lab. In 2020, our lab, like so many labs across the country, shifted primarily to COVID testing. And then in 2021, the lab developed the current NGS protocol that we use today. So 2022 is a very important transition year. It's the first year that our lab had its current NGS protocol in place. It is also the first year that Louisiana enacted Senate Bill 84 and mandated insurance coverage for next-generation sequencing. Moving along to our study, the following flow diagram outlines our initial cohort selection and analytic approach. We began with an initial cohort of 711 patients, and these patients had an NGS order placed between 2022 and 2023 at our genomics lab. We then excluded 93 patients based on predefined study criteria. We excluded patients younger than 18, older than 95, those with an incomplete NGS order, and also patients who were currently incarcerated. After applying these exclusions, we were left with a final cohort of 618 patients. For this cohort, we then gathered detailed data, including general demographics of age, gender, and race, cancer type and pathology data, including staging, insurance approval status, and also date of last follow-up or date of death. After creating this final cohort, we then began our initial review. We evaluated NGS approval rates stratified by payer type and assessed patient outcomes on date of last follow-up. We then conducted statistical analyses stratified by payer type, demographics, and progression-free survival to better understand differences in approval patterns and clinical outcomes. Notably, the payer distribution in our study population is nearly the inverse of the statewide pattern. Statewide, 44% of patients are privately insured. And then the chart on the top is our data from 2023 for our state. So statewide, almost half the patients are privately insured, but in our population at Weisweiler Cancer Center, only 14% of our patients have private insurance. In contrast, 46% of our patients were insured by Medicare, whereas only 14% of patients statewide have Medicare coverage. Additionally, the proportion of Medicaid patients in our study was about 10% higher than the statewide average at 41%. So, I'd like to say that this difference, while it is a stark contrast, is not necessarily unexpected. Academic medical centers and teaching hospitals often function as safety net institutions, and we care for a disproportionately higher share of Medicare and Medicaid patients, especially when compared to the community setting. As a result, our findings may not be directly generalizable to the broader statewide population. In our pilot study, 55% of our patients experienced either a denial or delayed approval for NGS testing. For context, the nationwide Medicare denial rate in 2021 was 33%, which is notably lower than what we observed. We grouped patients by payer type. Our payer types included Medicare, Medicaid, and then all private payer insurance companies together. We found that there was no statistically significant difference in approval, delay, and denial rates among payer type. We then assessed by gender. Males and females did not have significantly different approval, denial, and delayed approval rates. Our population consisted of primarily white and African American patients, but we found that approval and denial rates did not significantly differ by race. Finally, we looked at the impact of Senate Bill 84. In 2022 and 2023, we found that approval and denial percentages did not significantly differ. Less than half of our patients received initial approval for NGS testing. This persistent denial led our lab to look for outside funding. In the late quarter of 2023, we received private funding that secured NGS testing payment for patients in 2024 and 2025. Due to this private funding, we do not have data past 2023. However, we do have 2 years of follow-up data at least for all of our patients in 2022 and 2023. Now, following along, I know I've given a lot of descriptive information and statistics, and some of y'all might be thinking, well, how does NGS testing change by payer type? By cancer type, excuse me. And after all, it's a valid question. Cancer is not just one disease, it's multiple different pathologies. I would like to say that given the pilot nature of this study and the limited number of patients within each cancer subtype, meaningful subgroup analysis was really only feasible for our colorectal cancer cohort at this time. And for our colorectal cancer patients, the payer distribution was similar to our overall population, predominantly Medicare and Medicaid coverage. And additionally, I'd like to note that only 42% of patients in the colorectal cancer cohort received initial approval for NGS testing. In our cohort, among patients who experienced an initial denial for testing, Medicaid patients with an initial denial had a significantly lower overall survival compared to privately insured and Medicare patients with a p-value of 0.0017. Now, I'm not saying that the denial of NGS alone led to poor clinical outcomes, but I am saying that the denial of NGS is a part of a larger clinical picture. We suspect this lower overall survival reflects broader systemic and socioeconomic barriers. Genomic testing may function as a surrogate marker for overall access to timely, comprehensive oncology care. These patients may also experience delays in testing, screening, and reduced access to primary care in general, and this can potentially lead to a more advanced disease state at presentation. Additionally, we are a safety net institution, and we often care for patients with a higher comorbidity burden and a greater clinical complexity. Overall, in this pilot analysis, approval for next-generation sequencing remained inconsistent across payer types despite the implementation of Louisiana Senate Bill 84. We did not observe a significant change in approval rates between 2022 and 2023, nor did we detect differences when stratified by race or gender. However, in a subgroup analysis of colorectal cancer patients, those insured by Medicaid who experienced an initial denial demonstrated a significantly lower overall survival compared to privately insured and Medicare patients. Overall, Senate Bill 84 represents meaningful legislative progress, but the denial of NGS persisted. I'd like to address a few limitations head on. Our study is primarily composed of Medicare and Medicaid patients. While the bill, Senate Bill 84, is primarily geared towards regulating the private payer industry. Additionally, we only looked at next-generation sequencing. In Senate Bill 84, it mandates broad coverage for molecular testing, which includes NGS, but also every other test in the field of genomic testing. But ultimately, the fact remains that NGS testing was still denied in our state despite the passage of Senate Bill 84. This shows that policy reform can only be as effective as its implementation. So despite our progress, the fight is not won. Ensuring equitable access to genomic testing remains an ongoing priority in the delivery of cancer treatment in our state. Thank you for your time today. I've included my references, and I'm happy to take any questions from the audience.
Well, I just have a comment. I think this is phenomenal and terrific research, and I hope you publish it. Because this is something we really need to disseminate. And this is the type of data that we would really like to share with our elected officials, because our elected officials feel like once they pass the law, once it's been signed, that's it, it's done. But what we see is that may not always be the case. Like you said, implementation is really, really important. But also, I think you guys are really smart to look at outside funding, because we can't rely on the payers for everything, because we know they're just not reliable completely in every case. I work at Ochsner, and through sort of complex arrangements, a lot of our patients don't have as much responsibility through data sharing with the folks who do the sequencing and that sort of thing. So we bring value to them through the data, they bring value to us through the sequencing, and it works out really well. So kind of alternative arrangements, I think, are really important to fill the gap where the payers fall short. But this is terrific and so very, very, very important. So anybody else? Yeah.
Yes.
Yeah. So I'll echo what Dr. Trent said, and I think for where you are in your training to be this far along is amazing, and I think this speaks to the importance of advocacy to begin with. But I think one thing that really stood out, and insurance companies seem to maybe be the most equitable part of medicine, and that is denials for everybody. Okay, and so I think it speaks to that challenge. We're addressing this on a state level, but I'm glad you brought up the potential for federal issues as well, because a lot of the Medicare is going to be mandated by federal legislation, which speaks to our multi-tier advocacy that's required. So kudos, I think great presentation and wonderful data.
Thank you so much. Thank you.
Well, if that's the future of medicine, I think we're in good hands. So, I also want to recognize our abstract competition committee, which is made up of a subset of our scientific advisory board. They work really, really hard at reviewing these abstracts. It is very, very difficult for them to select the winners, because we have so many phenomenal abstracts that come through, and they put a lot of work into that, especially our abstract committee chair, Dr. Jackie Turner, who was supposed to be here this morning with us. She sends her regrets. She had to attend a funeral, so we're sorry for her loss, but just want to recognize her for the hours and hours and hours of work that she puts in to make this happen. Our next presentation is going to be given by Dr. Elizabeth Chang. Elizabeth, are you here? Oh, great, yeah, come on up. And she's from Tulane.
And she is going to talk about in silico discovery of fusion-specific RNA biomarkers in pediatric leukemias. So again, we're seeing biomarkers, precision medicine. This is a big piece of it. So we're so happy to have Dr. Chang with us and hear about her research. So thank you. Yeah, welcome.
Oh, shoot.
My slides went off, guys. Can we get my slides back? Our AV team? Okay. No. I'm sure it is not your fault. Until end user. Huh. Okay. Oh, let's see. There we go. Okay. All right. Okay. That was unfair.
Okay. So first off, I would like to thank the leadership and the committee for allowing me the opportunity to present part of my research. My project is called In Silico Discovery of Fusion-Specific RNA Biomarkers in Pediatric Leukemias. So as we know, pediatric leukemia is the most common cancer in children, and progress over time has generally improved. The 5-year survival rate now exceeds 85%. It's up from under 50% in the 1970s. And during this time, the mortality rate in the US has also dropped by more than 1/2. However, despite these good statistics, persistent challenges do remain. They include relapse risk, where the rate is about 15%, and post-relapse survival is around 35%. There is a global survival gap, with the 5-year survival in low-income countries being under 40%, and in high-income countries above 85%. Some studies suggest that delayed relapse detection may lead to worse outcomes, and the diagnostic process itself is both invasive and costly. Now, while adult leukemia originates more from mutations and epigenetic changes, pediatric leukemias are predominantly driven by fusion genes. And this is a nice graph which shows the incidence of common translocations in AML. So the x-axis spans the age range from the infants to the elderly, and the y-axis shows fusion frequency. And each of the colored lines is a fusion gene, with the gray one being normal cytogenetics. As you can see, fusion genes are highly concentrated in the infant, children, adolescent, young adult range, and it tapers off in the adult and elderly population. So from here, we can see that fusion genes follow an age-specific pattern, and we could potentially use them as potential biomarkers in pediatric leukemias. And this leads us into a new class of transcripts called neogenes. So neogenes were discovered several years ago by Viber and his colleagues to be these novel multi-exonic transcripts that arise from silent regions of the genome, and they're not annotated in standard transcriptomes. And what makes them interesting is how they actually get turned on. So in normal tissue, there are a lot of these silent genomic regions where transcription does not occur. However, in fusion gene-driven cancers, there are these things called oncogenic chimeric transcription factors, which bind to these silent genomic regions and activate abnormal transcription. So here's a common example, the EWS FLY1 fusion protein Ewing sarcoma. It binds to this previously silent genomic region, and it starts activating transcription. When that occurs, it creates these Ewing sarcoma-specific neotranscripts that eventually get spliced and polyadenylated and becomes these Ewing sarcoma-specific neogenes. So from here, we can see that these neogenes are tightly linked to fusion genes, they're highly cancer-specific, and they're not found in normal tissues. And from a diagnostic perspective, this specificity is valuable as we can use them as potential biomarkers in pediatric leukemias. So the gaps in knowledge. Well, first, what is known? We do know that fusion genes create neogenes in sarcomas, and this is a figure taken from the Viber paper where they looked at 18 different sarcoma types, and they found that each of these neogenes, or sarcomas, have specific neogenes that are driven by these oncogenic chimeric transcription factors, which is shown in this middle panel. And it's specific because we don't see any of these neogenes in the top panel, which is from other cancers, and they're not found in normal tissues from this bottom panel. And from our previous graph, we have seen that pediatric leukemia is largely driven by fusion genes. So the known unknowns now are, can we detect these neogenes in pediatric leukemia? Are these neogenes subtype specific? And are we able to use them as potential biomarkers? To do this, we assembled a custom bioinformatics pipeline to detect these neogenes using open source tools. We also use publicly available RNA-seq data sets. We first use a package called STAR Fusion because we know that to confirm the presence of fusion genes, because we know that neogenes originate from these fusion events. We then use STAR and SCALLOP, which helps us align and assemble the RNA-seq reads to a human reference genome. And then we use GFF Compare to help us identify all of the unannotated transcripts. Then we quantify and normalize those unannotated transcripts. And then lastly, we filter candidate neogenes based on 3 criteria. The first, that it's highly expressed in our leukemia subtype of interest, that it is strongly upregulated compared to other diseases, and that it is minimally expressed in unrelated tissues. So after going through this pipeline, we came up with this heat map for the expression of neogene transcripts in acute monocytic leukemia. And to orient you, each of these columns represents a subtype. So in this left-hand panel, we have the 7 pediatric leukemia subtypes. And in the middle panel, we have 6 other common childhood malignancies, with the first 3 being non-fusion gene-driven and the last 3 being fusion gene-driven. On the right panel, we also have normal tissues. And each of these rows represent a neogene transcript. The color is normalized by TPN value, or z-score normalized by TPN value, which basically means relative expression across all samples, with red being higher expression and blue indicating lower expression, and all of it is on a scale. So we can see from here that these neogenes are highly or strongly represented in only acute monocytic leukemia and largely absent in the other subtypes, including other cancers and normal tissues. From here, we can see that using these neogenes, they are possibly be able to be used for diagnostics in AMOL. And more importantly, we repeated this pipeline for the other 6 leukemia subtypes, and we also found that they each have their own unique neogene signature. And this is a heat map combining all of the individual subtypes into one graph. And then on the right-hand side, we can see summary statistics of how many neogenes were initially identified through our pipeline and how many were left over after the filtering process. Now, to see if these in silico discoveries were actual transcripts and not just computational noise or artifacts, we decided to look into the specific region of some of these neogenes and ask the question, do they show markers of active transcription? So here's an example we used. This one is from CML, and this is neogene 152. There's 2 isoforms, so 1 and 2. And it's located on chromosome 3. So first asked, are these transcripts open and accessible? So we looked at ATAC-seq and DNA-seq, and for orientation, the x-axis is showing the genomic region, and the y-axis is just signal intensity. So from here, we can see both ATAC-seq and DNA-seq have strong signal intensity corresponding to the rightmost exon, meaning that these transcripts are open and accessible for transcription factor binding and transcription. We also looked at POLR2A, which is RNA polymerase II, and we also do see strong signal corresponding to the same area, which means transcription is able to occur. We also looked at a couple histomarkers, particularly like ones showing promoter activity, activation, and elongation. So we can see from here it shows sustained transcription. And all these data taken together allows us to see that these transcripts are real, they're not artifacts, and they're actively being transcribed. So the next steps we're going to take is to confirm these neogenes in vitro and in vivo, and then hopefully be able to detect them in our patient samples. Now the natural question is, how do we integrate this into our clinical setting? So this is our conceptual model where our overall clinical challenge is relapse detection and its overall invasive process, invasive and high-cost process in monitoring. Our traditional workflow for detecting leukemia basically occurs when a sick child is brought to their primary care by parents and initial labs are first done. If there's some cause for concern, they'll be referred to hem-onc specialists for potential biopsy, and then later sent for some cytogenetics. They'll need to wait a little bit for diagnosis, and if positive, treatment will start. And then our intervention is this Neogene panel. Well, it kind of enters this model as a more streamlined NGS-based test where it's designed to reduce complexity, minimize invasiveness, and accelerate diagnosis. And the outcomes are early detection, decreased physical procedures, decreased emotional burden on patient and parents, faster treatment initiation, and overall lower cost. And the clinical and translational relevance of this, comparing conventional testing and our Neogene panel, is that conventional testing usually requires flow cytometry, NGS, cytogenetics, PCR, bone marrow, and blood samples. It's highly invasive and often requires sedation and anesthesia. Whereas our Neogene panel is one single NGS panel from one blood stick, it's minimally invasive and does not require sedation. It can also be done much more frequently and associated with overall lower costs. So our conclusion is that we were able to find subtype-specific neogenes in fusion-driven pediatric leukemias, and that these transcripts may serve as novel biomarkers. The clinical significance includes improved early and minimally invasive detection of pediatric leukemia, therapeutic monitoring of tumor progression or resolution. It will help us pinpoint tumor of origin, and in the future, it may even lead to expanding the biospecimen potential, including like the urine, where it'll be completely non-invasive and much more readily accessible, and would be ideal for our pediatric patient population. And that concludes my talk for today. These are my acknowledgements, Dr. Lee's lab, our STAR committee, and thank you. I'm happy to take any questions.
Dr. Cheng, that was incredible, incredible research you guys are doing. I have a master's degree in human genetics. I run a precision medicine program. I work in genomics every day, and I learned more about neogenes during that presentation than I've ever heard before. So kudos to you. I appreciate that. And it's incredibly novel and potentially practice-changing research as well. So we may see our approach to pediatric leukemias completely change from this. So that is phenomenal. Our final presentation will be given by Dr. Maya Hammonds, who is from Ochsner, and her presentation is entitled Clinical and Economic Impact of Single Anesthesia Events in Surgical Management of Early Stage Lung Cancer. And her mentor is Dr. Jordan Dozier, who I saw in the audience here back there. He's one of our CAGLA Scientific Advisory Board members. We grade these abstracts completely anonymously, so we had no idea, but we're very happy to have one of our Scientific Advisory Board members as one of the mentors for this research. So thank you guys. Is Dr. Hammonds here? Yeah, right there, coming up. Okay, great. Thank you. Welcome.
Hi, good morning, everyone. My name is Maya Hammonds. My voice is a little rough. I'm recovering from a cold, so sorry about that. But today I'll be discussing the clinical and economic impacts of single anesthesia events in the surgical treatment of lung cancer on behalf of my team at the Ochsner Medical Center. So currently lung cancer remains the leading cause of cancer-related mortality in the United States, and one of the key issues in lung cancer care is delays in treatment. This has been shown to increase the risk of upstaging and worsen survival. The recommended time to treatment interval based on the STS and ACS guidelines is 6 to 8 weeks. With the traditional workflow, This requires multiple procedures, including a biopsy followed by time for pathology to get back to you, and then a separate operation. This creates multiple anesthetic events and opportunities for delays. With advances in robotic bronchoscopy and robotic-assisted thoracic surgery, we have an opportunity to rethink this pathway. And for those of you who don't know, because obviously I'm on the surgical side of things and not genetics, robotic bronchoscopy lets you upload a patient's CT scan into their programming and allows you to map directly to the nodule and take a biopsy that way. It's a lot more specific and lets you get a lot deeper into the chest cavity than traditional biopsy methods. So for the SAE concept, or single anesthesia event, this combines diagnosis and treatment into one operative session. Patients undergo a robotic bronchoscopy, and rapid on-site evaluation, what we call the ROSE, is used to confirm malignancy intraoperatively. Basically, it's sending frozen pathology down to the lab, and they get back to you within 10 to 20 minutes. So if cancer is confirmed, then patients are immediately transitioned to a robotic surgical resection of that cancer. And the goal of this is to reduce time to treatment interval while maintaining patient safety. So here I'm highlighting the kind of key differences in the workflow. They both start with a CT detection and then referral to pulmonology. But then with the traditional pathway, first they get a bronchoscopy or some other type of sampling for a biopsy. Then you have to wait for pathology, and then you see your pulmonologist again, and then you schedule surgery, and then eventually you get a resection. And that usually takes about 12 or more weeks. With the SAE pathway, it's consolidated into a streamlined process, reducing the timeline to approximately 6 weeks. And this represents a major opportunity for us to improve efficiency in lung cancer care. So the objective of our study was to compare the SAE approach to the traditional pathway in early stage lung cancer. Specifically, we evaluated whether the SAE model reduces the time to treatment interval, maintains safety, and impacts hospital costs and revenue. For a new model like SAE to be sustainable and adopted at scale, it has to be good for patients and sustainable financially for the healthcare system. So this was a single center retrospective cohort study conducted from 2021 to 2024 of patients undergoing robotic bronchoscopy and robotic lung resection, which we divided into the traditional pathway or the single anesthesia event group. We had IRB approval for this, and the data came from an institutional registry. For our inclusion criteria, it was all adult patients with suspected early stage lung cancer, which is defined as tumor stage T2 or less without nodal disease. We did exclude patients that were higher risk, including those with nodal disease, stage greater than T2, poor pulmonary function, difficult airway, prior complex thoracic surgery, and some others listed here. This ensured that we had a relatively comparable operative cohort. So for our outcomes, we were looking primarily at imaging to surgery interval. That was one of our main outcomes. Pulmonology visit to surgery interval, and postoperative complications. Secondary outcomes that we looked at included length of stay and direct costs and net revenue. So for our cohort, we had a total of 62 patients, 42 in the traditional group and 19 in the SAE group. For the baseline demographics, including age, pulmonary function, and smoking history, they were similar between the groups. So for tumors, and this is all on the final pathology, adenocarcinoma was the most common subtype. The SAE cohort did have slightly smaller nodules measuring about 1.5 centimeters at a median compared to 2.1 centimeters in the traditional group. However, all tumors were early stage. So outcomes, for the time to treatment outcome, one of our key findings was that from initial imaging to the surgery, the interval decreased from 84.5 days in the traditional group to 48 days in the SAE group, which was highly significant. Similarly, from pulmonology visit to surgery, the time decreased from 62.5 days in the traditional group to 38 days in the SAE group. Overall, the SAE pathway reduced time to treatment by more than 1 month. So in terms of safety, there were no major complications in either group. That included respiratory failure, myocardial infarction, pulmonary embolism, and unplanned return to operating room. And readmission rates were also similar. There was no 30-day mortality for either group. We did have minor complications in 33% of the traditional patients and 0% in the SAE group. And those complications included an air leak lasting greater than 5 days, atrial fibrillation, pneumonia, and a chyle leak. So this suggests that our streamlined pathway did not compromise patient safety. So for our financial outcomes, we saw that from a financial perspective, direct costs were not significantly different between the groups, but we did have net revenue that was higher in the SAE group, suggesting that SAE is not only clinically effective, but also financially favorable for the hospital. So overall, our findings demonstrate that the SAE approach reduces time to treatment by more than 1 month, which meets the STS-ACS recommended 6 to 8 week treatment window, does not negatively impact safety outcomes, and has favorable financial implications. So we know from previous research that delays of treatment greater than 8 weeks following initial radiologic detection of lung cancer are associated with worse outcomes, which include reduced median survival, increased 30-day mortality, and an increased risk of upstaging. We also did not directly measure this, but believe that this may improve patient experience by reducing delays and reducing care fragmentation, which should reduce patient anxiety and time burden. We did have limitations in our study, primarily that it was a single center retrospective cohort study and it had a small sample size. We also had 2 benign resections in the SAE group. These were tumors that on the rapid on-site evaluation, they had atypia or concerning features, and then they also had radiologic features consistent with malignancy before we scheduled these patients. So that was also a limitation. For future work, definitely needs larger prospective studies to really get this off the ground, and evaluation of long-term impacts on survival. Also, I think it would be important to do assessment of patient-reported outcomes, including their quality of life. So in conclusion, the single anesthesia event pathway significantly shortens time to treatment interval, maintains comparable safety, and improves financial performance. This represents a promising streamlined model for lung cancer care. Thank you for your attention. I'm happy to take any questions. So I'm a first-year surgery intern, and I was not there, unfortunately, when this was all going down in the original data collection. However, I do know that Ochsner primarily serves people that are insured, and I think a larger percentage of our patients have private insurance. So I think that would be less likely to be an issue with our patient population.
I didn't know if y'all, went ahead and proactively authorized for both the initial procedure and the surgery as potential, or kind of what that approach was. That's phenomenal. And just knowing that the patients are getting hit with it, great job. Thank you.
Thank you. Any other questions?
Thank you so much. Absolutely phenomenal work, definitely benefiting patients. And I think we're hearing a theme here with Dr. Delavisio's presentation and this presentation that, you know, we can do really complex things, but it's hard, but it's worth doing, worth coordinating these things. We have a little break. We will meet again at 9:30 in our tracks, track 1 in here, hematology. We're going to do our precision medicine and prevention and early detection in track 2. Track 3 will be neuro-oncology, and track 4 gynecology. So please feel free to go grab some coffee, go to the bathroom, and we'll see you all in a few minutes. Thank you.
I wonder if you could,
Huh?
do we have the email for the guy who has had a baby?
Yeah, what is saying? I need to talk to this person. Do we know who's...
Inquiry behind this curtain.
I talked to them. They said no, it's
They
not
said-
them. They said somebody in light blue jacket. Who is that?
Hey. Thank you. Appreciate it. I forgot my glasses today. I can see nothing. Another prescription. And I can drive. And I was on a Zoom meeting and it slides up. I was like, I realize what the problem is. Yes. I should see Matrona.
All right. Hey. All right, ladies and gentlemen, thank you for joining us this morning on the one and only Heme Block, the official 4 talks. I appreciate you coming and joining us. We will start with Dr. Carter Davis. He's at Ochsner. He's the interim section chief of hematology and cellular therapy at Ochsner MD Anderson Cancer Center. He treats patients with heme malignancies, performs stem cell transplant, and CAR-T. Today he's going to talk to us about navigating treatment options in frontline and relapse refractory diffuse large cell lymphoma. Dr. Davis.
Good morning, everybody. Thank you for being here today. I'm excited to talk to you about the diffuse large B-cell lymphoma space. It has changed a lot in the last several years, and we'll talk about frontline relapsed refractory options in DLBCL, and specifically focusing on bispecific antibody therapies, which is one of the newer classes of therapies that we can use in this space. They have transformed a lot of what we're able to do for patients with relapsed or refractory disease, and hopefully, potentially even in the future, in first line. And so the objectives of this discussion are to understand therapy selection in first line diffuse large B-cell lymphoma, which we'll cover relatively quickly, identify bispecific therapies in diffuse large B-cell lymphoma, recognize the role of bispecific antibodies in relapsed and refractory DLBCL, and finally to select therapy in relapsed refractory DLBCL that includes the use of a bispecific antibody. So in this discussion, we'll talk about both on-label indications as well as NCCN guideline indications which may not yet have an FDA label or may not have passed the scrutiny of an FDA regulatory approval. First-line therapy in diffuse large B-cell lymphoma in many ways has looked very similar over the last quarter century. And you can see if you look at the NCCN guidelines that R-CHOP remains a preferred regimen across the board regardless of stage, although there are now opportunities to select alternate therapies, most notably the polatuzumab R-CHP regimen, which performed very well in a phase 3 clinical trial with superior progression-free survival compared with R-CHOP in patients with an IPI of 2 to 5 in diffuse large B-cell lymphoma. And so although R-CHOP has been the standard of care for 25 years, there have been numerous attempts to replace it. This slide depicts a summary of randomized clinical trials that compared alternate regimens to R-CHOP in diffuse large B-cell lymphoma in the first line. And the red bars indicate the time over which that took place and the failure of those regimens to achieve superiority compared with R-CHOP. So you can see there's a lot of red in this slide, which indicates that there really is not a better regimen until most recently when Pola R-CHP demonstrated a superior PFS compared with R-CHOP. The interesting thing about this is that additional analysis of the patients who really derive the most benefit from the addition of polatuzumab vedotin is largely limited to patients with the activated B-cell type DLBCL, that those patients with GCB subtype, which is the more favorable and more common subtype, don't necessarily do better. And although this is not reflected in the indication for selecting Pola R-CHP, it does provide a biological rationale where we might select Pola R-CHP for specific patients with DLBCL, and R-CHOP is still acceptable and appropriate for many others. So something to consider and something that I personally use in my practice. So this is just a summary of now longer-term follow-up of the phase 3 Polaric study comparing Pola R-CHP to R-CHOP, and with many years of follow-up now, we see a sustained PFS advantage in favor of Pola R-CHP compared with R-CHOP, and that has not really changed even from the first results that were released. What is interesting to note is that there has yet to show a true overall survival advantage of this regimen, which we believe largely reflects the strong ability to salvage patients that do progress with alternate therapies such as CAR T-cell therapy, novel therapies, and that will include bispecific antibody therapies. So thankfully, even if patients do relapse, we're still able to meet their needs just as well for the patients who got the polatuzumab in the first line. Despite these advances, nearly a third of patients may still experience disease relapse. So while many people like to talk to patients about how curable DLBCL is, the fact of the matter is that it's not for everybody. And so CAR T-cell therapy offers really impressive response rates in the second line, but not all patients are eligible or able to reach a CAR T center. It can be very demanding. We know that actually most patients who are CAR T eligible or who should receive CAR T don't end up getting it. Even among patients who do receive CAR T-cell therapy, only approximately 40% experience long-term remission. So although perhaps as many as 70% may develop a complete response to the CAR T-cell therapy, a significant portion of those patients do relapse, and so we need other therapeutics either to augment our first-line response as well as salvage patients who are in need of therapy beyond the first line. Bispecific antibodies represent a class of agents that promote interaction of immune effector T cells against a tumor cell. This is a generic sort of image of how a bispecific antibody might work with an antibody that has an antigen against both a CD20 target on the tumor cell and CD3 of a T cell. This enables the T cell to be activated against the tumor cell, and that has been demonstrated to be effective at tumor killing. This also can lead to release of inflammatory cytokines and cause cytokine release syndrome, a well now recognized entity, as well as immune effector cell associated neurotoxicity syndrome, or ICANS. Thankfully, with more and more experience with bispecific antibodies, there's increasing comfort in utilizing these drugs, not just with inpatient step-up dosing setting, but also developing therapies that can be administered entirely in the outpatient setting, using tools such as tumor debulking in advance of dosing and other prophylactic medications to help reduce the initial increase in cytokines. So in diffuse large B-cell lymphoma, there are 4 bispecific antibodies that either are in development, are recognized in the NCCN guidelines, or have formal regulatory approval by the FDA. Those in alphabetical order are epcoritamab, glofitamab, mosunetuzumab, and odronextamab. And so I have a summary of their indications, both based on regulatory approval and in the NCCN guidelines here. Although some of these are not formally approved by the FDA, the inclusion in the NCCN guidelines enables many patients to access these therapies and for many insurance companies to approve their use in standard practice. And we'll summarize both the FDA and NCCN indications in the data to follow. So first we'll discuss epcoritamab and its initial study as a monotherapy, and we'll focus on monotherapies first. But epcoritamab in the EPCOR NHL-1 study focused on patients with diffuse large B-cell lymphoma or other aggressive lymphoma subtypes such as PMBL, high-grade B-cell lymphoma, and grade 3B follicular lymphoma, who had 2 or prior lines of therapy, including an anti-CD20 agent, and failure ineligibility for auto stem cell transplant. CAR T patients were eligible with a primary endpoint of overall response rate. Treatment included epcoritamab with what is now considered their standard step-up dosing, was given in 28-day cycles indefinitely until disease progression or intolerance. The overall response rate that was observed in this study was 63.1% with a CR rate of 40%. Here are the Kaplan-Meier curves from the EPCOR NHL-1 study, which showed a median time to response of 1.4 months, so really quick acting. When patients often have an aggressive disease, we need therapies that do help them get to a response quickly. And so we see that that response does actually come on relatively soon after starting therapy, with 2.7 months to the median for patients who achieve CR of the time to the CR. So really, by the way that these trials are conducted, that pretty much as soon as the imaging assessment's being completed, we're seeing the responses occur. Median duration of response is 17.3 months for responders, so very durable. And for patients achieving complete response, 79% remain in CR at 12 months. So in this patient population, which was more heavily pretreated, very effective duration of complete response if it's achieved by this monotherapy. At 24 months, 64% remained in complete response as well. So this was really encouraging to be able to see this. This is a therapy that's delivered subcutaneously, so once stepped up, it does not require an especially burdensome toll on the patient to remain on therapy. The median PFS in the overall population is only 4.4 months, and that accounts for the non-responders, and the median overall survival is 18.5 months. So we can see, and the Kaplan-Meier curves demonstrate this well, that for patients with complete response, there's really excellent progression-free survival, but for those who do not respond completely, there's still a lot of unmet need. So those 40% of patients who achieve CR can do quite well. As far as safety and adverse events goes, CRS and ICANS are observed, but thankfully very few severe events. I'll call your attention, to the lower right-hand portion of this screen where the CRS and ICANS are summarized. And so almost half had some degree of CRS, but only 4 of the patients, or 2.5%, had grade 3 or higher CRS, and only 1 grade 3 or higher ICANS was observed, although there was a fatal ICANS event in this study. Glofitamab is another FDA-approved bispecific antibody for monotherapy in relapsed refractory diffuse large B-cell lymphoma. In its trial, it was studied also in a similar patient population, DLBCL or other aggressive non-Hodgkin's lymphomas, PMBL, high-grade B-cell lymphoma, and follicular lymphoma grade 3B. Once again, 2 patients with 2 prior lines of therapy, including anti-CD20 therapy, and failure and eligibility of autotransplant. And once again, CAR T patients are eligible. The primary endpoint of this study was complete response rate. According to the independent review committee in this study, the objective response complete response was seen in 61 patients, or 39% total. In a similar fashion to what we see with epcoritamab, we see that there is a very durable duration of complete response for those patients who achieve it. Although the overall 6-month PFS is only 46%, the 12-month PFS is 37%. So in the similar fashion to what we observed with epcoritamab, glofitamab is very effective for patients when it does work as a monotherapy. One of the big differences is glofitamab is given IV instead of subcutaneously, and was conceptualized with a fixed duration in mind, so 12 total cycles rather than an indefinite therapy. And so there's some consideration sometimes given based on patient factors that may reflect the use of one or the other. Safety and adverse events, we do see CRS and ICANS once again, but also with very few severe adverse events. And CRS is mitigated with Glofit with a pre-treatment with obinutuzumab, which was shown preclinically and to help reduce the rate of CRS. So we see grade 1 CRS in about 47% of patients, grade 2 and 12%, 3% grade 3, and then there was 1% grade 4. No grade 5 events related to drug. So I hate to compare across clinical trials. The purpose of this is just to summarize the data and show that both of these have good overall response, 63% for EPCO, 52% for Glofit, similar CR rates in the studies in which they were done. Median PFS is relatively short, but that includes the non-responders, and the median OS really will depend a lot on whether a patient responds. The good news is these are very feasible therapies, very effective for patients who need them, and can really help people who have been pretreated and have relapsed disease. Where I think things are most exciting is in bispecific antibodies and combination therapy. These are not FDA approved yet. So they do have reflection in the NCCN guidelines. And I think this is really where we will see a lot of utilization now and especially in the future. Epcoritamab has been studied in combination with gemcitabine and oxaliplatin in the EPCOR NHL-2 trial. So this is a summary slide that was from the manuscript in Blood, which demonstrates this combination. This is a phase 1b/2 trial, so there's no comparison arm in this. And patients did get hospitalized during the step-up dosing, as is considered standard. But overall, we see some really impressive response rates. So we can see that actually the overall response rates in all patients was over 80%, with 61% getting a CR. And for patients who only had one prior line of therapy, that overall response rate is 90%, with 74% of patients having a CR. The median duration of CR was almost 2 years in this study. So by combining a bispecific with chemotherapy, we can enhance the response rate and also get a durable response. So for many of those patients treated in the second line who maybe can't get access to CAR T, they can go on to a very feasible regimen which involves minimal inpatient stays and still get a really impressive response. And time will tell if this could be considered a curative therapy or not. Thankfully, the CRS events were primarily low grade, only 1% grade 3, so very manageable toxicity in this study. Glofitamab was similarly combined with chemotherapy in a study that's gained some notoriety in the United States because it did not get a regulatory approval by the FDA, known as STARGLO. And this was a randomized phase 3 study compared to R-GemOx. So patients with 1 or more prior lines of therapy and not eligible for auto stem cell transplant were randomized in a 2-to-1 fashion of glofitamab plus GemOx versus R-GemOx with a primary endpoint of overall survival. And it did meet its primary endpoint, showing superiority to R-GemOx, which of course is not generally considered what we would hope to be doing in the second line of therapy, but it is an important advance. The main reason why it wasn't approved in the United States is that the percentage of patients enrolled from the United States was relatively low. But despite that, this has still made it into NCCN guidelines as a considered therapy, and once again has very manageable toxicity. And so both the overall survival and progression-free survival strongly favor the Glofit GemOx arm with what appears to be very good durability and sort of a plateau in the survival and PFS curves, suggesting that this is a potentially curative therapy. As far as adverse events with the Glofit GemOx, we do see CRS in 44% of patients, but only 2% had grade 3 CRS, so thankfully also very manageable toxicity. And then finally, some newer data, the SUNMO trial, which incorporated mosunetuzumab and polatuzumab vedotin, so using essentially a chemotherapy-free combination, was another early phase study which looked at combination therapy with bispecifics. Mosunetuzumab has FDA approval in follicular lymphoma, but not in DLBCL. But this has also been a really exciting study to show that, one, it's active, and two, it has very manageable toxicity. So patients, this is another phase 3 trial that compared patients receiving mosun and pola to R-GemOx. They were also randomized in about a 2-to-1 fashion. And so what we can see actually is that the progression-free survival strongly favors the mosun pola arm compared with R-GemOx, of a median PFS of 11.5 months compared with 3.8 months, and that the overall response rate was 70% with mosun pola compared with 40% of R-GemOx. The duration of complete response was not reached with mosun pola and was only 9.5 months with R-GemOx, so a much superior efficacy overall. And here are the Kaplan-Meier curves demonstrating this. So the mosun pola is clearly superior in both PFS and trending towards superiority in overall survival. And so it's an appealing option in the second line. And mosun is actually completely an outpatient step-up dosing, and polatuzumab vedotin has a lot of comfort. So this is something that can be very feasibly given to patients. And the CRS rates were very, very low, which is probably the most impressive part of this trial. Only 26% of patients had CRS at all, 21% were grade 1, and only 1 or 0.7% had grade 3. So very, very low rates of CRS with a regimen that can be given basically entirely outpatient. There were more infections in the mosun pola arm compared with R-GemOx, so it may not be for everybody, but it is very feasible. So once again, comparing across clinical trials, which is always a little dangerous, these are different populations, we can see that all 3 bispecific combination options for relapsed refractory DLBCL offer high rates of response. So historically, with our chemotherapy, we would see response rates of less than 50%. We see in every single trial, bispecific combinations give greater than 50% response rates, and CR rates even over 50%. The median progression-free survival is about a year in all these trials, and if we consider the patients who achieve CR, it's even longer. And the median overall survival is almost 2 years, and the CRS rates are very manageable, especially the severe CRS. So in summary, bispecific antibodies represent an important therapeutic option in relapsed refractory DLBCL. Monotherapy, even in later lines, can be effective, and combination therapies as early as the second line show very impressive response rates and CR rates, which may salvage patients who are ineligible for or cannot get to CAR T-cell therapy. And patients who attain CR may achieve durable remissions, perhaps a cure. So ongoing investigations into these combination therapies, perhaps even as early as first line or as bridging to CAR T or alongside other novel therapeutics, may allow us to continue to improve our outcomes with DLBCL and hopefully lead to more benefit for our patients. Thank you.
All right, next is Dr. Harry Cicada. He's from my institution, Our Lady of the Lake Cancer Institute, the Heme Malignancy Program. Dr. Cicada's clinic is dedicated for AML and myeloid malignancies in general. Excuse me. He's part of the ramp-up effort to start allogeneic stem cell transplant at the Lake that we're hoping to start very soon. Today he's going to talk to us about redefining frontline AML therapy, the journey from 7+3 to AZA-VEN. Harry.
Okay. Well, I'm not that tall, so let me put it here. Good morning, my name is Harry Cicada. Thank you for the opportunity to present, and today I will talk to you about redefining the front line for AML. I think it's always very important before we start talking about clinical trial to place everything into perspective, to differentiate the patients we see in the clinical trials to the usual patients we see in the clinic. So just as a beginner, we're going to see the latest year data, and we're going to start with the average age of diagnosis of the AML. So AML, as we know, it's a diagnosis of elderly patients with an average age of diagnosis of 69. And more than 60% of the patients actually are diagnosed after 65 years of age. Not surprisingly, the age of death is actually a little above that, which is 74. And this also translates that even though patients still have access to treatment for AML, as they get older, the overall survival is compromised. And while more than 60% of the patients are diagnosed after 65, more than 75% of the deaths come from the same group age. Now, this is the 5-year-old survival for patients with AML, and this starts in the 1970s, where actually the clinical trials from 7 and 3 started, and this is all the measure points until 2017. So it took us roughly 5 decades to go from 5.5% of overall survival at 5 years to roughly 33%. Now that we got the basics out of the way, let's just start walking down the path of 7 and 3 and all the AML therapies, going through targeted therapies and bone marrow transplant. Everything started with Yats and this group in 1917. And these are 2 different clinical trials. We will talk first about the one in the left first. So this was the first clinical trial that proved that 7 and 3 was efficacious. So this was composed of 8 groups of 8 patients that were not treated before and patients that were relapse refractory. And for here we can see that the response rate for patients that were never treated before was significantly better. So 5 out of the 8 patients that were not treated achieved complete remission, and 2 of the patients that were treated, only 20%, achieved complete remissions if they received therapy before. Now, but where did 7 and 3 come from? What was the preceding chemotherapy regimen before that? That's the right picture that we have. So that's CALGB 7421, and this was the preceding chemo backbone that we had before 7 and 3, and actually was 5 and 2. And the idea before we switching from 5 and 2 to 7 and 3 is that 5 and 2 was not allowing the patients to be enough myelosuppressed. So they needed more chemotherapy to achieve more myelosuppression, and the idea that will improve the complete remission rates for the patients. And it was true. So if we see the curve with the 5 and 2 patients, there was only 33% complete remission rate compared to 56 with 7 and 3. And more than that, after treating more than 1,500 patients within the CALGB group, this was the first time that they recorded a 3-year overall survival to be 15%. They also noticed that the long-term overall survival was better for those patients that achieved complete remission early. That was more than double at 35%. With that information in mind, the first randomized clinical trial happened. And these have 3 comparison arms. They use 45 daunorubicin with 100 cytarabine, 30 of daunorubicin, and adriamycin 30. And kind of like what we use it today, patients that responded moved to maintenance therapy, but the maintenance therapy back in the 70s was significantly different, and they were followed along that. Now, what was the information available at the time of the creation of this randomized trial? So this table summarizes the highest complete remission rates and single institution data in the 70s. So we can see from the Yates, at this point they had 2 more patients with a complete remission of 63%. Then down to daunorubicin with food and the group that had a slightly higher complete remission rate with slightly higher dose of daunorubicin, and Reese et al. That had a whopping 85% complete remission with a little bit of more intensification with thioguanine as part of their backbone of chemotherapy. So how did this change translate into response rate? It's interesting that already in the 1970s, we had 85% remission rate. But as you can see, this was not something that everybody could have the benefit to achieve. It was only for younger patients. And as the age progressively increased, the complete remission progressively decreased. So it went from 85, 76, 65, 36, and as low as 21, only if you were more than 70 years of age. How can we explain that? Well, we just need to move to the next line, and it's the death during the induction rate. Patients that received the same amount of chemotherapy as they were aging, they were dying more from the chemotherapy, which precluded them to achieve complete remission. And here, already 50 years ago, we knew that the toxicity could compromise the responses that we have from our patients. And as a test of tolerability, we can just see the next age group, which is 7 and 3 with a smaller dose of daunorubicin, which is 30. This time, I would like you to pay attention to the 60 to 69 group and the 70 group. And it's paradoxical that actually with less chemotherapy, we achieve higher rates of complete remission here. And it was 36 compared to 49, and more than double, 21 compared to 43 in the older age group. And this is just a test that we knew already from the 70s that more chemotherapy could compromise the response rate. Now, let's talk about a little more of the complications, and this is comparing the 45 dose in a set of 60 years of age, more and below 60 years of age. And you could see already that patients that were above 60 were twice more than likely to get infections, significantly more likely to get hemorrhages, 3 times more likely to get liver disease, more than twice likely to get renal disease, and so forth. So older patients with the same regimen had significantly more complications, and this was compromising the rate of response for these patients. You could also wonder, why didn't we talk about adriamycin? This was the third arm in this group. And it's actually because although adriamycin achieved a significant good amount of complete remissions, that was compromised with toxicity. There was a big group that had enterocolitis, necrotizing enterocolitis, and patients unfortunately died from that complication. So what did we learn from these clinical trials? As you age, you're less likely to achieve complete remission, you're more likely to get complications, and you're more likely to die during the induction. Now, let's move to 2000s. So now in the 2000s, we're going to start with venetoclax as single agent. And this was a very important clinical trial, a phase 2 single-arm clinical trial that took 32 patients for venetoclax. It was mainly comprised of patients that were relapse refractory, so 30 out of the 32 patients were relapse refractory, and only 2 patients were newly diagnosed. In this trial, the dose of venetoclax was different to what we use currently. The dose here was 800 milligrams on every day. And for those patients that did not respond, were allowed to increase to 1,200. And for those patients that did respond, where they were losing their response, they were also allowed to go to 1,200 milligrams of venetoclax. We could see how many lines of therapy. There was heavily pretreated patient with 41% of the patients at least having 3 lines or more, which could either be 7-3, hypomethylating, and even transplants. And on the right, we can see the cytogenetic footprint of the patients that were in this trial. IDH was a little overexpressed compared to the usual distribution in AML, but you could see down that there were still some patients with complex cytogenetics. So what was the response in this clinical trial? We made two tables here. One is the overall response rate, and the other one next to it is the IDH2 mutant and IDH in general patients. Because it's important to know that majority of the single agent responses came from the IDH2 mutant patients. Actually, the only 2 patients that achieved complete remission were IDH2 mutant, and 2 out of the 4 that achieved CRI were IDH2 mutant as well. So the overall response rate for IDH2 mutant were 50% compared to a general population of all comers of 38%. And if you're not IDH2 mutant, you were more likely to get a stable disease rather than have a complete remission with single agent. To further characterize the responders, these are the complete remissions on the top and the stable disease on the bottom. And you could see that the average exposure to venetoclax was somewhere between 3 or 8 months in actually both of the groups. But the main difference is that the responders usually have more abnormal cytogenetics on top of the IDH2 mutation. And stable disease were more complex karyotypes, 72q deletions. At the end of this clinical trial, there was already preclinical data suggesting there was going to be synergy with azacitidine and venetoclax. So the first patients were starting to enroll with a phase 1b trial to prove the concept of AZA and ven. Once that information was available, the confirmatory phase 3 trial, VIALE-A, came to be, which randomized mainly patients that were above 75 years of age with ECOG performance status between 0 and 2, or younger patients that could have ECOG performance status up to 3. And what we're going to do now is we're going to go from the oldest patients to middle age to the younger patients, and we're going to analyze the data in every of those clinical trials. So this is the latest update for the VIALE-A trial, and after 40 months of follow-up, you could see that there was a significant difference for all comers for patients that have venetoclax combined with azacitidine. To look a little bit more down the differentiation, the median overall survival in the venetoclax group was 14.7 for all comers compared to 9.6 months. At 2 years, the overall survival rate was 37 compared to 16, so more than double. And actually, the CR/CR rate actually also more than double, 66.8 compared to 29. But let's go back to the IDH2 mutant. So what happened in the IDH2 mutant patient? How much of extra effect did the combination have? And actually, if we take both IDH1 and 2, the response was more than triple in all comers. And if we separated, IDH1 actually had more than 5 times better response when there was a combination of azacitidine and venetoclax. And while the numeric number was larger in the IDH2, it was because IDH2 itself has a better prognosis and a higher response rate with any treatment. And it was just a little bit more than double the response rate with combination of azacitidine and venetoclax. Moving down the age group, now we go for CPX-351. And just as a little refresher, CPX at the time came from a randomized phase 3 clinical trial that compares 7 and 3 versus CPX in patients that were between 60 and 79 years of age, so 15 years younger, that were high-risk AML and that had the history of either MDS or myeloid-related chemotherapy before they were randomized to this trial. And CPX proved to be better than 7 and 3 in this group. Now, this is real-world data that preceded the randomized trials we're going to see later, compared to azacitidine and venetoclax. And already in real-world data, before we were able to create these randomized trials, we saw that there was a comparable results. So the 30 and 60-day mortality were the same. The overall survival was not significantly different, but we saw that we were able to achieve the same results with less infections, less fetal neutropenia, and significantly less hospital stay. Going down the line, let's go to younger patients, now less than 60 years of age. And before we see the clinical trial, I just want to explain a little bit more about the prompt of this picture. It was interesting that most of the tables, before I came to this, I created artificial intelligence to create the tables itself. And the only prompt I said for this picture is, create a young patient that has the choice to walk 2 paths. One will be HMA and ven, and one will be intensive chemotherapy. I didn't say anything else. And it was the artificial intelligence itself that decided that the cloudy, rainy path was going to be intensive chemotherapy, and the HMA and ven was going to be the sunny path for that patient. Interesting. Now, let's see if that's true. So this data comes from Asia. And this was one of the first randomized clinical trials that compared intensive chemotherapy versus HMA and ven. And this time it was not azacitidine, it was decitabine. The randomization was 1-to-1, and you could either be in the decitabine arm, which followed the standard usage. You give 20 per milligram square, the usual use of venetoclax, and you achieve partial remission. You were allowed to reinduce with the same regimen. Same in the intensive chemotherapy arm was idarubicin with cytarabine. The difference here in this Asian clinical trial is that regardless if you're decitabine venetoclax or 7 and 3, both groups were consolidated with cytarabine. And that's different how we practice here. So important data to review, but it's not exactly how we do it here. Both groups were allowed to move to allo transplant depending on the risk, and they were treated until progression, toxicity, or withdrawal. Now let's see the results. Here, in even younger patients, we saw that the cytarabine and venetoclax had higher response rate, composite response rate, higher CRs, higher CRIs, deeper MRD negativity rate, and an overall response rate that was comparable. If we look a little bit deeper, in the subgroup analysis, which is, of course, only hypothesis generator, but you could see here, even within the young group, there was a division at 40 years of age. So after 40 years of age, already there was a statistical significance favoring the decitabine venetoclax over intensive chemotherapy. And probably to the investigators' surprise, one of the most treatable AMLs, which is core binding factor, only had a 44% complete remission rate compared to 88%, and this was actually favoring intensive chemotherapy. We move forward then down the line to the box. And I included all these mutations in the box. Some of them were statistical significant, some of them were not. But you could see as a whole, there was a numerical trend to favor venetoclax and decitabine as a group compared to intensive chemotherapy. And with that information, let's review what were the last ASH updates in 2025. So this is the Paradigm trial. The Paradigm trial took all this information that we reviewed before and created a randomized phase 2 trial that had a 1-to-1 randomization between azacitidine and venetoclax and 7+3 or CPX. That's the intensive chemotherapy arm. Like we saw before, core binding factor was not allowed, PML-RARA was not allowed, FLT3 and NPM1 mutated patients were only allowed if they were more than 60 years of age. BCR-ABL and mixed phenotypes were not allowed. But other than that, any 18-year-old or more that was eligible for intensive chemotherapy and had an untreatable AML was allowed to go into the trial. Both of the arms followed the usual way that we manage this, which is for day 14 bone marrow, partial remission can get a reinduction, response can go to either consolidation or transplant, and the same usual for azacitidine and venetoclax. Now, let's review here the baseline characteristics. And if you remember, the SEER data showed that the average age of diagnosis was 65, so this group resembles a lot the patient that we're gonna see in our clinic compared to usual, the decitabine that was younger patients. There was a couple of things that were interesting here, that there was a numerical difference between the favorable and the adverse groups in intensive chemotherapy in AZA and VEN. There was slightly more favorable group in the patients in the favorable group with azacitidine and venetoclax, which was comprised of IDH and NPM1 mutated patients. And as we know, those are mutations that are very sensitive to venetoclax. And roughly 50% of patients more of TP53 mutation in the intensive chemotherapy arm, which is historically we know that is chemo-resistant mutations. With that in mind, what was the healthcare utilization? So patients that were in the azacitidine venetoclax arm were less likely to stay in the hospital, actually less than half. Within the 6 months was 41 days compared to 58, and 0 patients were admitted into the ICU with the AZA and VEN compared to 10%. What was the response rate? So we had roughly a composite response rate in the AZA-VEN arm of 81% and 55% in the intensive chemotherapy. But more importantly here is that roughly 3 times more patients were refractory to this disease if they received intensive chemotherapy compared to AZA and VEN. And this is the summary of the results. So better composite remission rate, non-difference in the 30-day mortality statistically speaking. There was a significant statistical difference between EFS, 15 versus 6. There's no statistical significant difference in overall survival. And there were more than double of the patients that were either IDH2 or NPM1 mutated in the HMA-VEN compared to the intensive chemotherapy. And there were more TP53 in the intensive chemotherapy arm, and more patients moved to transplanted AZA and VEN arm. What are my observations from this clinical trial? To a certain extent, it feels we compare apples to oranges when we're talking about intensive chemotherapy and AZA and VEN because we're using event-free survival as a measurement of success. Keep in mind that when you do intensive chemotherapy, it only takes 1 cycle, maximal 2 cycles, to declare that the patient was refractory to the disease. But it could take up to 4 cycles of azacitidine to go to the same endpoint. So even those patients that were refractory took 4 months on average to say they were refractory. So the EFS was longer because of that. And there was no overall survival benefit, at least in the last update. But even after all this analysis, I asked myself the question, do we really need azacitidine and venetoclax to be superior to intensive chemotherapy, or being non-inferior is enough to be the new standard of care? Because this could potentially represent how we start transitioning patients over 60 from the hospital stay to get a complete treatment at home with their loved ones. And this is my closing statement. A chain is as strong as the weakest link, and this is the importance of comprehensive approach. Sometimes we think that treating AML is just choosing the right induction chemotherapy, but actually it's much more than that. It is access to medicine for our patients, it's financial toxicity, chemotherapy toxicity, the patient's age. There are so many factors to come to that. And it really takes a big team to get these results done. So that's why I urge all of us here in this room to keep working as a team and keep moving the needle for our patients. And that's it for me. Thank you.
Well, Dr. Davis started from the 90s with R-CHOP, and then Dr. Cicada went back to the 70s, I see, with AML. Let's see, Dr. Singham, where are you going to go? You have room. You know, myeloma was discovered in the mid-1800s, I would say. Well, it's a pleasure to welcome you in New Orleans. Dr. Shashank Singham, he's assistant professor in the Division of Hematology Oncology in the LSU Health System in Shreveport. He's currently the director of the blood and bone marrow transplant cellular therapy at Ochsner LSU Cancer Center. He is part of the effort to expand cellular therapy in the state and make it more available to our patients in Louisiana. It's a pleasure.
Next presentation.
They don't have it over there, so it's going to be.
All right. Thank you, Dr. Saba. Thank you, Dr. Finn, for inviting me to present. This is really an honor, but not so much for putting me after two phenomenal speakers. My slides are going to feel like a toddler with a sketchbook. So today I'm talking about multiple myeloma, and is it a curable disease? Just talking about cure is an accomplishment with multiple myeloma. When we talk about cure, we try to see our examples that have been set in some of the diseases. Hodgkin's, where 90% of the patients are cured. Testicular cancer, where majority of patients are cured. And so on and so forth, like CML, now we're seeing a trend to cure. So all of these diseases have set a precedent, and we are unable to do that or replicate that with multiple myeloma. So those are the things we'll kind of talk about why the biology of multiple myeloma is a little different, but also the great advances we've seen in the last decade, which gives us hope that we are very close. And then we'll take questions. So let's meet our darling plasma cells. So these plasma cells are basically mature lymphocytes which make antibodies to protect against various infections, bacterial, viral, all kinds of stuff. These primarily reside in the bone marrow and undergo constant changes to fight off different infections, bacteria, virus, and all kinds of stuff. And that is a price we pay for an active and effective immune system. So how these change to make these antibodies, and they have constant breaks in their DNA, and they rearrange. However, sometimes there are these DNA breaks and they go attach somewhere else, and that's what causes a kind of a driver mutation for these plasma cells, and these really lead to aberrant chromosomal translations. However, we know that these are just initiating events, and they may or may not progress to something like a disease. And what leads to that progression of events is usually secondary mutations involving TP53 or other mutations which add to that initial IGH translocation. And if there is a secondary mutation or if there is a clinical manifestation of this disease, that's how we define multiple myeloma. So we have these genetic and molecular changes causing that. It replaces the bone marrow, causing anemia and other symptoms, causes bone destruction, and also secretes all these non-specific clonal protein which clogs the kidneys. The median age of diagnosis is about 69 years, which is, as we talked about, large cell leukemia, all of these hematological malignancies are advanced age, African American race, environmental and genetic factors. And these are established criteria for multiple myeloma, mostly to deal with the CRAB criteria we just talked about, with organ damage, but also some of these numbers we deal with. Why is this important to us and why are we talking about it? So if you look at this match, these are age-adjusted incidence rates per 100,000. And this whole southern belt, starting North Carolina all the way to eastern Texas, we have a large myeloma population. It is very concentrated in this area, and it is very important for us to effectively deal with this cancer and also be in the forefront of new therapies for multiple myeloma. I looked at the tumor registry data from Louisiana, but we are doing very well compared to the national trend marks. However, we need to excel. So this is a traditional teaching for the natural history of multiple myeloma, is that it's an incurable disease but fairly treatable. We treat it with induction treatment, then we kind of get into remission. We use the stem cell transplant for consolidation in patients who are eligible. Patients relapse and get some therapy, kind of relapse again, and at the end are untreatable. This is a slide I had made for the during a patient education session. So how does cancer, and we talked about this mutation, lead to gain of function, and they arise as weeds in the grass. They have damage to cell apoptosis mechanisms, and there's evasion of immune surveillance, which happens a lot with multiple myeloma. The chemotherapy technically targets all these tumor cells either by starving them or killing them, but causing DNA damage. These is kind of frontline approach for most of the hematological malignancies. However, we seem to have resistance mechanisms. Ideal targeted treatments, which just take out the weeds, or target antigen that is not expressed on normal tissue, has good affinity, but also is very effective. And these are the immunotherapy targets we have in multiple myeloma. A little busy slide, but BCMA, CD138, CD38, CD19, which is often under-recognized, GPRC5D. So we do have multiple targets with multiple myeloma. However, we know that the myeloma stem cells are quite quiescent. You target these antigens, there's selection pressure. They evade immune system very effectively. They are hiding in the bone marrow micro niche, and they're kind of protected. So it's always been hard to treat or cure multiple myeloma. But saying that, right now, upfront therapy, we are in a golden era for multiple myeloma, I feel. And so we have multiple options to treat upfront multiple myeloma. Most of them have to deal with an anti-CD38 antibody with an IMiD and then a proteasome inhibitor plus a steroid. Hopefully we do that for a short duration. DARA-VRD is a VRD either in transplant eligible or DARA-KRD, one of those proteasome anti-CD38 antibody combinations. And we are seeing these data that there's long-term PFS data now often, and there's data modeling showing that most of these patients don't relapse after 6 or 7 years. So that is indeed great. But what happens after their relapse? I know even after all those years, we are seeing those relapses. And what happens traditionally with these triple class refractory patients, we see a very short PFS. The PFS, again, progression-free survival, and also a short overall survival. Here, I'd like to this is pooled data from multiple institutions. You see these drop-off. After every month or every few months, there's patients who are progressing, patients who are PASIN, and there's no plateau like you see in other cancers. Like, if you look at, I should have put something in comparison, but if you see Hodgkin's lymphoma, there is a clear plateau of responses, but we don't see this with multiple myeloma. And with that being said, this is pre-data, old data from before we have all these new agents. We had, after daratumumab in 2015, we had a little bit of void. Then we had belantamab, which was initially marketed in 2020, and isatuximab, also targeting anti-CD38. And then we had Abecma, idacaptogene viclucil, ciltacabtagene autoleucel, cilta-cel. Those are the two BCMA CAR T therapies. We had anti-BCMA antibody, bispecific antibodies, teclistamab, elranatamab, and linvoseltamab, talquetamab, which is anti-GPRC5D bispecific antibody, and belantamab is back in market, which is a anti-BCMA antibody drug conjugate. And there's selinexor also, which has been approved. So we have multiple options for treatment. Not going to bore you, but again, I just want to, we had a great lecture with Dr. Dall'Avisio about CAR T cells, but I just want to, before we talk about a little bit about some of the CAR T data, I want to kind of explain what CAR T cells are. So what CAR T cells are, you collect patient's T cell, they are modified with viral DNA insertion. Then there's expression of CAR on these T cells. These are multiplied in vitro with cytokines. They're primed, given into patient's body. Once they're in a patient's body, they do recognize the tumor cell. They attach to the antigen, and also there is in vivo proliferation of these cells, which makes it very effective, which makes it a living drug, and maybe it doesn't give the cancer a chance to hide and evade immune system. So this is the first time we have seen a plateau of responses with multiple myeloma therapy after relapse. Back in the day, we did see some with allogeneic stem cell transplant, however, quite morbid. We had like a 10% of patients who kind of had that plateau. But since then, I think this is the first plateau I'm seeing in relapse refractory multiple myeloma. This was CARTITUDE-1, which looked at ciltacabtagene autoleucel in patients with relapse refractory multiple myeloma after multiple lines of therapy. And this is long-term data, and now you're seeing a median overall survival of 60.7 months. And again, these are patients who have received multiple lines of therapy. So I'll try to kind of explain the kind of analogy about, so if you have an athlete running a marathon, over the years or over hours, and then at the end you ask him to sprint, he's going to be tired. That's how we explain T cell exhaustion, right? These T cells are constantly working; they're being utilized in these. You're having a anti-CD38 antibody, you're having all these therapies, which and say if you use a bispecific antibody before a CAR T, they are kind of exhausted. And if you try to collect these CAR T cells and look for them, there are exhaustion markers that are expressed on these. So if the thought was if you were to bring these CAR T therapies up front, what would happen? We have two landmark trials like KarMMa-3, CARTITUDE-4. We'll talk a little bit about CARTITUDE-4. So CARTITUDE-4 was cilta-cel in patients who had only 1 to 3 prior lines of therapy. You would give them standard of care, which was Pom-Vel-K-Dex, DPD, or Dara, pomalidomide, dexamethasone, which are two therapies which are used, or you'd give them cilta-cel with some bridging. They looked at PFS. They also looked at CR rates, objective responses. So again, the PFS data, this is published data. So at median follow-up of 15.9 months, the cilta-cel PFS was not reached. Standard of care was 11 months. Again, I would try to acknowledge that these are clinical trial results, right? This is not obviously generalizable to everybody because patients have to follow a set criteria. They should not have rapidly progressing disease. Most of the patients with rapidly progressing disease may not see these therapies or may not be eligible for the trial because they kind of don't live that screening period if don't treated. So despite these limitations, I think this is definitely a randomized trial. This is we have seen this in clinic that this works even in patients who are not on a clinical trial, that this works phenomenally well. And also, again, I would like to try to impress those plateau of responses you see. With standard of care, you see those drop-offs, but with the cilta-cel group, you're seeing a plateau of responses. So I'm definitely looking for overall survival data on this, but again, very, very promising. We think that's standard of care, but we got quite a competitor, which is bispecific antibodies. Bispecific antibodies, again, as Dr. Carter Davis talked about, was they attached to CD3 on the T cell and antigen on the tumor cell. We do have two approved therapies or four therapies which target two antigens, three of them with BCMA, teclistamab, elranatamab, and linvoseltamab, which are now approved, and then talquetamab, which is anti-GPRC5D. So this ASH, there was data from MajesTEC-3, and now was fast-tracked to was approval with FDA, which basically was teclistamab, which is anti-BCMA bispecific antibody with daratumumab, and versus compared to DPD or DVD, which was standard of care for patients who had 1 to 3 prior lines of therapy, so kind of early relapse for bispecific antibodies. The approvals that we had for bispecific antibodies prior to this was after four lines of therapy, or at 4th line of therapy. And the primary endpoint was progression-free survival. And again, very impressive results. If you look at this, at 36-month PFS, or 36 months, we had a 83.4% of patients who were in progression-free, compared to 29.7%, with a clearly a hazard ratio of 0.17. Again, you're seeing a plateau. So this is very impressive. This warms my heart every time I look at this graph, and and I show my patients this graph. Again, we have to acknowledge that these, again, may or may not reflect every patient you see in the clinic, because you see patients who are not eligible for these trials. And again, similar with our overall survival, we've seen these great results. Okay, so now it's good to have a debate, especially this, what to do after first relapse, right? So again, I have a bias, but overall, I think it is very important for me as myeloma. I consider myself a myeloma physician more than a cell therapy physician. So I kind of try to parse out a little differences between these two. So CAR-T, I think the advantages are really, it's a one-time therapy, and also it is becoming safer, as we kind of already, speakers have talked about this. I put on a little disclaimer to that is patients who get CAR-T still end up having some of the toxicities that may need to be managed, especially cytopenias, especially infections. So IVIG is a good tool, to have in your toolkit. at least understanding these are the things that happen, and a good communication from a cell therapy physician to the oncologist is really how to manage these side effects is going to be really important. That piece of is passing on the baton, during a relay. So it is very, very, very important. The second is neurotoxicities from BCMA CAR Ts. Also, you're seeing some signal of GPRC5D CAR Ts. Is important to acknowledge. However, we are getting better at treating these, especially even with patients. We know that taking them at earlier lines, taking them with a good bridging therapy, treating that T cell expansion with some steroids, monitoring that response. All of those are strategies that are implemented, and also we have some potentially safer CAR Ts on the horizon for approval. So all of those things, I think CAR T is really becoming safer. Cytopenias are really difficult to tackle if they happen in our patients. That's one thing I consult patients. So we've talked about different strategies after. They don't, obviously do a bone marrow for making sure they're not in dysplasia. Also stem cell boost, GCSF, TPO mimetics, all kinds of stuff we could throw at that. But it is definitely concerning something. I don't think is always attributable to the CAR T, but what we do with the lymphodepletion with fludarabine. However, there are to every puzzle there is an answer, so which is good. There are newer in vivo CAR Ts which do not require lymphodepletion that are also in clinical trials. It is great news. For bispecific antibodies, I think again we've seen great responses. The only downside to that is a continuous. It really needs to be trials on time-limited therapy. We are seeing some that are going to be again in the in clinical trials with time-limited therapies. Also very important to acknowledge infectious complications with bispecific antibodies, especially the BCMA bispecific antibodies. IVIG patients. Really need that. Always consider it's a doublet, not a single agent, or not a doublet as a triplet, because IVIG is definitely part of that care plan. So it is important to acknowledge that. And what to do? There is how to approach this, right? A CAR T versus a bispecific antibody first. You do CAR T first, and then bispecific antibodies, and then CAR T first, CAR T next. There's no right answer, wrong answer to this. However, I feel that just with that analogy that an exhausted T cell after a lot of bispecific, so the patient on bispecific antibodies relapses, it's going to be the CAR T. I think theoretically, and we've seen some of these later line therapy, later line studies, is that it may not be as effective. Because the T cells are quite exhausted, for autologous CAR T at least. I think if you do a CAR T, patients relapse, say, a few years later, then I think it's good to re-challenge them with another bispecific antibody with the same or different target. So I think that strategy makes more sense to me. Again, it is very, very not every size fits all. So it's important if a patient have a rapidly progressing disease, you have no option but to put them on a bispecific, which is because it's off the shelf. You can get it to the patient as quickly as possible. So it is really that closed door discussion between you and the patient, which is the right strategy for them. So again, with that, a lot of words just to say that we don't have a cure, but we are very close to it. It's definitely a challenging disease to cure, but every day we are getting a step closer. Thank you.
All right, it's with a great pleasure that I introduce Dr. Adrian Wiesner. Dr. Wiesner is a tenured senior investigator and chief of lymphoid malignancy at the National Heart, Lung, and Blood Institute, National Institutes of Health, NIH. Dr. Wiesner scored multiple discoveries in CLL and mantle cell lymphoma that shaped and continue to reshape not only the way we treat CLL and these diseases, but also our deep understanding for this disease biology. So with Dr. Wiesner, you'll hear the truth, the full, unbiased truth, no matter what. So I would say, let your guards down and enjoy his story of targeted CLL therapy. Adrian, I look forward to learn not only from your slide, but also from your wisdom. Thank you very much for coming here. I keep forgetting doing this. Make sure that these are the right one here. That's it, right?
Perfect, thank you. Thank you for the kind introduction and invitation to be here with you today. It's a great pleasure and an honor to tell you about some of the studies we've done in CLL, and I try to weave that into the overall evidence that's emerging from different groups and trials. Here are my disclosures. So we have primarily industry support for ongoing clinical trials and some of the correlative analyses. I would, as a brief outline, I want to take you from the key pathogenic mechanisms to how we can target these two problems that arise with resistance to targeted therapy. Briefly touch on continuous single agent versus time-limited combinations, give you some thoughts on special populations and outlook on goals for 2026 and beyond. So the key pathogenic pathways in CLL are now really well defined, and the first one has already been alluded to in the 1960s, is this resistance to apoptosis. The molecular basis is overexpression of BCL2 due to different genetic abnormalities, primarily the deletion 13q, the deletion of the long arm of 13, which deletes these MERS 15 and 16 that typically would downregulate BCL2 expression. So CLL cells have this high expression of BCL2, an anti-apoptotic phenotype. Oops, sorry. The other element is the driver of CLL. And I would really like to go as far and say the oncogenic driver of CLL is B-cell receptor signaling. Even though we don't have the classic mutations that were described in diffuse large B-cell lymphoma, which are actually in the downstream signaling portion, in CLL we have unique B-cell receptor structures that support the self-self association and a continuous B-cell receptor signal. And for one of these subtypes, it's actually really one specific mutation in the lambda light chain gene that leads to this self-self association. So there's a tumor mutation that is driving the tumor in this subtype of CLL. But it's a general theme. And so this then leads us to the two really most successful classes of drugs we have at this point to treat CLL. That's inhibition of B-cell receptor signaling with the most rewarding class of agents targeting Bruton's tyrosine kinase, and venetoclax that targets this anti-apoptotic phenotype by inhibiting BCL2 function. So I'll spend some more time on the B-cell receptor signaling part. So again, it's the oncogenic driver. We have several targets within this pathway, and all of them have been tested clinically. So inhibition of SYK kinase inhibits B-cell receptor signaling, PI3K delta downstream, and then the BTK inhibitors, which have really proven to be the most effective, but also the best tolerated agents. With the first class of BTK inhibitors led by ibrutinib as first in class. We have a group of agents that covalently inhibit BTK. They do this, all three of them listed there, ibrutinib, acalabrutinib, zanubrutinib, do this through covalent binding, so an irreversible bond to a cysteine residue within the protein. So that protein is gone, is useless, but it can be resynthesized. That's the reversibility, right? When we stop a BTK inhibitor, after a few days, there is enough BTK being resynthesized by the cells, and that restores the signal. So in multiple trials, we've seen that the BTK inhibitors, as single agents or in combinations with an anti-CD20 antibody, beat all types of chemotherapy, FCR, BR, chlorambucil. In all these trials, shown here for FCR versus ibrutinib rituximab in the ECOG trial, you see the really tremendous benefit of chemotherapy-free treatment, first-line treatment of patients with dramatic differences in progression-free survival. And let me just point out that this is now also seen for the IGHV mutated subgroup, which initially was thought to not have a benefit from ibrutinib rituximab over FCR, but with longer-term analysis, also this group is better served by the BTK inhibitor than with chemotherapy. This is the ELEVATE-TN study that used acalabrutinib as single agent or in combination with obinutuzumab. The study is not powered and not designed to test whether the antibody adds to the single agent, but clearly you see that both acalabrutinib-based regimens beat, in this case, chlorambucil with obinutuzumab. And updated data, of course, supports this continued benefit that also starts approaching maybe a benefit in overall survival. So what's the role of these newer or kind of coming after the first-in-class? Acalabrutinib and zanubrutinib have been compared in randomized trials in relapse refractory CLL. In both of these trials, the shared observation is that we have less cardiac side effects with acalabrutinib and zanubrutinib than with ibrutinib. That's primarily atrial fibrillation, hypertension, and possibly also some sudden death on ibrutinib that seems to be somewhat less common with acalabrutinib or zanubrutinib, but that is never common enough to actually reach statistical significance. For the zanubrutinib versus ibrutinib trial, there was also a suggestion that there is a better progression-free survival with zanubrutinib, at least in that study it was. It was not for acalabrutinib versus ibrutinib. They had virtually the identical progression-free survival. So whether really one of these is more effective than the other, I think can still be debated, is being debated. But they have advantages from a tolerability profile. So when we started with ibrutinib in 2012 at a clinical trial at the NIH, and I think virtually everybody I talked to in the lymphoma field said, well, with single agent, you won't get very far. You will have resistance that you have to immediately go to combinations. Well, we stuck with single agent, and yes, we do see resistance. Our longest patient has had his 14th year on ibrutinib this January, and he had about 6 prior regimens, so definitely it can work long term. But the resistance we see is either early, and that is typically unrelated lymphomas, so another B-cell malignancy, or it is transformation of the CLL into aggressive lymphomas or Richter transformation. These types of resistance typically happen early. The patients typically respond from their CLL component, but the Richter's is either less sensitive or not sensitive at all, and that's what emerges within the first 6 to 12 months. At later times, we see typical progression. We see a progression that's typical CLL type. And this CLL now carries mutations in BTK or PLC gamma 2. And it's immediately clear why these mutations confer resistance. The mutation in BTK is typically affecting that cysteine residue, so the covalent inhibitor cannot attach anymore. These drugs have a short half-life, so the effect is cleared rapidly, and you get either no inhibition or just a poor inhibition of BTK function. Or we have mutations immediately downstream of PLC gamma 2. This is from multiple studies. We find these mutations in up to 85% of patients. So this is the dominant genetic event in resistance to ibrutinib. Okay, so the prediction in some ways is correct. Yes, with single agent you may see resistance. But this resistance is not something else. It brings back BTK function, right? These mutations, what they do is allow BTK to be functional again. So it actually validates this target. It tells us that BTK really matters so much to the cells that the resistance focuses on bringing that signal back. So we spend an inordinate amount of time in trying to really understand everything about these resistance mutations, and that's now going soon into its 10th year or so. But let me show you some highlights from that. First, one comment often is that, well, the mutations are only affecting 10% of the cells in circulation. So how does that cause resistance if only a small part of the tumor actually carries the mutation? Well, yes, that can be true, but what I'm showing you here is the analysis of a patient that we studied by single-cell mutation sequencing. So we know for sure that all that I'm showing you here is happening in separate cells. So this clonal population we talk about is not an identical copy of each other, right? So in a first branch, this patient or this CLL evolved with having two different SF3B1 mutations. So we have two distinct populations. Within those populations, one set develops a PLC gamma mutation at the bottom of those lines, whereas in the other subpopulation, we see emergence of, 5 different BTK mutations. And because we did single-cell sequencing, we know every mutation is in a separate cell, in a separate subgroup of the tumor. So we deal with the complexity, right? The Greek mythology would be Medusa's head with all the snakes. So because we now know that this is in different subpopulations, we add up the total mutations. And when you then look at it, is many of these resistant patients have virtually all their cells carry a mutation, either in BTK or in PLC gamma or a combination of it. But yes, there are some patients where the explanation doesn't quite hold. At the bottom of this panel, we actually have 2 patients. Despite looking at everything, sequencing back and forth, we don't find BTK and PLC gamma mutations. So in a rare subset, yes, there may be other genetic mechanisms. But another explanation for relatively low tumor mutations in the circulating population is that the cells are not the same in all compartments. This patient, PD15 there, with a relatively low 5% frequency of the C481S mutation in the blood, 75% of his cells in the lymph node carry the mutation, and over 50% in the bone marrow. So yes, we're used to studying the blood in leukemia, but we have to keep in mind that it's really in the lymph node that things happen. That's where the cells proliferate. That's where mutations occur. So these clones don't necessarily equilibrate, and the blood may not give us the complete answer. So again, we're at the same point that we have these BTK mutations. They tell us that the cells really need BTK signaling so we can retarget BTK. And this is very nicely proven here with pirtobrutinib as a non-covalent inhibitor. So that drug does not care about the cysteine. It can be there as cysteine, it can be mutated, it doesn't matter. And you see this really impressive waterfall plot that pirtobrutinib in this setting is working in patients who discontinue the BTK inhibitor for toxicity, but it also works for patients who progressed on the BTK inhibitor, that's the darker green bars. It works for patients who had previously also received venetoclax, that's the red stars, and it also works in patients who have or don't have the cysteine mutation. So even if a patient doesn't have that cysteine mutation, retargeting BTK brings a response. I think that again validates how valuable this signal is to the cells. Okay, but we know that tumors evolve, so the evolution continues. And this is an example of a patient who had a C481S mutation, started pirtobrutinib, had a wonderful response, and then relapsed around a year, and the C481S mutation is gone. But now there is a new BTK mutation in 528W. And this work from the Memorial Sloan Kettering group nicely summarizes here from an early study the type of mutations they saw in patients progressing on pirtobrutinib. No C481S, as expected, but several other mutations can now confer resistance to pirtobrutinib. And this brings out an interesting point. With different types of inhibitors, we actually see different types of mutations. In this graph, you see the clinically documented BTK mutations by type of BTK inhibitor used. So ibrutinib has the most mutations because it's the longest studied. Okay? But when you look at it, it's mostly centered around the cysteine mutation. Acalabrutinib and zanubrutinib also have these cysteine mutations. So switching from ibrutinib to acalabrutinib or zanubrutinib will not work. This shared mutation is conferring resistance to all of them. Interestingly, we see some mutations, acalabrutinib, this T474I, that's uncommon with ibrutinib, not reported on zanubrutinib. On the other hand, we have the L528W mutation towards the bottom that is more common in zanubrutinib than we see in the other BTK inhibitors, the covalent BTK inhibitors. And then in red, you see the non-covalent pirtobrutinib. No mutations in the cysteine, as expected and understandable from mechanism of action, but we see other mutations. Some of them overlap, some of them don't, with the covalent BTK inhibitors. So this certainly, the tumor continues to evolve, but it again tells us it really cares about BTK. So what's the next strategy to go against BTK to overcome this? So we're changing the paradigm now. We're going from inhibitors to molecules that can completely degrade BTK. They do this by a hook which binds BTK, a linker, and then a harness that brings in cereblon, which has the activity of ubiquitinating BTK, targeting it for proteasomal degradation. So we're basically sending BTK through the internal waste disposal system, get it completely degraded. The Western blot below that shows you that what we did in the lab to show at even very low concentrations, we can get completely rid of BTK, and that's true for both wild type and C481 mutant. So this strategy is not impacted by mutations. So this is still in early phase trials. This is work we did together with Nurix. They have two molecules in clinical trials. Show you one example, one patient vignette from my clinic. Patient with Waldenstrom's macroglobulinemia, lifetime over 10 regimens, but the last 4 were for transformed lymphoma. And so she came back after her last treatment, again with this PET-avid long lesion there in the left thigh, with 2 cycles, 2 months of treatment, oral therapy. She's in complete metabolic response and has maintained this for over 2 years. So single agent BTK targeting restores the response here. So the other molecule from Nurix has recently received a name, Bexobrutideg. This is data presented at ASH last year, and you see here an impressive waterfall plot to point out the stars are CNS involvement in CLL. These patients also responded. And below the waterfall plot, you see actually the mutational profile that is complex, contains multiple types of BTK mutations, and this degradation still works. One advantage is this is an enzymatic reaction. You don't have to have a long on-target residence. If the molecules bump into each other, ubiquitin can be deposited. That's covalent attached, that stays attached. The drug can fall off, the ubiquitin stays. The protein is targeted for destruction. So this is a very different paradigm than what we have with inhibitors. Okay, for balance, let me get also to venetoclax. So studied initially as single agent. With single agent, one saw mutations. Again, immediately understandable why these mutations happen. And they abolished the binding of the venetoclax to BCL2. But that's not how we use venetoclax now. Venetoclax was quickly taken into combination regimens that are time limited. Here showing one of the first trials comparing venetoclax to venetoclax obinutuzumab. And this is the outcome. Of course, it was much better than chlorambucil. With venetoclax, we have another element that comes into play, and that's assessing minimal residual disease. So basically, what this nicely illustrates here, I think, is when we talk about complete remissions in CLL, it just means we don't see it with relatively superficial ways, right? Exam, a blood count, a normal ALC. But when you go with flow cytometry, in many of these patients, you will find disease. And so here we're just pushing the envelope to see how much CLL is actually left. And I think it gives us good information about types of treatment. It may not be something, personal opinion, that we really need to integrate into everyday practice, but it's an interesting readout of what a drug does. So here with venetoclax obinutuzumab, a high rate of such undetectable disease, so beyond clinical staging. In green, you see these undetectable for MRD, but you also see that after a peak at the end of therapy, now during just observation, therapy-free, the rate of undetectable disease declines. We start detecting low levels and higher levels. So I think what this can tell us is, yeah, fantastic, we get deep responses, but they are not equal to cure. It looks like these responses have a shelf life and eventually CLL comes back. What's clear is not getting to at least the level below 1 in 10,000, that's the easy, by flow cytometry, easy to assess level of undetectable MRD, that's bad news for progression-free time. But after that, it almost doesn't matter too much. Is it 1 in a million? Is it 1 in 100,000? Those curves are overlapping. But it's not good news if you don't get to below 1 in 10,000 with this approach. What about more intense or other comparisons? So this is the German CL study group, FCR versus rituximab venetoclax, obinutuzumab venetoclax. Here they call this GV, it's VO, because it's Gazyva or obinutuzumab, whatever you use, right? G and O in this are interchangeable. And then the triple combination adding ibrutinib. This is the PFS data published initially in New England Journal, updated in 25. So if you look just at the 4-year PFS, obinutuzumab venetoclax gives you a 4-year PFS of 82%. Keep in mind that 3 years of that is without any treatment, right? So it was a 1-year treatment and you're off treatment, and at the end of 4 years, you still have 82% of patients have not progressed. There is a high rate of undetectable MRD, both for obinutuzumab venetoclax, so the GV regimen here. Slightly more undetectable MRD when you do a triple combination, but you pay a price for it. More neutropenia, more infections, and you get the toxicity of the BTK inhibitor, hypertension, atrial fibrillation. So absolutely not clear whether it's worth the squeeze to make it a triple combination. The other approach to combination was to define acalabrutinib as the backbone, and this is the amplified trial, chemoimmunotherapy versus acalabrutinib venetoclax versus triple combination with the addition of obinutuzumab. The trial was designed to test whether acalabrutinib venetoclax beats chemotherapy. Yes, it did, and it got FDA approval for that. So this is an approved frontline regimen now that has been better than chemotherapy. Whether you need the triple combination is at times debated. Again, you definitely pay a price, more neutropenia, more infections. So with undetectable MRD, people have started to think about very sophisticated concepts of using undetectable MRD as how long you treat, how intense you treat. This is one of the trials that has done this in the most consequential way. They give ibrutinib venetoclax. They measure undetectable MRD, or actually the rate of decline in measurable disease. The faster you clear, the less your total treatment duration. If you take long to clear, your time on drug gets doubled up, and you may actually be treated for a long time. What that resulted in is that IGHV unmutated CLL patients had a median of 24 months on treatment, whereas IGHV mutated patients had 44 months. So I have to show you the progression-free survival that shows that this is super approach compared to FCR if you look at this progression-free survival curve. The downside, I would argue, is that you totally overtreat the patient population that does well in general. And that's the IGHV mutated CLL patients that are just almost 2 years longer on combination therapy that causes neutropenia, maybe diarrhea, maybe AFib, maybe hypertension. So I think this was a very interesting academic exercise. I don't think that's ready to be implemented in practice. Let me quickly show you, people say with single agent BTK inhibitors you do not get undetectable MRD. That's not true, you just have to be patient. This is our data now, continuous ibrutinib from 2012 through however long patients stay on it. This is the measurement of UMRD in these patients. It takes a median of 5 years to get below 1 in 10,000 CLL cells in the blood. But except for 1 out of these 13 patients, everybody has maintained their undetectable MRD. Okay, on continuous therapy, but nobody on continuous therapy, except 1 patient, has relapsed. So, promised you to quickly go over special populations, and I'll speed up a little. So, is it time, with all these effective treatments, is it time to just ditch, watch and wait? Nobody likes the term anyways, and just treat upfront for diagnosis. And this was again and again and again studied, and this time here with ibrutinib. Of course, the event-free survival, if you count an event as needing treatment or progressing, for patients who are not on treatment, obviously they will have such events. So this curve will always look good, but the resounding answer here again was no, don't do this. Yes, ibrutinib is effective. It is a treatment. The untreated patients will have progression and may need treatment when they need it. But everybody who is on treatment has the risk of side effects. So they had AFib in almost 6% versus less than 1% for placebo. They had hypertension at least twice as much. They had bleeding 2 to 3 times as much. So really, is that worth it? We should reserve treatment for when patients need it. What about the TP53 mutant patients, TP53 alterations, either deletion 17p, TP53 mutation? Ibrutinib works as single agent for actually a surprisingly long time, 4-year PFS, 80%, 79%. You can give venetoclax obinutuzumab, it works, but the progression-free time for patients with deletion 17p will be shorter. These patients will relapse earlier. So their median PFS was actually 49 months. So many of us would argue it's better to be on continuous therapy if you have deletion 17p, TP53 mutations. What about Richter transformation? So this is a quintessential picture of Richter transformation. With R-CHOP, I'm not showing you this, virtually everybody has relapsed by the end of the first year, and virtually everybody is dead by the end of the second year. So R-CHOP is not really the way to go. What people have tried here, Dana-Farber group, venetoclax plus more intense anthracycline-based chemotherapy, high overall response rate, but the median PFS is still only 10 months. And it's a hard regimen to give. So there are many other attempts to do this. One of the almost most controversial, promising ones is this combination of an anti-PD-1 plus zanubrutinib with a median progression-free survival of 10 months. We have data for CD19 CAR T cells, we have data for bispecific antibodies that were discussed. The median PFS is typically short, at best by about 6 months. So these patients should just go into clinical trial. There is really a need to figure out what needs to be done. But there's a big, big, big caveat with interpreting these studies. And that is, what is actually a Richter, right? Yeah, it's transformed CLL. But how do you really know it's transformed? Who tells us it's transformed? Well, this is a paper from expert pathologists. They tell us the upper panel is CLL, the lower is DLBCL. If you just glance at it briefly, it's actually hard to see the difference. In the DLBCL, the cells are larger, they're more densely packed, and you get this starry sky appearance of holes in between the blue. You don't see that in CLL. They're a little more dispersed, they're smaller. Okay, what about this one here, right? So this is a CLL biopsy, shows a proliferation center. Now let's look in this proliferation center. And these cells have nucleoli. They are a little larger. Is that Richter's? This paper, expert pathologists have coined the term accelerated CLL. And in contrast to Richter's, this is typically responsive and can be maintained for years on a BTK inhibitor. And then we get to pseudo-Richter's. Now look at the top. The top is what was called Richter's initially, but when you delve into the clinical context, the patient stopped the BTK inhibitor to undergo surgery. The lymph node biopsy taken during surgery is what we see in the top panel. Yes, there are mitosis, the cells are pretty large, but they're by far not as densely packed as what you typically see in DLBCL. Restarted BTK, and the next biopsy on BTK shows you a typical CLL panel. So what is the short message of a long presentation? Always question the diagnosis, always. And if Richter's is just read in one pathology suite, it needs to go to another pathology suite to actually know what we're dealing with. And it's probably never wrong to just go back on the BTK inhibitor. If it works, it probably wasn't Richter's. Okay. Do I have 2 more minutes? Okay, quickly, I won't go into every of these goals, but let me also give you just 3 highlights here about private thoughts. I talked about MRD. It's a tool. It's interesting. It's academic. But this is our long-term data with the ibrutinib trial. Patients who we looked at 3 years. Are you in undetectable MRD or not? And most of the patients were not. Most of the patients were either high MRD, so more than 1% of the circulating cells are still CLL cells, or low MRD, somewhere in 1 in 1,000 white cells is still a CLL. On continued therapy, these patients do perfectly well. Tells us there is no reason to call them treatment failures. As long as they are side effect free and happy with their treatment, that's fine. They don't need any heroic interventions or intensification of treatment. Affordability. Ibrutinib could soon be a off-patent, affordable drug. It may not happen immediately. That AbbVie disclosed the patent is to expire in 2027. No generic is in the pipeline, but the patent is about to expire. And I would argue ibrutinib is a fantastically good drug. The only problem is that we have acalabrutinib and zanubrutinib that is slightly better tolerated. So I really take the stand that ibrutinib is a fantastically good drug. If it's affordable, off-patent, it's a very good option for many people. What about immune function? As we know, infections remain one of the caveats, and so studying different treatments for how well they preserve immune function or strategies to restore, I think will actually take center stage over the next years. What we did here was a vaccination trial with hepatitis B and Shingrix vaccines, herpes zoster vaccines. So with hepatitis B, where we tested de novo immune response, we see very low responses in CLL patients, and BTK inhibitors virtually prevent the response. With the Shingrix vaccine, on ongoing BTK inhibitor therapy, we do get some vaccination response. That's the green. In blue is treatment-naive CLL patients. But it's both the antibody and the cellular response are impacted by being on the BTK inhibitor. So I think it just primarily reinforces the earlier we can vaccinate patients, we should do it. right? So basically at the time of diagnosis, probably going over all the vaccines would be a good idea. Okay, so with that, I would really like to thank for especially our patients. They undergo a lot more biopsies, blood draws, and procedures than they would in standard care. That's possible, and thanks to this unique hospital system in Bethesda. So we see all patients on clinical trials, all care is free. I mean, they have to make it to NIH at one point, but then from there on it's also travel assistance. And we see a lot of patients who also really come because they want to participate in research, fighting back this very American approach. I'm European by descent. So this very American, let's fight back, right? I have a disease, I want to fight it by giving to research. That's what many of the patients motivate to come. And then I have really a fantastic team with Nakli Salba having been for more than 2 years a very valuable component of that team. And so thank you all for your attention.
All right, we still have about 15 minutes for questions. I'd like to invite the panel to come back to the podium to take questions from the audience. So the panel is ready for your questions, guys. I can get started with you, Adrienne, while everybody's ramping up. Those who had progression on covalent, on ibrutinib in your study, and did not have any detected resistant mutation in the blood, those the last 2 or 3 patients in the bottom, did you find anything in the lymph node for those particular patients or not? Like, do you have somebody or patients without any detected mutation, any compartment?
So they did not have mutations. Does it work now? Yes, okay. So they did not have mutations by exome sequencing, by candidate sequencing, but I don't know if we had a lymph node in all of those 3 at the bottom that didn't have it in the blood. I would have to go back, Steve.
Yeah, but it's interesting that the compartment matters in those cells, and that definitely, for me, it explains how a low VAF might be associated with progression on those BTKIs.
Yeah.
Okay. Other questions? I have a few questions actually for the rest. Dr. Davis, with the Pola-R-CHP rising after almost 3 decades of failure against R-CHOP, do you foresee this lasting for a long time? I mean, you showed us the bispecifics in the second line. Also, we're aware of some data in the front line, early data. Do you think that will change soon, so we don't have to argue whether we should do Pola-R-CHP in the front line? Is it going to survive for a long time like R-CHOP did? I know you don't have the crystal ball, but what's your take on that?
That's a great question. I think it'll be interesting because there are studies that are comparing novel combinations with R-CHOP and novel combinations with Pola-R-CHP. So I think there will probably be some regimens that show superiority in things like PFS. I personally believe that overall survival benefit is still the gold standard, and we need to see a novel therapy that improves not just PFS but OS in order to really replace R-CHOP definitively. So I think actually in the foreseeable future we'll still see a lot of R-CHOP type chemotherapy because it's very feasible to administer.
Yeah, I can't agree more with you. We need OS in DLBCL. There was an old study of R-CHOP with maintenance LEN. That one had PFS benefit, and yet no one used it, arguably because it has more toxicity. In AML, Dr. Takeda, we have you showed us the Ven-Aza data. Obviously, it's not a home run, especially in the older population. I see you use more triplets and quadruplets in there. Any quick comment on how do you choose between these regimens and why?
Thank you for the question. So I think the data from ASH 2025 was just kind of a proof that ACE-Ven is a good backbone, but I think we can still do better. So the problem with ACE and Ven is that it gave the ability to us to kind of open and close the faucet, so patients that were having a lot of complications, we could manage the complications for those patients, and they had a better overall survival. And now that we can manage, the days of venetoclax on real time, now the question is, how can we less myelosuppressive but still kill more AML blasts? So now I think, and that's why I'm moving more towards the clinical trials of triplets, because I think we have to just learn how to do with the myelosuppression, and that takes a lot of experience, and that takes a lot of regimens and back and forward. There's some very interesting data with cladribine, low-dose Ara-C, venetoclax for patients that, especially older than 60 years of age, and that also challenges, and that comes with interchangeably ACE and Ven and this, and their results are impressive. So, of course, we need randomized clinical data to decide which one's better, but for now, we're just, in clinical trials trying most of these combinations.
Okay. All right, if no further question, that concludes the talk this morning. Thank you very much for attending.
Nice to meet you.
Oh, a picture?
Kim, can you save me a spot? Can you save me a spot? And Dr. Matrana?
Hey, how are we with, what time's the next speaker? I'm doing the keynote. I'm making sure all that's in there. So right now, so lunch is 11:30 noon? Yeah, what we got? Okay. Okay. So I'm gonna, in 10 minutes, I'm gonna draw. And what about the, are we good with the buses?
Yeah, I just spoke to the,
Spoke to the concierge, he said, just park in the right lane, I'm probably gonna have to block the lane, but whatever, just go right up. You're gonna see part of the bus, park up in front. It's gonna be two, probably a minibus and a tourist bus, but might be. So if I tell people that we're doing it, yeah, I booked it for 4:30, and said they'll be around 4:15, just to talk about traffic. Yeah, and he's staying there, so.
Really important stuff right here.
yes, look.
I wouldn't tell even if they did. Maybe out here. Yeah, I'm having a problem with downloaded. This is what happens. On my Google Drive, it's good. This is hard. I don't know.
Alright, you mean do my magic again?
Yeah, because you had it last. I don't know what the hell you did, but you did it. Watch this.
With this guy.
It's like a race car. So look, we can just do hers on Google Drive. Yeah, I didn't get with that. So they're doing it the base on the same topic. But I don't know who's going first. I mean, they're adults. They can figure out who's going to open it. This is the two. Like, we need to figure that out. First case is
Hello, hello, hello. If everybody could grab a seat. Oh, you know what? We don't have the David Yerman bracelets up here. We need them. They're not. The bracelets aren't up here. So let me go get them. Oh, wait, You know where they are, right? They are. In about 2 minutes, we're going to do the drawing for the David Yerman bracelets. Yesterday, we actually forgot to do it at lunch, so we're going to do 2 drawings. You actually have to be present to win the David Yerman bracelet. So if we have to pull more than one time, we will. We want to thank Oakwyn Hart Jewelry Store on Metairie Road for once again sponsoring our door prizes. While we wait, just a couple of household items. Everyone knows that we have our crawfish boil / fried chicken jam today at Nolay on St. Charles Avenue to end our, conclude our conference, which is at the boil and fried chicken start at 5:30. And if you're staying at the hotel and you don't have a vehicle, we're providing transportation. We're going to have 2 Greyhound buses outside the Sheraton they'll be outside as early as 4:15, but we're leaving to go to Nolay at 4:45. So if you're planning on taking the bus to the crawfish boil, please be on the bus no later than 4:44, because at 4:45, we're leaving to go. For those people that are driving to the crawfish boil at Nolay on St. Charles Avenue, the address is in the program. We're also providing free valet service. So if you're local and you're not staying at the hotel and you don't want to take the bus, then you can do that. You can just valet right there. One of the attendees told me that they attended the crawfish boil and the fried chicken jam, and the way he described it was, he said that it's his death penalty meal. That if he was given the death penalty and he could pick one meal, he would get Copeland's fried chicken, followed by 700 pounds of crawfish. So please come and get your death penalty meal tonight. We would really appreciate it. It's probably a bad, not the best way to explain it considering this is a cancer conference. But regardless, please come. It's a lot of fun. We put a lot of time and effort into it. Everyone's worked so hard, and you guys have worked hard attending this conference. So this is just an awesome way to conclude the conference. We have a DJ. We have great food, complimentary bar. So it's, everything's done the right way. So I think now we're going to do the drawing. And please be outside by 4:45 at the absolute latest. That's what time the bus is leaving in front of the Sheraton Hotel for Nolay. So we're going to do the drawing right now. Is the photographer in here? Jeff, you got your... And we're going to have Miss Kim Grow, who's a CAGLA trustee and has helped us run the volunteers this year. So she's going to pick. So go ahead, Kim. We got. All right, for the first David Yerman bracelet, we have, I'm probably not going to say this name right, Kalika Caldwell? Kalika Caldwell? Is she here? You have to be present to claim your bracelet. Does anyone know Kalika Caldwell? Is she here? Okay. So we'll give it a minute for her to come up. Kalika Caldwell. Somebody want to go get her real quick? Huh? Yeah. And if there's one other thing, yesterday we had some problems with the overflow room, which is right behind this room, but we're not having those same problems today. So we're live streaming the keynote speaker. So if you can't find a spot in this room, you can just sit in the room behind it, and there'll be a projector, and you'll be able to watch and listen to the keynote speaker. Let's see if, okay, I guess while we wait, we could pull the second one. Wow. What is it? Darlene. Okay. Darlene Bowie? Darlene Bowie, are you here, Darlene? Works at Ochsner. Come on up, Darlene. Either one. Present one to one and two. Let's give a round of applause. Come on up, Darlene. Ready to get in the middle, Darlene? Congratulations, Darlene. Thank you. Congratulations.
Thank you for coming.
Yes.
Right, so should we call Kalika?
We're going to call Kalika probably one more time, and then we may have to draw again if we don't get her here. So, does anyone know she's definitely here? Does anyone know if Kalika Caldwell is definitely here? Huh? Okay.
Oh, there she is.
Kalika Caldwell? Okay. Let's give a round of applause for Kalika Caldwell. Congratulations. Thank you, Kim. And let's give a round of applause for our sponsor, once again, Oakland Hart Jewelry Store on Metairie Road, the top jewelry store in the city of New Orleans. Great people who always support us every year. I think we're going to give it about 2 or 3 minutes, and then Dr. Matrana is going to introduce our next keynote speaker, who I'm super excited to hear speak.
All right, everyone. All right, everybody got their lunch and ready to go? I think you will agree that we have had phenomenal keynote speakers at this conference, right? No doubt about it. But we may have just saved the best for last. I am so proud to introduce Dr. Shuka Jain. She's a triple board certified hematologist and oncologist. She's an associate professor at the University of Illinois Cancer Center and the associate director of communication strategies in medicine. She specializes in GI oncology and leads multiple clinical trials focused on advancing precision cancer care. She's also the founder of Women in Medicine. She is a nationally recognized physician leader, and she was named Illinois' Physician Leader of the Year. She's been named one of Medscape's Rising Stars, Modern Healthcare's top 25 emerging leaders in healthcare, and one of OncoDaily's 100 influential women in oncology. Dr. Jain is the founder and board chair of Women in Medicine, as we mentioned, and she's a media expert. She's been featured on CNN, on MSNBC, ABC, Fox, and in Time and the New York Times. And she's a sought-after speaker on leadership, equity, and communication in healthcare. We are so lucky to have her, and can't wait to hear what she has to tell us today. Thank you for being here.
Hi, everyone. I mean, what pressure. Final keynote speaker. I don't know if I can handle that pressure. First, can we get a huge round of applause for the organizers of this conference? I mean, what a phenomenal conference. It's really incredible to see so many people coming together who care so much about cancer care. And what I'm going to be talking about is how we can make sure that cancer care gets to the people who need it the most. So as was mentioned, I live and work in Chicago, and one of the biggest challenges that we see in Chicago, and we are now seeing across really the country, is we have the best, the coolest, the most amazing innovation in healthcare. Immunotherapy, precision oncology, all of these incredible targeted therapies, all of these things that have transformed the way we deliver cancer care. Unfortunately, what happens is a lot of people don't have access to that care. And there's a lot of things that we can do about that. And a lot of people don't realize by actually investing time, effort, and money in these interventions, we could actually be saving our healthcare systems millions to billions of dollars. So I'm going to talk today a little bit about the problem, but my dad is a surgeon, and if you've ever heard me speak before, I always reference my dad because he always tells me, don't come to me with your problems, come to me with your solutions. So we're going to talk about the problems, but then we're going to focus on some solutions based on what we found works in Chicago, and also some of the things that we've implemented across the country that seem to really be having an impact. And I'll be sharing some information on some other institutions that are also doing amazing stuff. So first, let's talk about the reality of the situation. The reality is cancer care is excellent in the chair in this country. If you get the chance to get into that chair to get treated after you've been faced with this really traumatizing diagnosis, the chance that you're going to get exceptional care is very high because our doctors, our nurses, our social workers, our navigators are amazing. Unfortunately, many cancer outcomes are shaped before and after that appointment. I have patients who are long-haul truck drivers who drive around the country, and they get labeled as non-compliant because they miss an appointment. Or I get patients who say, I can't come in for chemo because if I don't show up to work tomorrow for my job, I can't put food on my table. I tell this story about a patient of mine. This is my favorite story to tell because it has a good outcome at the end. I was seeing this man, and he needed to be admitted to the hospital. And I said to him, you have to get admitted today or you will die. Like, this is not me being hyperbolic. You will die if we do not admit you today. And he said, Dr. Jain, I can't. I don't have any more sick days, and my boss will fire me. And I was like, nope, that's not going to happen. Give me your phone. So I called his boss, and I said, this is Dr. Jain from the University of Illinois Cancer Center. Who am I speaking with? He introduced himself, and I said, well, I have your worker here, Mr. I won't say his name because of HIPAA. And I said, so he needs to be admitted to the hospital or else he's going to die. Are you going to fire him if I admit him to the hospital? And the boss was like, I'm sorry, is this a prank? And I said, no, this is actually Dr. Jane, and I just need to know if you're going to fire this man if I admit him to the hospital. And he was like, no, of course not. If he needs to be admitted, then admit him. And so I put him on speaker. I said, I would like you to say that out loud verbally so that my patient knows he can safely be admitted to the hospital without losing his job. And the guy said, yeah, of course, go to the hospital if you need to go to the hospital. We hung up, and my patient said to me, Dr. Jane, you don't understand. Yesterday, this man told me that if I missed one more day of work, I was losing my job. And I said, well, you now have a witness. So he got admitted, we saved his life, and he was able to go back to work. But the point is, he's in my office. I know what I can do to help him, but I can't control all of these external things that are happening. I have no control over his life, his job, putting food on the table, his family, his other medical issues. So the real challenge is when we talk about how do we deliver care, it's getting the care to the people who need it and then ensuring that they can actually utilize that care. We know that structural barriers drive inequities and the challenges that we have in our healthcare system. Healthcare for years has been built on structures that favor certain groups and don't favor others. We know that there is structural racism and a lot of challenges that were built into the healthcare system. Women were not in the healthcare system when it was built. We were not working as physicians, maybe as nurses in some cases, but really when the healthcare system was built, women were not in leadership, and many women were not even working in the healthcare system, but we were patients. So the healthcare system was designed without thinking of what 2026 would be like. And under-resourced patients often pay the price. So we're going to be talking a little bit about this discovery-delivery disconnect. And let's talk about cancer care and where cancer care really breaks. So I had great conversations yesterday about how prevention and screening are so important. You must invest in prevention. And that is one thing our country, for some reason, does not do very well at. We focus a lot on solving the problems after the diagnosis has already happened. But what we should be doing is telling everybody at the age of 45, get your colonoscopy. If you have a family history, get it sooner. The American Cancer Society just released that people under the age of 50, the #1 cause of cancer death is colon cancer. That should not be happening because we know that colonoscopies can save lives. So why is everybody not getting a colonoscopy at the age of 45? Mammograms, HPV vaccines. There are so many ways that we can prevent cancers from developing. Treatment access is a huge issue, whether it's transportation, whether it's you can't drive 4 hours each way to get to the nearest hospital, whether it's clinical trial access, because there's only clinical trials available in your town, but that town is 3 hours away. How are you going to get there for a clinical trial? Follow-up and support, making sure that patients, if they're having side effects, they don't just stop their medications. The number of times I've had patients come in and be like, Dr. Jane, you made me sick. Like, no, I really didn't make you sick. What happened? They're like, I had to stop these meds because I was having all this nausea. I'm like, well, remember, I gave you these medicines to help with the nausea. And the patients are like, shoot. I forgot, and I just stopped taking my meds. So the follow-up and making sure that patients know that there are resources to help them, or we can reduce the dose. There's lots of ways that we can help patients understand that we're there to help, but that gets lost in a system where there just isn't time to constantly be checking in on our patients. Food insecurity, housing instability, language and health literacy gaps, limited integration of community resources, and a huge one that I'll be talking about near the end of my talk is misinformation, and how misinformation is a public health epidemic, and it has driven our vaccine rates down. I mean, we're basically losing our status for eliminating measles in this country. The fact that we have people coming to me saying they're worried about microchips from the flu vaccine. I mean, the misinformation that I hear in my clinic is just profound. And when it comes to cancer care and misinformation, it can actually be very deadly. So we'll talk a little bit about that. So what does the word equity mean? Because it gets thrown around a lot these days, and a lot of people have put a negative connotation around equity. The way I think of equity is what I teach my kids. So I have 3 kids, 11, 8, and 8, and I tell them we treat others the way we want to be treated. To me, equity is making sure that people have access to equal resources. Now, I understand that somebody in rural Iowa may not have the same access as somebody in LA, but it's working within those structures and figuring out how do we make sure people have some sort of equitable resources to help drive their care. We talked a little bit about finances, and we talk about social determinants of health quite a bit, work and caregiving realities. So I will tell you, I am the worst culprit of this. Thank God I have a husband who harasses me to go get my medical stuff done, because I will tell you, most women, especially if they are caregivers, either to elderly aging parents or to children, are often foregoing their own health for others. I'll tell you, one year, my mammogram got delayed by a couple of months, and my husband was furious. He said, "What are you doing? If you aren't around, then who's gonna help take care of all of us?" Which is true. But the point is, we often forget that we need to take care of ourselves so that we can also take care of others. And then one thing that I think is really important is there's a lot of lack of trust in healthcare systems. There has been for years and years and decades, and some of it is very, very well placed. I mean, we can talk about Tuskegee, we can talk about Henrietta Lacks, we can talk about how many people felt marginalized and ignored in our healthcare systems. So there are communities that have a very real reason to have this lack of trust in the healthcare system. And then the pandemic and social media and this rise in misinformation has fueled that and fed into that. Now, I use social media quite a bit. I'm not as social media famous as some doctors out there, but I do think that social media is a good way for us as healthcare providers, healthcare physicians, nurses, people as a part of the care team can help fight that misinformation. So, as I said, I'm from Chicago. When we talk about where you live can impact your life expectancy, I'm not even talking about from LA to Iowa. I'm talking about different stops on our Green Line. So in Chicago, if you've never been, definitely come. It's a lot of fun, especially in the summer. Don't come in the winter. But the challenge happens where we have a red line, a blue line, a green line. We have these elevated trains, and there was a study done that showed where you lived on the Green Line route actually impacted your life expectancy. It differed by over 10 years along that Green Line route. So you could live 2 miles from someone and have a 10+ difference in your difference in your life expectancy. So equity should never be an add-on. This is not something we should be thinking of as something that, I guess we should infuse some equity into our system. It really should be the center point of everything that we're doing. It's a part of care design. And when we talk about equity, we talk about things like navigation, talking about primary care and the focus on investing in primary care, community infrastructure, so partnering with churches, with barbershops, partnering with schools, thinking about how can you get the community involved. Clinical trial equity, I'll talk a little bit about how we can get more clinical trials out to the community where people actually need it, and getting people to understand what clinical trials are. Because the number of patients who've told me, Dr. Jane, I'm not letting you experiment on me. I don't want to be in a clinical trial. We've got to reframe the narrative. 90% of what we do when it comes to medicine is figuring out how to present things to patients so they can make an informed decision. Gone are the days, for the most part, of the doctor saying, you're going to do this, and the patient saying, okay. Now I have patients come in with stacks and stacks of printouts from the internet where they say, I want this drug, I want this, this, and this, and I'm not going to take no for an answer. And so what we need to do as physicians and healthcare providers is we need to be thinking, how can we work within the system that we have now to help our patients make informed decisions and go through all of that stuff that's online? Some of it's good, some of it's not. How do we help them navigate that? Because even as a physician, sometimes I read stuff and I'm like, is that real? Like, did that really happen? So it's not easy to go through all of this. So we need to figure out, how do we talk to our patients? And then I'm not going to talk very much about policy and payment reform, but holy cow, do we need to have a conversation on how we need policy and payment reform in this country. So let's talk a little bit about the infrastructure. So one of the things that was introduced several years ago that has been very effective at helping with that gap after the patients leave is patient care navigation. Has anyone here not heard of navigation? Okay, a couple people. All right, good. So the way navigation works is it basically connects patients to resources and support that helps drive these equitable outcomes. So what it means, I see a patient in clinic, and then I have a nurse navigator who will then follow up in a couple days and say, hey, are you taking your chemo pills? Are you having any side effects? Did you develop that rash Dr. Jane said? Oh, you did. Okay, are you using that cream? You haven't picked it up from the pharmacy? All right, you should probably go do that and try using that before you stop the chemo. So just checking in, making sure, is your CT scan scheduled? Did you have any questions? Did you meet with the geneticist? So it's almost like having somebody on the inside who can help you navigate your care. One of my very good friends was recently diagnosed with cancer, and one of the things she said to me was, if I didn't have somebody in the system like you to help me figure out how to navigate it, I never would have known what to do. It shouldn't be like that. We shouldn't be a society where the only way you know how to get care is to have a doctor friend or a nurse friend who can help you figure it out. There was a study that came out of the University of Alabama where it showed that this Patient Care Connects program, where they were really proactive on navigation, and these weren't actually nurses, these weren't healthcare providers, these were just people who were a part of this program, and they would connect with patients between clinic visits. They did regular outreach to patients between visits. They also addressed things like transportation, food insecurity, medication access. And what they found was this reduced ER visits, it reduced hospitalizations, it improved continuity of care, and it showed that the time outside the clinic is actually even more important in some cases than the time spent in the clinic. I mean, I think I'm super important. I can write the prescriptions, I can give you the treatment plan, but again, the real implementation is where we lose these patients. And it's scary to me where I have patients who I could cure and they can't get cured because of all of these external barriers. How do we help them with that? So this Patient Care Connect showed that when navigation follows patients into their real lives, not just their appointments, the outcomes improve. And in Chicago, one of the things that's really cool, you know, when I always remember that I always heard, and I still hear sometimes, oh, academic institutions are very competitive. They don't want to collaborate. We want to keep our patients here. And that in oncology isn't necessarily the best thing to do, right? I recommend all of my patients go for second opinions, third opinions, as long as it's not going to delay care. So one thing that that's been launched in Chicago is this Chicago Cancer Health Equity Collaborative. It's a cross-institution collaboration that addresses these inequities, and it partners with community organizations. And again, at the end of the day, from our academic institutions, we can do so much, but we don't always have the trust that we need in order to implement these things. It's your neighbor that you trust. I mean, the number of people who've said, my uncle's second cousin, sister's brother's husband's nephew said that this magic pill cured her cancer. What are you going to do for me? Those are the people that people trust. They don't trust me, Dr. Jane. They trust their whatever I just said, however that person was related to them, right? So we need to figure out, how do we get into those communities and help them become our advocates? How do we help our patients get that trust, not just from us, but also from their community? And this matters because equity work is really stronger when institutions collaborate and work together, and these community relationships are incredibly important. And we know that cancer outcomes are directly related to these types of outreach efforts. One of the things that we've done at University of Illinois is we've launched this Illinois Cancer Health Equity Research Center, because we're academics, and academics like research, and we like data before we implement things. And so there's multiple different studies that are ongoing at University of Illinois that are focused on implementation science, community-engaged research, training future equity leaders, and translating evidence into real-world care. Because for those of you who ever attend ASCO, our big oncology conference, the number of times I've sat in the audience and people are giving a standing ovation for this amazing new drug that comes out, without fail, my mind goes to, awesome, this is such a great, innovative drug. 90% of my patients won't be able to have access to it because it's only available at 3 sites in the entire country. And even when it becomes accessible to everyone, how are those people who aren't near an academic center going to get it? And so this is in partnership with the American Cancer Society and several institutions. And I'm not going to go through all of the projects because there's so many of them, it'd take another couple of hours. I'm going to highlight a couple of them that can actually be implemented at your institutions and actually have a real impact, and I'll tell you the impact. So the couple that I want to talk about, so there's one called Test Me Gene Study, looking at optimizing best practice solutions for implementation of population-based cancer genetic services. Fun fact, a lot of people don't know that your family history is incredibly important when it comes to cancer risk. You might need your colonoscopy at the age of 30, which I know sounds terrifying, but it's really not that bad, I promise. So cancer genetics is really important, and family history is very important. Another study looking at culturally sensitive narrative intervention to promote equity in clinical trial enrollment. My patients who are constantly saying to me, I don't trust clinical trials because I don't want to be experimented on, I don't want a placebo. The LaLisa study looking at community-based approaches to empower patients, because a cancer diagnosis can feel like you've completely lost control. I mean, you are living, think about this, you're living your regular life, you're going about your day, and all of a sudden you go to the doctor for what you think is a regular visit, and now you've been told you have cancer, you have to come to clinic once every 2 weeks, you are going to feel like garbage sometimes, and you might have to miss a lot of work. Oh, and you have kids getting married. You might lose your hair before the wedding. You have a grandson who's graduating. Okay, well, let's figure out how to move your chemo so it doesn't conflict. A cancer diagnosis completely transforms your life. And so most patients that I have talked to feel that they completely lose any sort of control or decision making. And so empowering patients to feel like they have some control, because you do have some control. It's just not the same control you have in the rest of your life. That can actually be really empowering, and it can actually impact outcomes as well. There's a colorectal cancer risk assessment and a couple other studies that we have ongoing. So first is precision reaching primary care. Over 4,000 patients were screened in FQHCs looking at genetics and genetic testing, and they found that genetic testing rates doubled, and there was over an 80% primary care physician participation. Precision oncology, precision care, genetic care cannot be limited just to academic walls. It just can't. And part of it is educating the physicians and the people providing the care, and a part of it is educating the patients and getting them to understand why we are doing this. How will this potentially impact your life and the life of your children, your sister, your brother, your uncle, your aunt? For me, clinical trial access is an equity issue. So there's a QR code if you want to look at the video, one of the videos that was put out. But this is talking about how do we talk about clinical trials to our patients? How do we get our patients to understand what a clinical trial is? And the most important thing is having people who look like your patient population engaging in these videos. Because again, if I'm talking to a lot of people who don't necessarily look like me, who don't know who I am, who don't trust me, they're not going to resonate with me as much as someone who looks like somebody that they feel like they could be friends with, or somebody that might be their neighbor. So sometimes thinking about culturally sensitive topics and presenting things to certain groups of people based on their background, their cultural beliefs, can be very different. I will tell you, my aunties and uncles, my Indian aunties and uncles, when they found out I was going to be an oncologist, the amount of Facebook nonsense I got of, have you seen this magic cure? Have you seen this pill? Have you seen this cleanse? And they don't do that anymore. But they did at the beginning, and that was because those were the types of things that were getting passed in their communities. And I mean, as I said, I'm of Indian origin. I was born in New Jersey, but I am of Indian origin, and we believe in a lot of homeopathic, holistic care. Turmeric is a great anti-inflammatory, but there needs to be evidence behind what we're doing. So incorporating in cultural beliefs and cultural sensitivities can also be very impactful when you're talking to patients. And then this LaLisa study was looking at empowering at-risk Latino women to promote cancer genetic services, and they found it resulted in a greater uptake of cancer genetic services than standard. So again, empowering your patients can be really impressive. I'm going to talk very briefly about food insecurity, because we sometimes forget that food is actually a huge part of cancer care, because most patients who have a diagnosis of cancer either don't want to eat because they feel sick because of the cancer, or they don't want to eat because of the chemo, or they just don't want to eat because they may not have access to the food that they actually would enjoy eating. So food insecurity actually has a big impact on patients and on their outcomes, because we want them to be healthy eaters while they're getting treatment. So what we are doing at University of Illinois through this Harvest program is we look at food access by increasing a volunteer workforce and development in food pantries. So again, partnership with the community. We talk to FQHCs and we do lifestyle referrals via the EMR. So you can actually trigger these types of referrals through your electronic medical record. And digital lifestyle programs, so looking at going back to navigation and talking about Medicaid enrollees, how can we do tools that people can use to empower themselves? And then we have coalitions, virtual platforms, and it's all integrated into the electronic medical record. So you need to have routine screening about food insecurities in workflows. And I will also tell you, patients are embarrassed. It's embarrassing for some people to say, I can't afford to get chicken to eat because it's the protein I need. Or I can't afford the Ensure. Can you give me coupons for it? So having those open and honest conversations and talking to the patient and making them understand this is not a fault of theirs, this is not something they should be embarrassed about, because food insecurity is something we often do not talk about. Community partnerships and food, if you're not eating and you lose weight and you get dehydrated, you pass out, you end up in the hospital, it can interrupt treatment as well. So again, we're talking about saving the healthcare system money. How do we save the healthcare system money? We prevent problems from happening. How do we prevent problems from happening? We make sure people have the food that they need to eat. All right, this is my favorite topic, misinformation as a clinical risk factor. So when I was a kid, how many of you actually, I don't want to, well, I'm going to call you out. How many of you were born before social media existed? How many of you are really happy there was no social media when you were in college? So social media has completely changed the game. It has completely transformed the way we deliver cancer care. It's changed the way I talk to my kids. Social media has become a huge impact in every part of our daily lives, whether we want it to be or not. And so during the pandemic, my friends and colleagues and I actually started another nonprofit called Impact. And it was a 501c3, and the purpose of it was to fight misinformation. Now, this is not an oncology-focused nonprofit, but I think that the lessons that we learned are very applicable to what we see in the cancer space. So our goal was to leverage social and traditional media, grow and leverage these novel partnerships, and we created a recipe for how do we craft and disseminate messaging to fight misinformation. It feels like the pandemic was like a lifetime ago, but when I tell you the amount of nonsensical things that came across my computer, I mean, it was impossible to keep up. I'm not even going to tell you some of them because I don't want to remember them. So we also crowdsourced to identify gaps and issues that needed advocacy, and then we repurposed and repackaged our messaging. And we used it to strategically amplify healthcare workers' voices to guide policymakers and the public during a pandemic. And this strategy I've implemented in the cancer space as well, and it has worked so well. So I'm gonna share this with you all in the hopes that maybe it might encourage you to do something online to try to fight misinformation. So how did we work? So first we created the recipe. So back in the old days, the way people got their information was the newspaper, the nightly news. There was not this 24/7 news cycle. There was not this constant scrolling. It was you get your news at the radio, the nightly news shows, and the newspaper predominantly. Now we are getting our news 24/7. So what did we do to try to help with that? First, we would create content. So we would create an infographic. So a picture that would be a, here is a fact, here is a myth that people are trying to sell you, and this is why that is not true. We would write something about the same topic. So we'd write a blog post about it. we would publish an op-ed, and we'd partner with a community organization, and then we'd get featured in a local or national media source, and then we would collaborate with either organizations or with schools or with churches or with barbershops, and we would then disseminate this messaging across all of our platforms. So social media, traditional media. It was actually really genius the way we did it, because we would have one message for the week. We would figure out what is the biggest misinformation that's come out this week, which honestly, there was like 10 things coming out a day, so it was kind of hard to pick. But we usually would ask our doctor friends in our physician Facebook group, hey, what are you hearing everybody is thinking about this week? And then we would take that message and we would amplify it across all of these different channels. And so it led to local and national news stories. It led to us getting published in the New England Journal of Medicine. It led to us getting featured in Time Magazine. This is a really cute picture that I have to include of my 3 kids during the pandemic. We were trying to find ways to stay active, and it was in the Chicago Tribune. So we were able to also humanize the story. When I was in training, we were often taught, don't be too vulnerable, don't tell people about your own history or your own story. That is not my personality. For any of you who've met with me in the last 2 days, you will know I am a sharer. I like to share my own stories because I also feel that people will resonate with, what are you going through? One of our co-founders is the vice dean of medical education at the University of Chicago, and she was pregnant during the pandemic. And so when the vaccines came out, she published about, should I get vaccinated with the COVID vaccine while pregnant? And she did. The highlight, I think, was one of our infographics was attacked by Nicki Minaj. I have to say, never in my entire life did I think I would ever be referenced alongside Nicki Minaj, but there you have it. I should put that on my CV, actually. So that was a highlight. But point being, when you have a coordinated, and we were all nobodies in the sense that we were not famous, influencers, we're not famous celebrities. We were just doctors, nurses, social workers who wanted to get the messaging out there. And we were able to fight misinformation with this coordinated strategy, putting it all out there. So what else did we do? We created a clearinghouse. So we talk about access to care. There's ways to put together huge databases where people can access it. I don't know if any of you have accessed the clinicaltrials.gov page ever to try to find a clinical trial. It is the bulkiest, most frustrating, if somebody in this room is able to come up with a better way to navigate clinical trials in this country, you will be a billionaire. I will invest in your company. Come find me. Because finding ways to easily get this information out to patients is really key. I'm a doctor, and it's hard for me to figure out which clinical trials people might be eligible for. So we created this vaccine clearinghouse during the pandemic when vaccines became available. And within a couple of days, we had over 20,000 people accessing it. And we were able to utilize that clearinghouse to then get tens of thousands of people vaccinated in underserved communities. Now, how did we do that? Because I told you, nobody trusts us, right? There's a lot of misinformation and fear. Well, again, we partnered with community partners. We went out to churches. We went out to schools. We did virtual webinars. We literally had people going to the barbershop saying, hey, we are hosting this vaccine drive. Can you tell anyone who comes in to get their haircut to come? And we got tens of thousands of people vaccinated, and we started to rebuild that trust in our healthcare systems. We partnered with, so there's, again, the academic part. We got grants. We partnered with large academic institutions like the NIH to get grant funding. And we also delivered policy letters. So one thing I think that's great that CAGLA is doing is focusing on not just how do we educate, but how do we drive change? Because we know that without healthcare policies that actually help patients, we are just spinning our wheels here. I can stand up and talk for days about what should be, but if the policy doesn't change, nothing changes. Prior authorizations, for example, are a huge challenge. I have the number of patients who I've written an order for a chemotherapy agent, and it has either been delayed or denied, where I've had to do multiple peer-to-peers and prior authorizations. That should not be how things are. We learned during the pandemic how, I don't want to say easy, but how it is possible to get incredible, innovative care delivered into the hands of the people across the nation, and it should not take 10 years. We know we can do it. It just shouldn't always be done under a national emergency. We need to rethink our policies, we need to rethink our structures, and we need to rethink our delivery of care. We also, so the other thing I always tell people, if any of you are publishing academic papers out here, one thing that I tell everybody, if you ever publish anything, always, always, always publish a complimentary op-ed with it. Because the people who read the New England Journal are not the same people who are reading USA Today. And our research that we have done, the things that we've gotten the most traction on, the things that have gotten my residents' TV interviews, the things that have ended us being tweeted by Nicki Minaj, those are the things that we wrote a complimentary op-ed about, because the academics are reading the academic papers, and I'll tell you, a lot of academics aren't reading academic papers. So most people are getting their news, where did I say? Social media, right? So how are we going to get this information out there? We need to meet people where they are. We need to find out where people are getting their information. Now, there are still people getting their information from the newspaper, from the news, so we also need to reach people there, which is why that recipe of getting information across multiple channels is so key. So I talked a little bit about hesitancy, and this goes back to cancer care as well. Why are people so scared? Well, cancer itself is terrifying, but why are people so scared of healthcare? People are scared of healthcare because there's a history of mistrust for a good reason. And two, there is so much misinformation coming out right now. And the sad thing is the misinformation is not just coming from influencers anymore. And never in my life did I think I would ever stand on stage and say, I am trusting vaccine schedules from the American Academy of Pediatrics, but not necessarily from websites through the government that I would have been going to for years and years, because some of the decisions that are being made are not science-based. And this is not a political statement, this is just scientific evidence and fact. We don't even know in the healthcare space sometimes where we can get our information. So how the heck are our patients gonna know? I mentioned my dad is a surgeon. My mom is, I call her an honorary doctor because she has attended every meeting with my dad her entire life. So she talks, people think that she is a physician because she speaks like a physician, because she understands. I mean, I say she's got an honorary MD, and we listen to her more than my dad when it comes to one of us being sick growing up. But she and I were talking, and she is very intelligent, and she's not really on social media. She follows me, basically, because she wants to see what I'm doing. But she will send me articles, and she'll say, I can't even tell if this is real or not. Like, this seems like a good thing, but you're posting that it's not. Explain to me why this is not a good thing. And so if intelligent, educated people can't figure out what's true and false, how can we expect our patients coming in who are already terrified, who are facing a major diagnosis, how can we expect them to navigate through all this misinformation? So what's the through line? How does equitable cancer care actually get built? And I think this is really the key point. So I've talked to you about a lot of things today, right? We've talked about food insecurity. We've talked about transportation. We've talked about misinformation. We've talked about just mistrust in the healthcare system. But what can we really do? What can we really do to drive change? How can we really make sure that our healthcare systems are equitable and that our patients are receiving quality care? And I still have a little bit of time, and I usually go way over time, but I made sure today that I had enough time for questions. So I'm going to leave time for questions. But before we get to that part, I want to just see if you had a solution. And this is a big question, if you had a solution, how do we fix our healthcare systems? How do we provide care to everybody? Anybody have an idea? Big ideas. Yes. We get big corporations to help us bring care to the people. I love that. How do we do that? Sorry to put you on the spot. I appreciate that you answered my question. No one else is going to want to answer now. Love it. So if you couldn't hear, he said we have to show them how it's profitable for them to give back to the communities, because at the end of the day, it brings them a profit as well. In the back there. More nurse navigators. Love it. Financial navigators. Love it. Back there. I love that. So do good here, and what you learn here, you can actually do in other countries to actually make even more money. Love it. Yeah. So it's interesting. So he just said was opening it up so more people can get into med school so that we have a larger supply of doctors. So that's fascinating. So many of you may not know, today is actually match day, where medical students find out where they match, which is awesome. My match day, if you go to my Instagram, you'll see a little story about my match day. I posted it, so you can learn about my match day. But the interesting thing is, when you think about getting more med students, there is actually a lot of spots that go unmatched. So it's almost like it's not necessarily a supply and demand where there's not enough doctors. I think one of the big challenges, there's not enough doctors going into primary care. So when you talk about like navigation, when you talk about this throughput of how do we make sure patients are being taken care of from start to finish, back in, again, the old days, it used to be you had your primary care doctor who knew your GI doctor, your cardiologist, your oncologist, and was coordinating all that care. Now we have less and less of primary care physicians because it's harder to navigate, well, for a variety of reasons. One, pay is low. Two, it's harder to navigate all of these things that are happening and all of these new innovations, and there's less and less incentive to become a primary care doctor. So I agree, we do need more doctors, but I also think we need to incentivize primary care physicians, because in a lot of parts of the country, those types of roles are being replaced by nurse practitioners and PAs. And I will say, I love my NP and PA colleagues. We are multidisciplinary. I love working with them. But the challenge is the amount of training you get in medical school is very different than the amount and the type of training you get as a nurse practitioner or a PA. So I don't think it's an either or. I don't think we can either have more doctors or have more, NPs and PAs stepping up. I think it's we need more doctors because we need that level of care to coordinate very complex things. So I agree, more people in medical school is good, but we need those residency spots because there aren't enough residency spots for the med students that currently exist in some cases. So when med students are going unmatched, meaning they finish med school and they don't have a spot for residency, that is a failure in our system. And when we're not incentivizing these brilliant med students to go be primary care doctors. That is a huge gap. And I will say, I think primary care docs are some of the smartest people I know. I couldn't do it because you've got to know everything from diabetes and heart disease to like ophthalmology and oncology. I mean, you need to know a little bit about everything or a lot about everything. So you had your hand up. So talking about bringing healthcare costs down, whether it's drug costs or just healthcare costs in general, how many of you understand how to navigate your medical bills when they come through? Anybody? I don't. I honest to God, I once had to get some imaging done at the hospital I worked at. And I called and I said, how much is this going to cost with insurance? And they said, oh, it's $2,500 with insurance. And I was like, that's bonkers. I have really good insurance. And I said, okay. And then I called back again and pretended to be someone else. And I said, I'm self-pay. How much would it cost? And it was $200. And so then I called back again, third time, because I was curious, and I said, hi, and I pretended I was myself again, and I said, so I actually just found out I lost my insurance, I'm self-pay. And she was like, no, that's not true, we have your insurance here. And I said, no, I'm canceling it, I want to be self-pay, because it's $200 instead of $2,500. And she was like, you can't do that. And I was like, I'm already paying for insurance, and now you're charging me 10 times as much for my imaging that I need. I mean, what are we doing here, folks? This doesn't make sense. Medication, how many people know people who've gone abroad to bring medications home? I mean, that should not be happening in this country. We have created a system that is not sustainable. And it's not just not sustainable for people who are living paycheck to paycheck. It's not affordable for people who have health insurance, who make good money, who one medical diagnosis, one cancer diagnosis could wipe out their entire life savings. I have a patient right now who has asked me to share her GoFundMe because she's 26. She's got a metastatic colon cancer diagnosis. She's got young kids, and she's like, Dr. Jane, I can't afford my care. And it's not just the oncology care, right? It's not just the chemo. There's imaging, there's biopsies, there's pathology, my favorite story is you go someplace and you get a surgery and you get a bill and they say, oh, your anesthesiologist was out of network. Cool. So I was unconscious, and your hospital brought in somebody who's not covered by my insurance, so now I'm on the hook for $50,000. What? And it's the same hospital. I confirmed that your hospital is under my insurance, so you just have one anesthesiologist who's not covered? Oh, no. One anesthesiologist was, but they weren't on call that day. Cool. So can you call that anesthesiologist and tell them that to put his name on because I can't afford $50,000? I mean, what are we doing? Oh, yeah, you can. So for those who can't hear, what was just said is very appropriate and very accurate. Patients don't know they can advocate, and many patients don't have time to advocate. Forget the patients, most doctors don't have time to advocate. If you think I see 25 patients in a clinic day, and let's be conservative. Let's say 10 of those patients I have to do a peer-to-peer on. When you do the peer-to-peer, many of you may or may not know this, there's a lot of stuff on social media about it. You have to find a time that works for them, and then you have to make sure that they're available, and oftentimes it's when you're in the middle of clinic. Then it sometimes takes few minutes to get that person on the phone. Then you're often not talking to somebody who has the same credentials as you. I've talked to nurses who could not pronounce the drugs that they were denying. Literally, she was like, can you pronounce that drug for me? And I was like, if you are denying my patient this drug, you damn well better be able to pronounce it. And so it's a time issue. It's on the patient side and the physician side. And honestly, people give up. People just give up because it takes too much time, and it shouldn't be this hard. Staying healthy shouldn't be this hard. I'm not even talking about getting treatment. Staying healthy should not be this hard. I saw a hand over here. You're absolutely right. So, the sad thing is, 30 years later, we are now at a point where things have been signed on the dotted line, and we are now in a system that it puts profits over patients. And when you've built a system that focuses on profits over patients, you're never going to put the patients first. And the challenge is doctors put patients first. So I was literally yesterday, I had to leave that awesome second line for a few minutes to go take a call with my cancer center director, or our whole cancer center team. And we had just this conversation about how hospitals around the country are struggling because many hospitals are run by people who don't see the impact of the decisions that they're making. So there's two times that I wish I'd recorded myself on the phone with these companies. Once, I was on the phone and they were denying care to a patient who was going to die if he didn't get his treatment. I just admitted him to the ICU. I got the guy's name and I said, you are going to be famous in about 24 hours because I am calling CNN. And the guy started stuttering, and I was like, I am not kidding. I actually have the phone number of a reporter at CNN, and you just get prepared because you are about to become very, very famous. And the guy blubbered for a second, was like, well, okay, it's approved. So I have no shame for doing that. Just want to throw that out there. Yeah. Send me a separate email. Yep. Yeah. And people don't know that you can negotiate your costs. I mean, when I called back for the self-pay, eventually they ended up bringing my bill down by 50% because I was like, this is nuts. Like, you can't charge me 10 times. And I was able to bring it down. Still not to the self-pay amount, but... Mm-hmm. Well, and this... Absolutely. Well, and part of the challenge is this gets translated then to your mistrust of the healthcare system, which then also gets translated to the mistrust of your doctor. Because people think that doctors are the ones bringing in all that money, and I can tell you that's not happening. So I think, I asked the question, what can we do to fix our healthcare system? You all gave some fantastic things that we can do. At the end of the day, I think when it comes to reimagining our healthcare system, how can we provide care to everybody? We have to put people in power, people in charge who understand what it means to be in that room, having that conversation, telling someone your life is about to change. I tell my trainees all the time, we see thousands of patients. You may not remember every patient, but that patient is going to remember you because you are permanently imprinted on their life. The words you say are incredibly important and have so much power, whether you're a med student, a resident, a practicing physician. And many of the people making the decisions don't understand the gravity of that discussion and how we become imprinted on people's life story. And when money and finances and thinking, I can't pay for this, I don't have time for cancer, and now I'm being told I have to pay $100,000 to get the treatment that's going to save my life. I don't have $100,000. Those aren't conversations that should be happening, but they are because of the way our system is set up. So my solution, one of the many, is we need people who are making the decisions who've been in that room, who've had those conversations, who understand that the decisions that are being made are not just names on a paper. These are people's lives. And we've seen a shift away from physician-owned private practices. We've seen a shift away from physicians in leadership. I'm hopeful that the pendulum will start to shift back, where we start seeing the people who are making the decisions actually be people who have delivered the care and who understand that feeling of being in the room and holding someone's hand and watching them process what you've just told them, and then helping them navigate the next step. And the next step should not be, how am I going to pay for this? The next step should be, how are we going to help you get through this? So we talk about equity principles for cancer: meet people where they are, remove friction, trust, support. Equity must be designed. So what's the responsibility? We fall short where we design without community, where we measure outputs instead of outcomes, when we ignore payment reform, when we treat equity as an afterthought or as optional, or when we expect patients to navigate us. It's not fair to tell somebody your life is about to change, here's a diagnosis, now you go figure out how to navigate this very broken system. So we have to do better. We have to work towards navigation reimbursement. We need food insecurity as standard screening. We need trial communication as routine. We need community partnerships and infrastructure. And we must think about early intervention and prevention. How do we capture patients at the very beginning, before they're even diagnosed? How do we get them in for their colonoscopy, for their mammogram, for their cervical cancer screening? How do we educate that vaccines are the most incredible thing that have ever been developed in the history of medicine? I will stand by that till the day I die. I don't care if we figure out a way to live till we're 500 years old. Vaccines have saved more lives than anything else. And we are throwing all of that amazing knowledge and amazing opportunity away because we are not focusing on what matters. We're focusing on things that put profits over patients. So what do we need to do? We need to ask about transportation, food access. We need to talk about family history, advocate for navigation. So what is the thing I'm sending you all home with today? Equity is modern oncology. We need to think about biology, but we also need to be thinking about access. We need to be thinking about trust, and we need to be thinking about how do we redesign our healthcare systems. Because cancer care should not be dependent on luck. It should depend on the system design that supports our patients, no matter what you look like, no matter your background. We all deserve to be cared for. We all deserve to be treated equitably, and like human beings. And I hope that you leave here not feeling sad, but leave here feeling inspired, because there's so much we can do to fix this system in which we are currently in. It's just going to require all of us to work together to do it. Thank you so much for your time.
We've got a break for about an hour, and then we'll start the afternoon sessions back up. But this break is to go and visit the abstract sessions. The authors of the abstracts are going to be down. It's at the end of the hall where we keep all the abstracts. We have all the abstracts being presented. And lastly, don't forget the crawfish boil, fried chicken at No Late tonight. The bus is leaving at 4:45 in front of the Sheraton Hotel today. So just a reminder.
No, but I'm setting up for I'm chairing this session, so I'm trying to get everybody set. But no, I didn't. Okay.
McKinney. We've met before, but there's so many names and faces.
Oh, I know you're like bombarded with everybody, so yeah.
No, I'm happy to help. Okay, so let's see, where are we at? You're on this panel, or you're chairing the panel?
I'm chairing the panel.
Yes, ma'am.
So,
Let's see. Hey. if you do have that, that's pretty cool. Thumb drive. Dr. Tang. Yes, indeed. Okay. Yes, yes. So he has updated slides. I want to make sure I have his. Oh, they're new. They got the what's it called, USB-C, whatever.
Just send my daughter the version.
Oh,
did you get that version?
Let me delete the one I have, and I'll pop that one.
Right. 10 o'clock because I find it is tiny typo.
This is your previous one. I'm going to just close that. That's done. This is the new one.
Go to the last slide. I know it.
Okay.
Last slide. This one. Yeah, minimal toxicity.
Beautiful. Okay. All right. Then you're all set. Dr. Tang. Yes. Yeah. It does make sense. Yeah, I've been there.
So I'm all set, right?
Yes, sir. Yours is already on the computer. We're good
All right.
to go.
Yeah.
I'm waiting for it to catch up. I'll get it in just a second. So I have two slides. I have one slide deck for Tang and then one for third block replacement for Dr. Taylor. So I didn't know. I'll leave that up to you guys. Y'all want to put it on one up and then the other up. I just okay, and then okay, that's fine. So I have them both labeled as 220 and UC Taylor, and then that's so whatever order you want to do them in, just totally good. And then y'all can just yeah, y'all know PowerPoint. So yeah, this is yes, black, and that's the new indicator. Yes, yes, yeah, that'll be this guy. Yeah, well, I had to plug it back in. You definitely can. We should. No, I don't know that. You might have to. Yeah, yeah, and you can move around. Yeah, and there's a mic too if you need to move. So as y'all are going, what you would do. Yeah, so to do that, right now this is blank. This is screen 2. If you want this on screen 2, just hit down here, slideshow view, and then you get presenter mode, and it's on the screen 2. Yeah. So then when you're ready to transition on your 220, right, so Dr. Tang go the same thing. I mean, it's yeah. So it is when you're ready, Dr. Taylor, same thing. So easy. Yeah.
Did you figure out the other one?
Yeah, she just sent me an updated one, so we can go.
How many is it?
5 total, so we got 2 going out. Let's see, they're doing it in the base. The one
Or did you talk to them about it already?
I did, yeah. So
They all know how to do it?
Yeah, they're gonna. So y'all are gonna do it from the stage, right? Okay. Because I have some of my volunteers doing it. Yeah, well, so just to make sure the process was smooth, I didn't want to leave it up to the speakers who are doing things for work. Yeah, yeah. So if you guys would like to, absolutely, y'all can be on the computer. At least for the 2 slides, I don't want to interrupt the space. But I could definitely have some discussion. Or not at the table. I mean, like station in the room, and then they'll just. Yeah. I don't want to distract y'all. I mean, just move it. But again, it just helps.
Around your program, how many do you see? Roughly. Three per day. By yourself, I can know what the product, but you guys don't see the field, you see the per 15 here, yeah. Yeah, yeah.
Like, I don't know, breast gathering, happy hour.
Right, I came to hear the rock stars talk. Hey, how are you, Judge McKinney? Came to hear this one.
Oh, Lord. Well, luckily I'm not speaking. I've got such great qualified.
Well, there you go. You just get to do the introduction.
I get to do the moderation.
It is so good to see you.
You too. Got 1 minute. You want to come sit here? I'm going to sit in the... Yeah. Okay.
I can move off too if y'all want me to move somewhere.
No. Good afternoon, everyone. We're actually going to start on time. Hopefully, we will end on time. We have a packed, full session with lots of good information. Welcome to the breast session for CAGLA. When Dr. Hendricks and I were talking about what we wanted to kind of present, we decided that we wanted to bring to the forefront several controversial topics that we see in current practice and that are emerging as far as future directions. So we didn't want this to be just giving you information, but really having you think about all the things that you see in practice every day that you struggle with and that we struggle with as clinicians. Even though we're statistically behind the curve here in Louisiana, we are really blessed to have wonderful practitioners and clinicians who stay at the forefront of what is happening, research, clinical, innovation, and trying to get the word out about what is available here in Louisiana for our patients can be rather hard. So I'm happy to have a panel of colleagues that are those experts, and we are going to go in the order of what is presented on the program. Hopefully these topics will spark some discussion. If you have questions, we're going to do panel questions at the end, so write your questions down, please. First up is Dr. Vera Hendricks. We unfortunately lost her to Yale School of Medicine last year, but she is the assistant professor of surgery. She specializes in breast surgical oncology. She is a member of the Center for Breast Cancer at Smilow Cancer Hospital. She completed her general surgery residency at Tulane and breast surgery fellowship at the University of Southern California, following her medical degree from Georgetown University. She is a distinguished scholar. She has advanced training in all of the oncoplastic surgical techniques and is known for her multidisciplinary surgical care. So she will talk to us about a surgical debate in our world as to whether we should be doing more or less when it comes to axillary surgery. Dr. Hendricks.
Thank you all so much for having me. Like Dr. McKinney said, I was here for 10 years throughout residency at Tulane, and I worked at Mary Bird Perkins Cancer Center for 3 years before taking a job closer to home in Connecticut. So I'm very happy to be back. I've only been gone 3 months, so it's nice because it's very cold in Connecticut. Yeah. And I'll be talking about axillary management, surgical management in CT1, 2, and 1 HR-positive, HER2-negative breast cancer. So that's a mouthful, and you'll hear me say it multiple times today. I have no relevant disclosures. Learning objectives that I hope we go over today are defining what sentinel lymph node biopsy is, what targeted axillary dissection is, and what formal axillary lymph node dissection is, comparing the oncologic outcomes, and discussing morbidity of each and quality of life implications. And then hopefully identify current guidelines and recommendations and what to look forward to in the future in relation to all this. And hopefully creating axillary management plans for that early stage hormone positive, HER2 negative breast cancer population that's getting upfront surgery with node positive disease. So this is Dr. William Halstead. He pioneered the Halstead radical mastectomy, which included axillary lymph node dissection. And basically what an axillary lymph node dissection is you're removing level 1 and 2, sometimes level 3 lymph nodes during your surgery, and typically you're getting over 10 lymph nodes in your retrieval. And they were doing that historically as standard of care for staging and for local regional control. There was a lot of morbidity associated with axillary lymph node dissections. Lymphedema rates, which is the arm swelling, was upwards of 30%. You had other complications, including neuropathy, increased cost, chronic pain, reduced quality of life. So that's how sentinel lymph node biopsy kind of came into the picture over the last 30 years and led to a paradigm change. We were trying to do minimally invasive axillary surgery as a staging approach. Using dual tracer, we had low false negative rates, and we reduced morbidity of axillary lymph node dissection. Then came about targeted axillary dissection, or TAD, and that's historically used in patients who had node-positive disease. They were getting neoadjuvant chemotherapy, and they converted to node-negative, or they had a PCR in their nodal, they had a nodal response. And so in order to do this targeted AXE dissection, those patients had a biopsy placed at the time of their pre-op consult. They had a localization, and then they had a sentinel lymph node biopsy as well. And this showed low false negative rates, and this became acceptable instead of offering those patients who converted to N0 a formal lymph node dissection. So lymphedema comparison rates between all three, as I mentioned, axillary lymph node dissection is 30%, sentinel lymph node biopsy and TAD around 5%, and then a significant quality of life benefit with sentinel lymph node biopsy and target AXE dissection. So these, in general, were the indications for axillary lymph node dissection in upfront surgery if a patient had over a 5-centimeter tumor, matted or fixed lymph nodes, palpable lymphadenopathy. In NSABP B18, 28% of patients had 4 to 9 positive lymph nodes, and 23% had over 10 positive lymph nodes if they had palpable lymphadenopathy. Indications for axillary lymph node dissection in the post-neoadjuvant setting are if patients are the size criteria of T4, matted or fixed lymph nodes, if they only had 1 to 2 sentinel lymph nodes identified and they didn't obtain that previously biopsy positive clip node, the false negative rate was extremely high, upwards of 24%, so that also entailed performing an axillary lymph node dissection. And then, of course, if palpable lymphadenopathy persists after neoadjuvant chemo. And then all patients with inflammatory breast cancer also had axillary lymph node dissection. So in summary, all clinically node-positive patients historically required a formal lymph node dissection. There was de-escalation through the use of sentinel lymph node biopsy and TAD, particularly in patients with clinically node-negative, limited nodal disease, so only 1 or 2 sentinel lymph nodes positive that were getting upfront surgery and then adjuvant systemic treatment and radiation. And then also in the setting of node positive that converted to node negative with neoadjuvant chemo. But what about the node positive patients that are HR positive, HER2 negative? The management of that is very complex, it's evolving, and it's complicated because most of those patients don't respond to neoadjuvant chemo, and they have low nodal PCR rates, less than 20%. So this is the NCCN guidelines, and you can see outlined in red are for patients who have clinically palpable lymph nodes. They get a biopsy, it comes back positive, and they're not getting preoperative chemo, so they're getting upfront surgery. Those patients typically will get an axillary lymph node dissection, even if they have limited nodal disease. If you look at the second line where it says no palpable lymph nodes, but axillary suspicious imaging and maybe 1 or 2 lymph nodes that are biopsy positive, they can undergo a lymph node biopsy. So that's the difference between image detected suspicious lymph nodes that are biopsy proven and palpable lymph nodes biopsy proven. And they have 2 different managements. So this just goes further into de-escalation of axillary surgery. On the left side, we had axillary lymph node dissection where we took a multitude of lymph nodes, and then we had a lot of landmark trials, including Z11, Amaros, Cenimac, that showed that we can do sentinel lymph node biopsy in clinically node-negative patients, and we don't have to go on and do a completion axillary lymph node dissection if they had only 1 or 2 lymph nodes positive. And then the far right pictures, targeted AXE dissection, that talked about clinically node-positive patients converting to node-negative after neoadjuvant chemo. These are just the clinical trials more in depth and whether they randomized patients to sentinel lymph node biopsy or axillary lymph node dissection or axillary radiation therapy versus axillary lymph node dissection. So all of these landmark trials omitted axillary lymph node dissection as standard of care for the clinically node-negative patients getting upfront surgery, but they excluded clinically node-positive N1 patients. So if you remember the NCCN guidelines, that top line is extrapolating from these clinical trials like Z11 and Amaros criteria, T1 to clinically node 0, undergoing upfront surgery with very limited sentinel lymph node positivity, and they're putting it towards technically CN1 patients. This slide is just a summary, and it goes into the novel technique now, which is targeted axillary surgery. And that I'll talk a little bit about in the TAXUS ongoing clinical trial that came out, that started in 2024. So, in summary, clinical node-positive breast cancer management, like I said, CN1 is technically defined as image-detected or palpable lymph nodes. Upfront surgery is possible in select hormone-positive, HER2-negative breast cancer because of that low rate of nodal PCR. If they don't have a PCR after undergoing neoadjuvant chemo, usually they will get an axillary lymph node dissection. In the neoadjuvant chemo setting for node-positive breast cancer, usually HER2-positive and triple-negative will all get neoadjuvant chemo. And then in terms of hormone-positive, HER2-negative, it depends on other factors. So our exponder was addressing the ability of a 21 gene recurrence score to predict survival benefit from chemotherapy in patients that had 1 to 3 positive lymph nodes, so N1, with hormone-positive, HER2-negative breast cancer. It randomized 5,000 women with T1 to T2 tumors and a recurrence score less than 25 to endocrine therapy or chemotherapy in addition to endocrine therapy. And it showed that there was no survival benefit in the addition of chemotherapy to endocrine therapy in postmenopausal women. So if you extrapolate that, you can think that the use of neoadjuvant chemo for axillary downstaging alone is not warranted, for example, in that population I had just mentioned. Systemically, Monarchy was another trial that looked at kind of more compelling evidence towards doing more axillary surgery. It randomized 5,000 women, high risk, with hormone-positive, HER2-negative patients to get adjuvant endocrine therapy alone or with a CDK4/6 inhibitor, abemaciclib, along with the endocrine therapy. And it basically showed a significant disease-free survival with the addition of abemaciclib to endocrine therapy. So there were concerns about undertreatment among those patients that had a low Oncotype score who may benefit from chemotherapy only based upon nodal disease. Then the NATALEE trial came out, and that was looking at ribociclib plus endocrine therapy, and that showed basically it was applicable to node-negative and node-positive patients. And so in turn, systemic decisions should be based on nodal information that you have available and try to avoid unnecessary axillary lymph node dissection. This is the ASCO guidelines from 2025, and if you look at the outline box here, you can see clinically node-positive patients that are going upfront surgery. The standard of care is axillary lymph node dissection. But which patients with hormone-positive, HER2-negative, CN1 breast cancer can we safely limit axillary surgery? So these are 3 studies that actually showed 50% of CN1 HR-positive, HER2-negative breast cancer have only 1 to 2 lymph nodes that are positive. If upfront sentinel lymph node biopsy is standard of care for CN0 with 1 to 2 positive lymph nodes, can upfront TAD be applied to CN1 patients with a limited nodal burden, less than 3 lymph nodes? And so this just showed some of the predictable factors of what could cause a patient to have higher nodal burden, like a higher T stage, so a larger size of their tumor, was a predictive factor in most of the studies. This also shows these other significantly associated factors of having a higher nodal burden of 3 or more positive disease. If a patient was less than 60, if there was lymphovascular invasion, if there was a history of recurrence, a mastectomy, the larger tumor size that I mentioned, and then a shorter tumor to nipple distance was also important. This is the TriNet-X study. It was a US collaborative network retrospective study that looked at 140 million patients across 106 healthcare centers, both academic and community. The inclusion criteria was anyone over 18 with CN1 disease, hormone positive, getting a sentinel lymph node biopsy versus an axillary lymph node dissection, and it showed the 10-year overall survival was equivalent between those with CN1 disease getting a sentinel lymph node biopsy or an axillary lymph node dissection. This is the TAXUS trial. It's an international randomized controlled trial of patients with node-positive breast cancer, either undergoing neoadjuvant chemo or upfront surgery with the targeted axillary surgery, the TAS, which is that new novel term. And they were randomized to completion axillary lymph node dissection or axillary radiation therapy. And so there was a cohort within this study that was a prospective observational cohort that actually underwent upfront surgery, and you can see on the bottom they either underwent axillary dissection or axillary radiotherapy, and so the data is still ongoing because they're still recruiting, but you can see in the upfront surgery group the factors that were associated with additional positive lymph nodes on axillary lymph node dissection was the number of positive nodes they had on TAS, and if there were palpable lymph nodes to begin with. MD Anderson did a retrospective single institution study looking at patients between 2001 and 2021 that had upfront surgery with axillary lymph node dissection. They all had positive axillary ultrasounds and biopsy-proven nodal METs. If they had more than one suspicious lymph node on axillary ultrasound, that was most predictive of having a higher nodal burden, and 30% with one suspicious lymph node had greater than N2 disease. So they concluded that pre-op imaging, including axillary ultrasound and MRI, can predict the evidence of nodal METs, but it's inaccurate in letting us know the extent of the nodal burden. This is another NCDB analysis that showed kind of 5-year overall survival rates between sentinel lymph node biopsy and adjuvant radiation versus formal axillary lymph node dissection in our patient population that we're looking at getting upfront surgery between 2010 and 2016. And it showed that there was a similar overall survival, so kind of favoring less is more. There are 3 prospective randomized clinical trials that are ongoing right now at MD Anderson, MSK, as well as the TAXA study I mentioned, looking at the accuracy of doing upfront primary TAD in our patient population. So there are some preliminary results from the MSK prospective trial. They had 78 patients with T1-2 size, hormone positive, HER2 negative, CN1 positive, and they actually just did palpable positivity, not just image detected. And on axillary ultrasound, they had to have less than 3 abnormal or suspicious lymph nodes. And these patients had upfront surgery and a sentinel lymph node biopsy. They were randomized if they only had 1 to 2 positive lymph nodes to no completion axillary lymph node dissection, and if there were greater than 3 positive lymph nodes, they had a formal completion axillary lymph node dissection. In their relatively short follow-up, which is less than about 12 months, they saw no isolated axillary or local regional recurrences. So in summary, the MSK trial actually, the preliminary data supports use of upfront sentinel lymph node biopsy or TAD in our patient population as long as they're getting pre-op axillary ultrasound, and it showed that it avoided axillary lymph node dissection in 70% of patients. You did have to remove the palpable lymph node during your sentinel lymph node biopsy. That was one of the main criteria. And it also minimized the morbidity that we all know of axillary lymph node dissection. But we do need more long-term follow-up to determine the local regional failure rates. So if you are a breast surgeon, you know that the American Society of Breast Surgeons is basically our Bible. So I had to include a slide from their most recent resource guide in 2026 looking at axillary management. So the top one is kind of referring to that NCCN chart that I showed previously, but if you had a clinically node negative, palpably node negative patient that had abnormal suspicious axillary imaging and or a positive biopsy, you could technically do a sentinel lymph node biopsy, and they showed that 50% of those patients with a positive lymph node on biopsy only had 1 to 2 positive sentinel lymph nodes, and they avoided axillary lymph node dissection. In the second point, in clinically node positive, palpably node positive patients, biopsy proven that were getting upfront surgery and ineligible for neoadjuvant chemo, axillary lymph node dissection was the appropriate care. And that's because the palpable lymphadenopathy, usually those patients had higher volumes of nodal disease. So in final conclusion, CN1, hormone positive, HER2 negative breast cancer, we all know neoadjuvant chemo is suboptimal, low nodal PCR rates less than 20%, rare axillary downstaging, 80% will end up with an axillary lymph node dissection and possibly lymphedema. The S2206 study is ongoing, and it's looking at MammaPrint high-risk 1 patients getting upfront surgery. So that's something we will have more information as it comes about. Upfront TAD in select patients with limited nodal disease burden may prove to be a better option and have less morbidity and similar oncologic outcomes as formal axillary lymph node dissection, but we need accurate pre-op imaging, and we need intra-op consistency because it's very subjective between when surgeons are doing sentinel lymph node biopsy, target axis dissection, and this novel TAS, target axillary surgery. And of course, we have to have multidisciplinary tumor board discussions and consensus with everybody, because when the breast surgeon de-escalates something, the radiation oncologist or the medical oncologist may not be able to de-escalate in their area. So we have to have a tailored approach to each patient in each case. Thank you for allowing me to speak on this topic. I look forward to any questions. This is my daughter. She's 3, and she always hears mommy is going to clinic or to surgery, so this is her version of going to surgery in her Disney princess dress with her dolls and her grandfather escorting her out. So it just shows you anything's possible.
Thank you so much, Dr. Hendricks. You know, we as surgeons are often viewed as just a technician. You know, after your medical oncologists do what they're going to do or not do what they're going to do, then just send them to the surgeon, and the surgeon will do whatever they do. But, and surgeons historically don't like to be told what to do. Of course, that's not us. But you know, this multidisciplinary approach is extremely important. For our patients, this is an ever-moving kind of target for us. And what really hangs in the balance is patient morbidity. We know that their risk for lymphedema is a lifetime risk. That's something that they constantly have to worry about. And it should be on our minds as surgeons as well to reduce that risk as much as possible. So every patient really deserves and needs an individualized treatment plan, approach, multidisciplinary consensus. So if your surgeon is not involved in that process, please make them involved in that process, because coming up and asking them, are you planning to remove a couple of nodes or all the nodes, you know, can make a difference in, you know, patients 10 years, 20 years from now. So in moving on to our next speakers, we have the dilemma of looking at ADCs and really trying to figure out the efficacy versus the toxicity of these new emerging agents. And breast is always developing new drugs. We have a lot of funding, and every 6 months it seems like, or less, it seems like some new drug is coming out, and it is. It keeps them on their toes, but it also keeps everybody else who's a part of the team on their toes. So Dr. Tang, who many of you know, and I have had the pleasure of working with him not only here at LSU, but also at the University of Mississippi Medical Center. He is a world-renowned researcher. He leads our phase 1 trials over at the Cancer Center at University Medical Center. He is certainly a board-certified medical oncologist, but has particular interest in bringing newer modes of treatment and targeted therapies to those who need it. He is well, I guess your title is professor of oncology here at LSU. And as you see on your program that Dr. Locke is supposed to be the counterpart in this pro and con in talking about ADCs. But just like everybody's filling out their brackets and replacing, we have a wonderful, wonderful stand-in who is Dr. Taylor, and she is representing the con side of ADCs and how we should be using them. She is a board-certified medical oncologist at Ochsner Health. She specializes in breast cancer treatment, completing her fellowship at Emory University. She is currently the Associate Program Director at Ochsner and is actively involved in training the next generation of oncologists. Her clinical focus is on outcomes and making sure that outcomes for her patients are beyond par. So I will have them come in that order, Dr. Tang and then Dr. Taylor.
So this is the advanced, right?
Mm-hmm. You wanna, yeah, exit.
Thank you. Thank you. I want to thank the organizer for inviting me to speak. Of course, I want to thank Dr. McKinney for your kind introduction. So today, I'm going to talk about a controversial issue, that is, do you need a biomarker to offer patient antibody drug conjugate or ADCs? So I'll represent the con side, while Dr. Taylor will talk about the pro side. And this is a very controversial topic, of course, and many of my talks are based on my own research. Some of them are not published. So before my talk, I want to do a quick poll and to see how you feel about whether we should use biomarker to offer ADCs. And I'll give you 3 options. And the first is we should test everybody in order to offer ADCs. Let's see a show of hand. Should we measure biomarker? Well, second choice is no, we don't need biomarker. We can offer ADC to anybody. Let's see a show of hand. Okay, I guess everybody go for the third option then, that is maybe, which is obviously what I'm going to recommend. I'll tell you why. So I'm glad we got a consensus already, but unfortunately I still have 15 minutes to give. So when I was doing my PhD over 40 years ago, my thesis was to clone a gene which requires raising many monoclonal antibodies. At that time, after we raised all these monoclonal antibody, we thought, would it be nice to attach a toxin to the monoclonal antibody so we can use it as a magic bullet to kill the cancer, specifically the one that expresses certain biomarker. So of course, nowadays, those dreams in the lab have come to fruition. We have a lot of ADCs on the market now. The way ADC works is that we have a monoclonal antibody against the biomarker. Now attached to the monoclonal antibody is a payload or toxin through a linker that makes the payload inactive until it reaches the tumor, enter the cell, and the linker gets cleaved, and the payload release. It kills the tumor in a suicide fashion. This is how ADC works. And of course, TDM1, as you know, in breast cancer, is one of the first modern ADC developed. I was fortunate to be one of the co-investigators who studied this drug through the media trial. Of course, it is a Herceptin linked with the EM-tensine through a non-cleavable linker. And this is how ADC works for Kadcyla. Of course, through the trial, we know that this drug fulfills the requirement of ADC. That is, it is not very toxic because the payload is only released inside tumor cells, not systemically. Therefore, it has minimal toxicities. But then we asked the question, even with Kadcyla, we still see some toxicities. It should be toxic-free. Where does that toxicity come from? See, since I was one of the PIs, we did more research, and I thought perhaps the free payload got released after cell broke down, and it released the payload into the blood, which caused toxicity. That's the only place where the free payload could come from. If that is the case, I further hypothesized we should see a correlation between toxicity of TDM1 and the degree of tumor response, and then patient survival. So we did a multinational study involving Canada, where I trained my PhD from, and Georgia and Mississippi. We collected tissue of the patient who received Kadcyla and see if we can correlate their toxicity with their survival. Of course, it's a positive trial. Indeed, if you look at on the left side, if you have higher toxicity, we have toxicity sum score, where we sum up all the toxicity from the liver, from the blood, and others. We make a toxicity sum score. And this sum score is highly correlated with the survival. If you have a toxicity 2, your survival is longer than patient who only have a toxicity 1. If you look at the right side, if you have toxicity 3, patients survive even longer than toxicity 2. Again, confirming our hypothesis that for TDM1 with a stable linker, the toxicity is actually good for longer survival or response. Now, we have a conundrum now, because we know that of many ADC out there, Some are less toxic, such as Kadcyla, some are more, such as HER2. And some ADCs require biomarker testing, while others don't. It doesn't make sense. Why don't we have a uniform approach? If an ADC, you go for a biomarker, this should be toxic-free, right? So those are our current conundrum. Indeed, this is from my unpublished data. It's being published, by the way. If you look at all the current available ADC on the market, half of them require biomarker testing with the companion diagnostic test. The other half in the bottom do not. Why? It's ADC. You've got to measure the biomarker, right? That's how monoclonal antibody works. So again, when you go back to the original HER2 trial, that's the Deslin Breast 01 trial, when it was published as a phase 2 data in San Antonio, I was impressed not only with its efficacy, but also with its toxicity. I asked why? Why are we seeing toxicities? And in fact, when you compare the Kadcyla's toxicity, as you know, its payload is TDXD, which is a topoisomerase 1 derivative. Its toxicity is actually more than its parent drug, such as topotecan, irinotecan. Why? This is a daughter drug. Why it is more toxic than the parent drug? That's my further question. And indeed, when I compare the two drugs, TDXD and Kadcyla, one has, they are both targeting HER2 as a target. One drug has a lot more toxicity compared to the other. Again, you ask why? They are both ADCs. So our hypothesis is that, perhaps, it is the linker. Because when I compare the linker, TDXD has the tetrapeptide linker, which is cleavable by peptide disc, whereas Kadcyla has a non-cleavable linker with a ether linker. So our hypothesis is perhaps, with the cleavable linker, you release more payload before the ADC even reach the tumor. Therefore, you have a higher free blood concentration. As a result, you would have more toxicities. Number two, since you have a lot of free payload in the blood, you probably don't even need a biomarker to act, which you don't even need a HER2 to be effective. And finally, of course, we look at the survival. Our hypothesis is that perhaps those ADCs with a cleavable linker should have more efficacy and result in longer patient survival. So that is our original hypothesis. We actually proposed this, several years ago. We were the first in the field to propose this hypothesis and published the data in ASCO, again, through a meta-analysis where we divided all the ADC in two groups, 11 of them. One group with the cleavable linker, the other group with the non-cleavable linker. We asked those three simple questions. Does the different groups have different free payload in the blood? Number two, do they have more toxicity or less? And number three, efficacy, which we couldn't determine because this is a retrospective meta-analysis. This is from the study showed indeed, it fulfilled our hypothesis that those with the cleavable linker have higher free half-life or free payload in the blood, and they actually are more toxic. So we chased up that study with a subsequent systemic review and meta-analysis. And this is just published last year. And this meta-analysis basically represented two systemic reviews. And we searched all the publications of ADCs in the literature. And it represents 40 clinical trials with 11 drugs, FDA-approved drugs, representing 7,000 patients in each arm. And we asked, again, the same question. Do these two groups have different free payload? The answer is yes. Those with the cleavable linker have a lot higher free payload in the blood. Number two, which one has more toxicities? Of course, the answer is yes. Those with the cleavable linker have a higher degree of systemic toxicity. Even if we factor in the DAR, which is the antibody to drug ratio, and it still shows that those with the cleavable linker have higher toxicities. So the conclusion from our own research is that, indeed, ADC with cleavable linker are associated with significantly higher serum-free payload concentration and systemic toxicities. And also, ADC with the cleavable linker would act in the biomarker independent matter because you're going to kill the tumor with the free payload rather than with ADCs. Whereas those with a stable linker kill the tumor in the biomarker-dependent matter. So, of course, our observations were subsequently confirmed with additional study, both clinical and preclinical. DAISY trial look at the same question about the activity of Enhertu in HER2-positive tumor, dividing them up in HER2 3+, 2+, 1+. It shows consistent activity of Enhertu even in patients with HER0 population, about 30%. Showing that even if you don't have target, Enhertu still works. Of course, the final proof that nailed the coffin is this study that was published from a Yale group, that was published in Nature last year. They proved conclusively with a preclinical study, indeed, Enhertu is actually cleaved before it even reached the tumor. What study shows that, in fact, T-DXd in HER2 low and even HER2 negative breast tumor is independent of the HER2 expression. And you don't need a HER2 for the T-DXd to be internalized and kill the tumor. In fact, where does it get cleaved off? In the tumor microenvironment. In fact, as you know, when tumor breaks down, they release a lot of proteases. Most T-DXd were cleaved in the microenvironment before they reach the tumor by cathepsin L. So as a result, they release the payload before they even reach the tumor. And to follow up additional observation from the preclinical trial, again, a group from Yale is actually doing a phase 1 study to confirm clinically whether it's the case, because we now proved preclinically you don't need a HER2 for HER2 to act. So they're going to do actually a study looking at HER2 0 population and offer those patients HER2 and see if they indeed respond. This is a bold movement, but based on preclinical study from their own group and also based on DAISY trial. So I think this will be a very interesting study to follow. So coming back to my initial question, do we need a biomarker to offer ADCs? The answer, to me, rely on the linkers. So it is, yes, you need a biomarker if you have a non-cleavable linker, but you don't if you have a cleavable linkers. Of course, there are many other factors that determine the efficacy of ADCs, including antibody binding affinity of ADC to the biomarker, drug-to-antibody ratio, or DAR, mechanism of action of the payload. You are going to offer the patient a payload that has no cross-resistance with the prior ADCs, talking about ADC sequencing. More importantly, membrane permeability of the payload also play a role because they cause the so-called bystander killing. And finally, ADC induced tumor killing by ADCC through the immune system. So this is how I think we can put together how ADC would work, which is, again, being published. On this side shows the ADCs with a non-cleavable linker where you got to have a biomarker to get in the tumor cells to be released, to release the payload inside tumor cells. Whereas on the right side are those ADCs with a cleavable linker, where the linker got cleaved up actually before they even reach the tumor, and the free payload get into the tumor to kill the tumor. So this is how those two groups of ADC works. And talking about next generation of ADCs, we know that ADC with a cleavable linker, they probably are more potent, yet they are more toxic. And those with a non-cleavable linker, they may be less potent, but of course they are much safer. So how to strike the balance, which is the theme of our discussion here. So I always say ADC linker is a double-edged sword, So therefore, to approach this balance or to increase the therapeutic index of ADCs, there are several factors we can take advantage of. One is tumor microenvironment, because we know that in tumor microenvironment, their condition is different from normal tissue, where it's more hypoxic, more acidic, and has more proteinase, where the tumor cell break down. And therefore, we can take advantage of this to generate what we call microenvironment specific or conditionally released linker, where the linker will be released in the microenvironment but not in the blood. So there's a novel generation of ADC being generated, and they include, of course, the novel payload that act cross-resistant to prior chemotherapy. There's site-specific conjugations. These bispecific antibody where they can actually target two antigens, or novel payload, or even dual payload. The ADCs can carry two payload, instead of one type of payload. And you even have a peptide drug linker ADCs where you can target the intracellular proteins rather than membrane proteins. And this is a summary of what they call ADCs with conditional release linker, what we call second or third generation. And those are linkers that are released by special protease-sensitive linkers, acid-labile linker, reducible linker, beta-glucuronidase linkers, double lock linkers, and iron labile linkers, and finally, even photosensitive linkers, where you just shine a bead of light to the tumor, and linker will be released in that spot, not nobody else. It will be very specific to target tumor, but not the systemic circulation. And finally, this is the slide I put together in terms of how we think the ADC works. Basically, if you have a conditionally released linker, and the linker will be released in the tumor microenvironment, then they'll enter the tumor cells by the free payload without the biomarker. So therefore, you can enhance the derivative payload to the tumor, but not to the blood cells. So I want to summarize what I discussed so far. And targeted therapy, of course, requires biomarker testing if you do have a biomarker targeting agent. And controversy exists in biomarker testing in order to identify tumors that are suitable for ADCs. And ADC with a non-cleavable linker, of course, function in biomarker-dependent manner, while those with cleavable linkers, they function in both biomarker-dependent and independent manners. And of course, what we need is novel strategies to optimize ADC designs with the maximal efficacy and minimal toxicities. So on that note, I'll finish my presentation. I was going to do another poll to see if I have swing your opinion after my talk. Since everybody went for maybe, I think I've done my job. Thank you.
Okay, that's going to be a tough act to follow, Dr. Tang. So I'm Caitlin Taylor. I am a breast medical oncologist at Ochsner. I'm standing in for Michelle Locke today, so thank you all for having me. And I am going to be talking about antibody-drug conjugates and arguing for the pro-biomarker side of things here. So we'll see how I do. These are my disclosures. So this slide really frames the central question of our debate. And I would say that biomarkers are not just useful for antibody-drug conjugates, but really they're essential for optimizing patient selection and really understanding who benefits most. So biomarkers that we are currently using and ones that we may use more in the future, let's go through some of those. So first, antigen expression, so things like HER2 and TROP2. HER2 expression is the most established biomarker for ADC selection. HER2 IHC and ISH guide TDM1 and TDXD selection, while TROP2 expression is relevant for sacituzumab govitecan, though not yet required for prescribing. mRNA, or protein quantification. So beyond simple IHC scoring, quantitative approaches like HER2 mRNA expression are showing promising results for really refining predictions of ADC response. The tumor microenvironment. So there's emerging research here that shows us that immune signatures, so things like PD-L1 expression, B-cell signatures may influence ADC efficacy. And then ADC treatment response scores. So I think really this is probably where the field is heading looking into the future. But these are composite, multidimensional biomarker scores that integrate antigen expression, tumor biology, the microenvironment, really combines all the things we've spoken about to predict who benefits the most. Why do we need biomarkers? So predicting the likelihood of response, to help us limit toxicity in biomarker low subgroups. Again, really understanding, who's going to benefit the most, who is not, and helping those patients potentially avoid toxicity. Combating resistance mechanisms, optimizing sequencing and novel combinations, enabling adaptive trial designs, and then, of course, the most practical matter is coverage by insurers. So currently, payers require biomarker documentation. For example, without HER2 status, you're not going to be able to get T-DXd approved as of now. So let's get into the data a bit. I'm going to present clinical trial evidence showing survival benefits stratified by biomarker expression for the 3 major antibody-drug conjugates. So we'll talk about T-DM1, T-DXd, and sacituzumab govitecan. Catherine was practice-changing. So this established T-DM1 as the standard of care for HER2-positive early breast cancer patients with residual invasive disease after neoadjuvant therapy. Beyond the headline results of this, Catherine actually generated some biomarker data that I will get into. This is the intention to treat analysis for invasive disease-free survival. And you can see at 7 years, T-DM1 achieved 80.8% invasive disease-free survival versus 67.1% for trastuzumab. This was an absolute difference of 13.7%, and you can see those curves stay nice and separated going out to 10 years, showing that this really shows durable disease control in the curative intent setting. Here's the overall survival curves. Overall survival was 89.1% with T-DM1 versus 84.4% with trastuzumab, a difference of 4.7%. And really, in the adjuvant setting, demonstrating an overall survival benefit can actually be challenging because many of these patients are cured regardless of which arm they are in. So the fact that Catherine showed this really speaks to the magnitude of its effect. So the question is, this raises the question of, did everyone benefit equally? Or did biomarker status influence who got the most out of T-DM1? So this was the companion biomarker analysis from Catherine. And here, investigators looked at HER2 expression by IHC and ISH, HER2 gene copy number, HER2 mRNA expression, and multiple immune gene signatures to determine which factors predicted benefit from T-DM1. So what you'll see here is that even among a HER2-positive population, there is a lot of heterogeneity there. So again, this is just digging into the variance of HER2 expression level and response to T-DM1. So you can see towards the top that patients with IHC of 3+ had a robust benefit. The hazard ratio was 0.43. If you look at the patients with IHC 2+, the hazard ratio is 0.83, and the confidence interval crosses 1. And then with IHC 0 or 1+, the hazard ratio was less than 0.01. It's a very wide confidence interval due to small numbers and few events. Further down, you can see that patients with homogeneous HER2 staining had more of a benefit than those with heterogeneous expression. And similarly, lower than that, HER2 gene copy number that was greater than or equal to 6 showed more benefit than those who had a copy number greater than 4. This forest plot examines whether mRNA expression levels predicted a differential benefit from T-DM1 versus trastuzumab. So patients with above median HER2 mRNA had a hazard ratio of 0.30, showing a dramatic benefit, while those with below median still favored T-DM1, but the effect was more attenuated in that group. If you look further down, they look at some of the immune-related biomarkers, so PD-L1, CD8, T effector signatures. And across the board, you can see that T-DM1 benefit is seen in both the high and the low subgroups, but the magnitude of benefit does vary. So these data really support moving beyond simple IHC testing to potentially more sophisticated biomarker assessments to help us tease out who is most likely to benefit from ADC therapy. This figure is showing invasive disease-free survival stratified by HER2 mRNA expression. And in the trastuzumab arm, so the trastuzumab arms are the red and then the gold color, and then the TDM1 arms are the blue. So you can see that HER2 in the trastuzumab arm, that the HER2 mRNA level was strongly prognostic, and that high expressors actually did much worse, while those in the TDM1 arm did much better. That may seem a little counterintuitive at first, but this dramatic response to the TDM1 and the high expressors has to do with the mechanism of action of TDM1, as Dr. Tang walked us through. Higher receptor density leads to greater drug internalization and intracellular payload delivery. So TDM1's mechanism of action is critically dependent on HER2-mediated endocytosis. So really this high HER2 mRNA group identifies a higher risk group that would derive exceptional benefit from TDM1 rather than just trastuzumab alone. So now let's look at similar biomarker data for TDM1 but in the metastatic setting. So TERESA was a phase 3 trial of TDM1 versus treatment of physician's choice in heavily pretreated HER2-positive metastatic breast cancer patients who had received at least 2 prior lines of HER2-directed therapy. This study provided biomarker data in the metastatic setting, complementing what we saw in KATHERINE. So here in A at the top, you can see that patients with HER2 mRNA greater than median had significantly better PFS with TDM1 at 7.2 months versus 3.4 months, compares with those who had less than median expression. Further down in B, you can see that they also assessed PFS by PIK3CA mutation status and found that TDM1 benefit was similar regardless of PIK3CA mutation status, which is a critical distinction from other HER2-targeted therapies. So this 2023 publication examined ERBB2 mRNA expression as a predictor of TDM1 efficacy in advanced HER2-positive breast cancer. HER2DX is an emerging genomic tool that quantifies ERBB2 mRNA expression, and so this study asked, can mRNA levels predict response, PFS, and overall survival with TDM1? So essentially, if IHC and FISH are telling us if a tumor is HER2 positive, mRNA quantification is able to tell us how positive. Panel A, I know this slide is sort of busy, but panel A shows us that mRNA correlates with IHC. So the left panel shows ERBB2 mRNA expression and how that increases across IHC categories as you go from 0 to 1+ to 2+ to 3+. And so it validates the fact that mRNA quantification captures the same biology. Panel B shows that mRNA predicts response. Patients who had partial response or complete response had significantly higher ERBB2 mRNA than those with progressive disease. And then panel C and D look at PFS and overall survival by mRNA groups. And you can see the curves show dramatic separation between those with high ERBB2 mRNA versus those with median versus those with low. So the same pattern holds for overall survival. And then finally at the bottom, this just confirmed that the benefit on TDM1 held when TDM1 was used in earlier lines. So when they restricted it to looking at patients receiving TDM1 in the first through the third line, the results looked similar. So this was not just a late phase phenomenon that was seen. Okay, so we're going to move into TDXD. DESTINY-Breast06 was the pivotal trial that established trastuzumab deruxtecan, TDXD, in HER2-low metastatic breast cancer. So this trial fundamentally changed how we think about patients with HER2-positive disease. It asked, can patients with HER2-low expression, so IHC of 1+ or IHC of 2+ that was ISH negative, benefit from HER2-directed antibody-drug conjugates? And the answer is yes, but the degree of benefit varied, as we'll see. This looks at PFS across subgroups, so HER2-low and HER2-ultra-low populations. And you can see panel A, it looks at the HER2-low population, and you can see that the TDXD achieved a median PFS of 13.2 months versus 8.1 months with chemotherapy. This was a 38% reduction in the risk of progression or death. In panel B, this is the intention to treat population, so this included HER2-ultra-low, and it showed really similar results. Panel C is the ultra-low population, so patients who had an IHC that was greater than 0 but less than 1+, and median PFS here was also shown to be beneficial, 13.2 versus 8.3 months. So you'll see, notice the pattern here, as HER2 expression decreases, the hazard ratio did move towards 1. So essentially the benefit decreases with lower expression. This is the subgroup analysis from DESTINY-Breast06, and it shows how TDXD benefit varies across patient and tumor characteristics in the HER2-low population. So really the HER2 expression level is sort of the key row here, but you can see that for patients who were IHC 1+, they had a hazard ratio of 0.74. IHC 2+ had a hazard ratio of 0.43, so nearly twice the relative benefit. And then, of course, patients with higher HER2 expression had even more benefit. Further down, patients who had received prior CDK4/6 inhibitors still had benefit, as well as patients with liver metastases. So across the board, you can see that really every subgroup did favor T-DXd, but the magnitude did vary substantially. DAISY was a phase 2 trial that prospectively evaluated T-DXd across the full spectrum of HER2 expression, including patients who were HER2 negative, so IHC 0 tumors. And patients were divided into 3 cohorts. Cohort 1 were the HER2 overexpressing or 3+ patients. Cohort 2 were HER2 low, and cohort 3 were the HER2 non-expressors or IHC of 0. So this was really the first trial to systematically test whether T-DXd works even in truly HER2 negative disease. And so here you see the 3 waterfall plots. Cohort 1, the HER2 overexpressors, of course, had the deepest response. Their response rate was 70.6%. Cohort 2, the response rate was 37.5%. And cohort 3, it was down to 29.7%. So again, the response rate drops by half as you move from HER2 high to HER2 low, and then drop even further as you get into HER2 0. So biomarker expression here directly correlates with the likelihood of response. Panel B at the bottom looks at the PFS curves, and we see a similar pattern. Essentially, as patients decrease in HER2 expression, so does their benefit. You can see that about 30% of HER2 0 patients did respond, and this is likely due to bystander effect or other heterogeneous expression of the disease. So now we're moving into sacituzumab. So ASCENT was the phase 3 trial that established sacituzumab govitecan in metastatic triple-negative breast cancer. And this is the biomarker analysis that was published along with it that examined whether TROP2 expression predicts benefit. So sacituzumab govitecan targets TROP2, which is highly expressed in most triple-negative breast cancers. But the question here is, does the level of TROP2 expression matter for outcomes? Investigators stratified patients by their TROP2 H-score. So high scores were greater than 200, median 100 to 200, and then low was under 100. Panel A shows us PFS by TROP2, and you can again see the separation of the curves here. TROP2 high patients had a median PFS of 6.9 months. Median TROP2 scores had a PFS of 5.6 months, and then low was 2.7 months. The chemotherapy curves, of course, were all clustered at the bottom. And then panel B shows this broken down by overall survival, and the same pattern holds here. This figure shows objective response rates stratified by TROP2 H-score. And again, TROP2 high score patients have a response rate of 44% with sacituzumab govitecan versus just 1% in the treatment of physician's choice group. So an excellent clinical benefit. For TROP2 medium patients, response rate was 38%, and then TROP2 low was down to 22%. So yes, even TROP2 low patients did better with sacituzumab govitecan than with chemotherapy, but the magnitude of benefit was substantially less. So I think in the real world, where we have limited resources and real toxicities from some of these medications, I think biomarkers can help us prioritize and personalize treatment options. So current FDA approvals. T-DM1 is approved for HER2-positive early breast cancer in the adjuvant setting for patients who have residual disease after neoadjuvant therapy, and for HER2-positive metastatic breast cancer. Both of these indications require HER2 positivity by IHC 3+ or ISH amplification. T-DXd is approved in combination with pertuzumab for first-line HER2-positive metastatic breast cancer, and as monotherapy for HER2-positive patients after prior anti-HER2 therapy. So here again, the FDA currently requires biomarker testing. Sacituzumab govitecan is approved for metastatic triple-negative breast cancer after 2 or more prior systemic therapies, with at least 1 in the metastatic setting. One note I'll make here is that based on ASCENT 03 and 04, NCCN guidelines have actually been updated and now list sacituzumab plus or minus pembrolizumab as category 1 for triple-negative breast cancer in the first-line metastatic setting, but this has not gotten FDA approval yet, although I suspect this is coming. It's also approved for metastatic hormone receptor positive, HER2-negative breast cancer after endocrine-based therapy, and at least 2 additional lines of treatment in the metastatic setting. So in summary, antibody drug conjugates have transformed breast cancer therapy. TDM1, TDXD, and sacituzumab govitecan have all demonstrated survival benefit in their respective populations. Biomarker-guided therapy does not limit our options, but I would argue informs our treatment selection to help us make safer and more precise treatment decisions. And I think the field is moving towards multidimensional biomarker assessments, things like mRNA quantification, looking at the tumor microenvironment, and other signatures like these treatment response scores. And then lastly, there is the more practical issue of insurance approval and the fact that insurance requires biomarker documentation for coverage for some of these agents is the current reality that we are in. And that is all I've got. Thank you all.
Thank you, Drs. Tang and Taylor, for giving us a really thorough explanation for ADCs and bringing it back to the practical. You know, we have all of these great drugs that are coming out, but our insurance agents, are they going to pay for them for our patients to benefit? We can talk about treatment for 2 hours. I mean, each one of these talks could have their own hour or 2-hour discussion. I am going to introduce our next speaker in the realm of bringing another controversial topic that we see all the time in our clinics. What are we doing with women who are suffering from menopausal symptoms? Thankfully, this is a conversation that has come to the forefront, and women are at the forefront of the conversation, but I think it has left both physicians and women in general more confused than not. And what do we do when those patients come into our office, not on the treatment side, but really in our high-risk clinics, in our evaluation for benign disease? What do we tell those patients? Because those questions are coming to us. Dr. Veronica Gillespie-Bell is a nationally recognized obstetrician gynecologist. She is a women's health expert. You've seen her on TV. She is a public health leader. Her work focuses on improving health outcomes for women across their lifespan by transforming clinical care, health systems, as well as policy. She serves as System Medical Director of Health Outcomes and Medical Director of Quality for Women's Services across Ochsner Health Services, where she leads quality and safety initiatives in women's health care. She's a professor at the new and upcoming Xavier Ochsner College of Medicine. She directs the Minimally Invasive Center for the Treatment of Uterine Fibroids, another topic which can have, it's a whole other hour of discussion. Nationally known for her clinical expertise in managing heavy menstrual bleeding, performing advanced laparoscopic and robotically assisted surgeries. She also is the medical director of the Louisiana Perinatal Quality Collaborative and Pregnancy-Associated Mortality Review. That's a mouthful, but we know that there are so many, we have high pregnancy mortality rates across the nation. She has led statewide initiatives across more than 40 hospitals that have improved care and reduced maternal morbidity. Her work has shaped state and national policy, including testimony before Congress and being an invited speaker at the White House, Maternal Health Day of Action. She is our trusted voice on women's health from beginning to end, quality improvement as well as health equity. You've seen her on CNN, Good Morning America, CNBC. We're just happy that she's here with us. So please, in the short amount of time that you have, set us straight and give us something we can use on Monday to tell patients. Dr. Gillespie-Bell.
Thank you. Thank you so much for having me. I'm really excited for, yes, if you can help me, excited to be here and to be able to talk about menopause. It took Halle Berry going to the Capitol and saying, I'm in menopause, for us to start having these conversations. And these are conversations that we need to have. We need to socialize these conversations, and we also need more advocacy, and I'll talk about that as well. So I'm going to talk about some statistics with menopause, what the symptoms are, and talk about what treatment options are available. First, there is a difference between perimenopause and menopause. So perimenopause is when women are first starting to undergo those changes. They start to have irregular cycles. On average, it starts at 47 years old. The most common symptom, actually the first presenting symptom, is sleep disturbance. It's the waking up at 3 o'clock in the morning. I thought I had to pee, but I really don't have to pee. But now I'm up. I can't get back to sleep. Now I'm thinking about all these things. I can't go back to sleep. That really is the first symptom, is the sleep disturbance. And I see some faces that tell me you know what I'm talking about. But the other things that we see are hot flashes, mood change, and then again, those are regular cycles. Menopause is a whole year with no period. So for women that go 6 months, they don't have a period, and then it comes again, they're not in menopause, that's perimenopause. So menopause is a whole year with no periods. The average age is 53, and the most common symptom is hot flashes. So despite the fact that we have not really been having this conversation, 6,000 women enter menopause every day, over 2 million women a year. And these are not new numbers. We have not been talking about this. We do have disparities as well. Black women experience menopause about 8.5 months younger than their white counterparts, and their symptoms can be more severe. And 75% of women don't seek care when they're having these vasomotor symptoms, hot flashes, night sweats, vaginal atrophy. And then most women spend about 40% of their life in menopause. And so this isn't just a time of, I'm going to be uncomfortable and this is interfering with my quality of life. It can be much more than that. And again, 40% of the lifetime for a woman is spent in this time period. Again, looking at the vasomotor symptoms, about 80% of women have them. Now, just because you're in menopause does not mean you will have these symptoms. So that means there's about 20% of women that are in menopause that have no symptoms. And that's important when we talk about the Women's Health Initiative study. So again, those hot flashes are the most common symptoms when women are transitioning into menopause, with sleep disturbance being the first. Symptoms can last up to 20 years. So that is a long time for women to experience these symptoms and to suffer unnecessarily when we have treatment options. Again, the prevalence is worse in Black women. And then we see after that Latina women, then white women, and then Asian women. Other symptoms that we're now talking about more, again, the sleep disturbance, 94% even if you don't have night sweats. Decreased concentration, that brain fog that's not in your head, that is menopause. We now know that we have estrogen receptors on the brain. Decreased energy. Then we also have the more severe symptoms, severe vasomotor symptoms associated with higher blood pressure, higher cholesterol, cardiovascular disease, and osteoporosis. So again, menopausal symptoms are not just I feel uncomfortable. There are other medical complications that can come from that. And then vaginal dryness. This is one that patients don't like to talk about. For me, as a gynecologist, I'm doing an exam. It's something that I can see and can ask them about, but it's not something that most patients come into my office saying, hey, sex is really painful because it's really uncomfortable down. They're not saying that. And so 75% of women don't seek help because they're embarrassed. And when they start having that vaginal dryness, it's not just painful sex, it's also irritation, it's difficulty riding a bike. That again, burning with urination. And so this can be really, really uncomfortable. So with treatment options, there are lots of treatment options available. We'll talk about who is right for which treatment and contraindications, but we have hormone replacement therapy, we have SERMs, we have the neurokinin antagonists, which are a little bit newer on the market, and then we'll talk about bioidentical hormones, pellets, and then alternative options. So the Women's Health Initiative. So in 2002, I think this was the greatest tragedy to women's health. What came out in the media? Hormone therapy is stopped because there's an increased risk of breast cancer. So what happened? All women that were on hormone replacement dropped their tablets into the toilet. All the doctors said, stop taking your hormones. They wouldn't prescribe hormones. And then for me, I trained from 2004 to 2008. So then as a resident, we did not get educated on hormone replacement therapy. So the things that I know are from what I've done, my own research, and from looking at our professional societies. And so again, this I think was just really a tragedy for women's health. So what they actually found, and I think to talk about the study, so the average age of the women in the study were 63. They had been in menopause for 10 years or more and had no symptoms. So this is not the patient population we're going to be prescribing hormone replacement therapy to. So that was not a good representative. Now, those women did have some side effects, and so we don't generally now recommend starting hormone replacement in women that are over 65. But when they went back and did a secondary analysis, they found much different information that really, quite honestly, hasn't made it to the headlines in the same way. For women that were 50 to 59, looking at side effects and looking at risk for looking at it per 10,000 women, per year. For women that had estrogen and progesterone, so those women that still had their uterus, they need progesterone, they found an absolute risk reduction in colorectal cancer, all cancer, fractures, death from any causes, fewer cases of diabetes. They found a slight increased risk, less than 10 per 10,000, so then that's considered a rare event. DVT, pulmonary embolism, coronary heart disease, stroke, and breast cancer. There were 6 per 10,000 for breast cancer. For women that were 50 to 59 per 10,000, only taking estrogen, so these are women who had already had a hysterectomy, absolute risk reduction in coronary heart disease. What is the #1 killer of women? Heart disease, okay. So coronary heart disease, stroke, decrease in breast cancer, colorectal cancer, all cancers, in fact, fractures from osteoporosis, and fewer cases of diabetes. There was a slight increased risk, less than 5, so again, that's below our threshold to be a rare case, DVT and pulmonary embolism. So again, this is not information that has really made it to the headlines, and I think a lot of us that are physicians in practice as OBGYNs still are relying on the Women's Health Initiative study, which we really, it's time to change our practice. In November 2025, the FDA requested companies to update their language and remove that black label referencing a risk of cardiovascular disease, breast cancer, and it also said probable dementia on the black label, so that has been removed. There is still an increased risk of endometrial cancer for women that are just taking estrogen, so they do need estrogen and progesterone. Now, this does not mean, as much as I'm a big proponent for hormone replacement therapy, this does not mean that everybody is a candidate. For our patients that have breast cancer, it is still contraindicated, but it is not the only treatment for menopausal symptoms. So we also have our SERMs, our selective estrogen receptor modulators. These are really used for treating vaginal atrophy, and this activates estrogen receptors in the vagina for the SERMs that we use in not tamoxifen and raloxifene, but the SERMs that we use in gynecology. And then I think one that's really interesting is our neurokinin antagonist. So we have 2 on the market. Neurokinin B is a brain chemical, and basically it works in the thermoregulation center of the brain. So when we are not in menopause, estrogen is here, neurokinin B is here, and then once we start going into menopause, estrogen drops, but neurokinin B does not. And that difference is what causes hot flashes. So these 2 medications then bind neurokinin B so that it's lower, and that helps with those vasomotor symptoms. Now, it will not help with all symptoms of menopause. It's not indicated for that. It really just helps with the hot flashes and night sweats. Currently, it is not FDA approved for treating in breast cancer because there have not been clinical trials tested in women who have breast cancer or a history of breast cancer. There are physicians that use it off-label, but for the purpose of what is FDA approved, it is not FDA approved, although I hope the FDA is looking at it soon. Bioidentical hormones. So these became very, very popular after the Women's Health Initiative study came out. This is, well, there's different, let me say it this way, there's different categories. So bioidentical hormone is just a phrase meaning that hormones that are given to you are similar to what the body produces. So there are some that are FDA approved, such as micronized progesterone. That is a form of progesterone that is the closest to what your body naturally produces. But then we also have the bioidentical hormones that can be made by compounding pharmacies. I think a lot of women they feel that these are safer because they're not medications, but the reality is they're compounded, they're not FDA approved, so you really don't know exactly what you're getting. Also, it lacks the safety and efficacy data, so that we want to be very, very cautious of. Pellets. This is one of the ways to deliver hormones. When we do hormone replacement, we have pills, we have patches, we have creams, we have pellets. Pellets are they look like little grains of rice. They go underneath the skin. And usually patients will get them usually every 6 months. They are also not FDA approved. We lack the safety and efficacy data around pellets as well. When we've looked at pellets, or not me, but when they've done studies, they've looked at pellets versus hormone replacement. You are getting such a surge of hormones from those pellets, much, much higher than what you get from hormone replacement therapy. In this study that's cited here, they looked at pellets. They saw that women and this was looking specifically at testosterone. The testosterone level was between 194 and 400 nanograms per deciliter. That is an enormous amount. That's much, much higher than even the male level. When we do hormone replacement therapy, it's around 16 nanograms per deciliter. And so that is definitely a concern because of that big increase. Now, I will tell you from the patients that I know that have been on it, when they get their pellets, they feel like Wonder Woman. They feel like they could climb a mountain, they could push a car, they could, their libido is great, and then it falls off very quickly. And so they're always wanting to get those hormones faster, but there are concerns because of that really, really high testosterone level. Now, there are other alternatives. This is from the North American Menopause Society, their position statement regarding those alternative options. And so this first box are things that we should think about for our patients that do have breast cancer or are in remission from breast cancer, have a history of it. We have cognitive behavioral therapy, hypnosis, and the selective serotonin reuptake inhibitors. These are FDA approved for treating menopausal symptoms, and in general, breast cancer is not a contraindication, so these are really, really good options for those patients. Again, this is going to help with hot flashes, it'll help with night sweats, it won't help with vaginal dryness or some of those other symptoms, but these are options that are recommended. Other things that may benefit, inconsistent data that shows that they benefit, losing weight, reducing stress, soy. We do know that soy gets converted to a form of estrogen, but it's been inconsistent in the data as far as relieving symptoms. Stellate ganglion block is an option as well. Things that have been shown to not work, cooling techniques, which is something I know we tell patients all the time, just put a fan by the bed or have a cooling pillow, exercise, yoga, and even some of the herbal options that are recommended like evening primrose, black cohosh, those actually haven't been shown to be effective. And so the question is, where do you start? So if you have a patient in your office and it's a high-risk patient, and or what I hear from patients is, I don't want to take hormones because my grandmother's sister had breast cancer, or we think she had breast cancer, but we didn't really talk about the history back then, but we think she had breast cancer, so I have an increased risk for breast cancer, so I don't want to take it. So we have to definitely use a shared decision-making model with our patients, understand what our patients are wanting, what are they looking for, what symptom is it that they would like to treat. We have to help them compare the treatment options, We have to, again, for those patients that may be high risk, we have to quantify what their risk is, and also now understanding what the Women's Health Initiative study shows. We have to assess their values, reach a decision with that patient, and then evaluate the patient's decision. It can be a lot. There's a lot of information out there that is not accurate. And so it is really, really important for us as healthcare providers to understand what is accurate, what the data shows, and to be able to walk our patients through that process. So vasomotor symptoms are very common in perimenopause and menopause. Many women suffer in silence. Hormone replacement is safe for most women, and there are alternatives for those who are not able to take hormones. And then I feel like there may be some questions about this, so I'll be happy to answer questions at the end, and this is my contact information.
Thank you so much, Dr. Gillespie Bell. 40% of our lifetime, huh? That explains a whole lot, a whole lot. You know, we've talked about treatment. We've talked a little bit about those who are high risk. We can give all of our patients great treatment, and then we're on the other side in survivorship. And just like Dr. Gillespie Bell said, women suffer in silence. We notoriously do that. We take care of everyone but ourselves, and we ignore, ourselves repetitively. Even for our breast cancer survivors, they don't have to suffer. I'm pleased to introduce Shauna Moron, who we work in collaboration with our breast and GYN-ONC team. She is an APP with the GYN Oncology Group at University Medical Center. She really is our go-to person to be able to help women on the other side of their treatment who we are giving life-saving treatment to, and tell them that they have to be on it for 5 years or 10 years, or that their ovaries have stopped functioning, and they think that we don't care, but we do, and we should. They are suffering in silence. She is the head of our Garnet Clinic. Don't ask me what the acronym is, totally. But it really is our clinic, our partnership clinic at University that sees women who have any female cancer and who have symptoms and side effects, and really focuses in on what women are feeling. Like Dr. Gillespie Bell said, they won't talk about it, but we make them talk about it. We ask the questions, are you having this? And give them a safe space in order to tell us their symptoms so we can help them. So Dr. Moran is gonna let us know what is safe. And also sometimes as medical oncologists, you all don't want to prescribe some of these medicines for your patients with breast cancer because you think it's going to counteract what's happening with their breast cancer risk. But Shauna's going to tell us that it's okay.
Somewhat. Thank you. Thank you, Dr. McKinney. I might need help. Oh, here we go. I got it. Yeah. And then where are the? Okay. Oh, here we are. Okay. Yep. Awesome. Thank you, Dr. McKinney, for the introduction, and I'm honored to be back here at CAGLA speaking. Thank you, Dr. Gillespie, for laying the foundation. There's going to be a lot of redundancy probably here today, but I'm really going to focus on our female cancer patients. I don't have any disclosures. So the elephant in the room now after that talk is, should we use hormone therapy in our breast cancer survivor patients for the treatment of their menopause symptoms? And just like everything in medicine, it's a balancing act between the risks and the benefits and having these shared decision-making discussions with our patients. Women's Health Initiative in 2002, what it did is it stopped real discussions about menopause between patients and clinicians, and women began to suffer in silence. And as was said before me, in November of 2025, the FDA lifted the black box warning for estrogen products in the use of menopause hormone therapy. And now we're in a menopause revolution, and you get estrogen, and you get estrogen, and right? And that's where we're at. Our professional societies were out in front of this, and 3 days after the Health and Human Services announced this, ASCO put out a statement, and in their statement they said systemic hormone replacement therapy remains contraindicated for women who previously had breast cancer, particularly those with hormone receptor positive disease, and also other estrogen responsive cancers due to the increased risk of occurrence. However, low dose vaginal estrogen remains a good option for those survivors whose genitourinary symptoms do not respond to non-hormonal treatments initially. And of course, this should be done after having a discussion about relative risk and benefits with an oncology professional. So why does this discussion matter? Well, it really matters because we know that our patient population that we treat, female cancer survivors, their menopause symptoms are often more severe. This gravely impacts their quality of life. We also know that there's conflicting messages out there amongst media outlets and between clinicians themselves. Our breast cancer patients are now on longer treatments, more complex endocrine therapies. This can cause adherence consequences, so up to 25% of our breast cancer patients will often stop their endocrine therapy due to the side effects. And then, of course, patients can also go online and get estrogen products. So it's really important that we're having these informed conversations with them so that they're not just going out there and getting, what was told by them on Instagram to get, and then it's a risk to them. So this discussion, this menopause discussion with our patients really does matter. Breast cancer is not a monolith. Every patient's needs differ, and the treatments must be individualized. SGO also put out a statement after the removal of this black box warning. Basically in our GYN cancers, I won't spend a lot of time, I do work in gyn-onc, so I do want to talk about gyn-onc a lot, but basically in our gyn-onc clinic, we are starting to prescribe hormone therapy for these symptoms in our lower risk patients. We are not giving it to our advanced stage endometrial cancer or uterine sarcomas, nor are we giving it to our low-grade serous or endometrial ovarian cancer patients. The AUA also put out a statement, and just kind of focusing right here for the sake of time, the middle one here. So the AUA said for GSM symptoms with patients that have a personal history of breast cancer with GSM symptoms, it's recommended that we use low-dose vaginal estrogen, but using a multidisciplinary shared decision-making model. More recently, in January of this year, there was a comprehensive review looking at the current evidence of menopause hormone therapy amongst breast cancer patients, and Glenn and Associates put together a 25-member multidisciplinary panel, and the panel consisted of 18 physicians across various specialties. They reviewed the current evidence relating to the use of vaginal and systemic menopausal hormone therapy, and based on the available data, the consensus is that shared decisions be based on an individual's menopausal symptoms and impact on quality of life, the potential increase in an individual's risk of relapse by use of menopausal hormonal therapy, and patients' preferences, views, and treatment goals. Also, at the end of last year, there were 2 systemic reviews and meta-analyses that looked at recurrence data with our vaginal hormone use in breast cancer survival, and both of these reviews concluded that there was no significant increase in cancer recurrence among our breast cancer survivors when using vaginal estrogen therapy to treat their symptoms. This is kind of a table that really looks at the different studies that were reviewed in that data, and I did want to highlight one of the studies that can cause some controversy or that people talk about is the Danish study that came out in 2022. This was a large cohort of postmenopausal Danish women with invasive non-metastatic ER-positive breast cancer that were diagnosed between 1997 and 2004. They did a stratification by adjuvant endocrine treatment and found that women that were on an AI had an increased risk of breast cancer recurrence if they were on vaginal estrogen. However, the same study found that there was no increase in women who were using systemic estrogen, which I think is interesting. I do not believe that this study should be practice changing or deter us from using low-dose vaginal estrogen, and the reason why I believe that is because that the women that were included in this study, this was done during a time when it wasn't reported that there was any HER2 expression or molecular signature testing. It was very hard to stratify how high risk these women were. Also, the type and standards of endocrine therapy have changed since that time, and the type of vaginal estrogen. So in this study, in the Danish study, the vaginal estrogen that they were using was a very high dose of 25 micrograms. That's not what we're using now. We're using lower doses of vaginal estrogen. So ultimately, I think what this study, the Danish study, tells us is that we need to continue to personalize our approach to our patients, weighing all of the factors that we've been discussing. So implications of estrogen exposure. So from the standpoint of or regarding systemic hormone therapy in our patient population, this is generally avoided or it's used with extreme caution in our ER-positive patients, regardless of their surgery type. Mastectomy does not eliminate the systemic risk of recurrence. Local and vaginal estrogen for GSM symptoms there's increasing evidence that supports careful shared decision-making with its use. Surgery type plays less of a role than recurrence risk, time of diagnosis, and ongoing endocrine therapy. So we've looked at the literature showing no increased risk with low-dose vaginal estrogen. We know what the recommendations from our professional societies say now. But maybe you've never prescribed local vaginal treatments, or you're not comfortable with the signs and symptoms that patients may present with. So I just want to spend a little bit of time talking about that today. It does start with knowing that we can make a difference when we validate and listen to women for the purpose of improving quality of life, extending outcomes, preventing long-term consequences, and really empowering women through education. Because menopause is survivorship care, and these discussions will not happen in 5 or 10 minutes. When we open this discussion up to our patients, it is important to know that the indications for hormone therapy, this is based on the Menopause Society's most recent position statement, where they're looking at indications for hormone therapy in average risk women. And these guidelines do recommend that we use caution with estrogen in our breast cancer survivors. But of these 4 categories, we're going to cover the GSM. Today more closely. The Menopause Society statement says that there's random controlled data and evidence for restoration of GSM anatomy, reduction in pH and symptoms of GSM, an increase in superficial vaginal cells for women that are just having symptoms related to GSM, and that we can just treat locally. So what exactly is GSM? Thank you for asking. So many of you probably know all of these symptoms, but just as a reminder, as we keep our patients in the center, oftentimes women will experience dryness, lack of lubrication, as well as that infamous vulval vaginal atrophy or changes to the vulval vaginal tissue. This is why I really do like the term GSM better, because it acknowledges that it's not just the vagina and the vulva, but also many women have urinary symptoms and recurrent UTIs. It also includes sexual dysfunction, and we know that sexual health is health, and this is an important quality of life a factor for women. All of these symptoms can be subjectively reported by patients, but what are the objective findings when your patients come and say they have these symptoms? So Objective findings are going to come from doing an exam. I realize that not every clinician feels comfortable with doing a pelvic exam. But I assure you, we were all trained to be able to do pelvic exams, and we all can do them. They're within the scope of our practice, and you're not going to break your patient by doing a pelvic exam, even if you don't have a lot of experience doing it. It actually is going to give you valuable information to help have those shared decision makings and guide your treatment if you can get those objective findings. So what are you going to see if you do a pelvic exam? Oftentimes you'll see stenosis or narrowing or shortening of the vagina. The vagina tissue is going to be a little more, there's going to be some hypopigmentation, a loss of rugae, thinning of the tissue, sometimes thinning of the hair. You'll see micro fissures in the vagina, and there's going to, the vaginal pH usually increases. You might see like a yellow, like stringy discharge that's not really consistent with BV. There's fusion of the labia minora. The urethra becomes more prominent. Everybody's faces are cringing, but these are the things that women are suffering with, and this is what you find on exam. This is true. Oftentimes the cervix becomes flush with the vaginal apex, and we really need to be, we really need to be proactive about this, because the fallout of GSM is that these symptoms are chronic and progressive. They get worse when not treated. And it leads to painful intercourse to the point where women stop being intimate and they just stop having sex with their partners. There's a downstream effect with issues of self-confidence and self-esteem, relationship breakdowns. So it's not just the GSM. This is a much bigger for women, and sexual health is really a really important part of their overall health. So we need to encourage women to treat this right away. There's nothing wrong with women. This is just physiologically what is happening, and we need to support them and be proactive. So as mentioned, 70% of breast cancer patients experience GSM, and more than 50% of them experience sexual dysfunction, with dyspareunia being the most common complaint. Younger patients, these symptoms are often more severe and they're at higher risk. There are barriers to personal and systemic. The barriers are both personal and systemic for clinicians and patients due to limited data, time constraints, lack of comfort with the topic, and as was previously mentioned, up to 75% of patients want their clinicians to initiate these conversations. So my recommendation is in your survivorship clinics to have maybe a menopause screening tool that patients can, check the box of these symptoms, and this will open up the discussion and allow you to screen for these symptoms and get that conversation going. I'll briefly touch on this, but some of the GSM therapy options obviously are non-hormonal. We have vaginal moisturizers. I always tell patients these vaginal moisturizers are something that you want to use every day, like you put moisturizer on other parts of your body. You're going to just do that in your vagina every day. And the more consistent you are with it, the better outcomes you're going to be. These moisturizers are not used for intercourse. We have lubricants for that, and I always counsel patients, even if they're on vaginal estrogen, to still use copious amounts of lubrication during intercourse to reduce that friction. Some of the pharmacologic options are vaginal estrogen, vaginal DHEA, and ospemifene. It's important to know that no one medication, including hormone therapy, is enough to fully optimize midlife health. Just briefly, DHEA, these are vaginal suppositories that have been shown to work great for GSM and treating dyspareunia. In the studies, the serum steroid levels were within normal postmenopausal range, and there was no change in the endometrium. So just a note, with all of these vaginal topical therapies, you don't need a progesterone to protect against endometrial cancer like you would if you were using systemic hormone replacement and they had a uterus. Important to know that the data here with DHEA is limited in breast cancer survivor, but there are some trials looking at women who have survived breast cancer and are on an AI that DHEA is both effective and appears to be safe. Another pharmacologic option is the ospemifene, and really what I'll just highlight on that is that that's not approved for use in breast cancer survivors in the US. but it is approved in Europe, and they're using it in breast cancer survivors in Europe. So that's probably just important for us to know, because our patients might be hearing this, on social media or through media outlets, and we want to make sure that we're giving them informed decision, letting them make informed decisions. So some of the different formulations of vaginal estrogen, we have various different types of low-dose vaginal estrogen. There are rings, creams, inserts. Systemic absorption varies by formulation, so the NCCN recommends these bolded or highlighted options for consistent dosing and lower systemic exposure. The ring, the tablet, and the insert, as you see here. I did want to point out that the ring, the 7.5 microgram ring, the brand name is E-String. That's for local use. The other 2 rings that you see here at higher doses are for systemic use. All right, so let's talk about what estrogen does for the vulvovaginal area and why we will probably see better benefits from local estrogen use for these symptoms than we will with the non-hormonal. So basically, vaginal estrogen reverses all of these symptoms that come with menopause. It lowers the vaginal pH, it increases the proportion of superficial cells and decreases the proportion of parabasal cells, thickens the epithelium, increases rugae and elasticity, increases vaginal secretions, vibratory sensation, and it alleviates the subjective dryness, itchy, and irritation complaints that our patients have. When counseling patients, it's important to use these principles and approaching the conversation from an evidence-based standpoint and not a fear-based standpoint. We always discuss risk versus benefits, helping our patients make a decision they feel good about while taking into consideration their values and goals. Using informed consent and allowing for patient autonomy. I do believe women have a lot of wisdom when it comes to their bodies and how they feel, and I believe that if we present women with all the data and all the information, they can make a decision for their bodies that they feel really good about, and really that's the essence of patient autonomy. A few pearls when treating GSM. So for our high-risk patients, you always want to start with aggressive moisturizers, some of the non-hormonals that we talked about. The more proximal vagina, or the upper third of the vagina, is where the highest absorption is going to occur. So for our high-risk patients, it might be more beneficial for them to use cream around the introitus or the distal vagina. And along those lines, our patients who are having pain with insertion during sex, estrogen could be beneficial when applied to the introitus. And then always, it's very important that if these patients are complaining of vulvovaginal symptoms and the symptoms are progressive, that we consider biopsying it, because a lot of our vulvar cancers and other etiologies start with itching of the vulva. So it might just not, we don't want to miss a secondary cancer. Pretty much. Key takeaways, so first-line treatment in our female cancer survival should be non-hormonal options. Low-dose vaginal estrogens and vaginal DHEA can be considered for many with GSM. Also to note, low-dose vaginal estrogen and vaginal DHEA are systematically absorbed in a dose-dependent manner, with the serum estrogen levels being maintained within a postmenopausal range. Breast cancer and menopause is not a one-size-fits-all. These discussions require a collaborative approach because they're very nuanced. Patients have differences in their personal values, individual risks, and their tolerance of uncertainty. And hormone therapy, whether it's systemic or vaginal in our breast cancer patients, should not be a hard no without having a valuable discussion with the patient first. I wanted to plug the San Antonio Breast Conference of this last year, because they did an entire session on hormone replacement therapy in breast cancer patients, and they do have a YouTube channel, and I highly recommend that references, and thank you so much for having me.
That was great. Thank you so much. And we basically stayed a little bit on time. So I appreciate all of the speakers. If you have questions for any of our speakers, please raise your hand, yell out, let me know. Yes. Okay, discussion on progesterone. Is this mic working? Okay, thank you.
Turn it on a bit. Okay. So for when we're doing hormone replacement for women that still have a uterus, we always have to balance the estrogen and progesterone, because if you give unopposed estrogen, then it can lead to endometrial cancer. For women that are having difficulty sleeping in their perimenopause, again, what I was saying earlier, micronized progesterone is the one that's the closest to what our body naturally makes. And so for a lot of my patients, they may not have hot flashes, night sweats because they're perimenopausal, so we do Prometrium at night because it makes you sleepy, and it definitely helps with sleep. Did that answer your question?
Yes. And how do you monitor the levels of all of these hormones once therapy has been initiated?
So that's a great question. I generally, in the recommendation from ACOG, we don't monitor any levels. All the time I have patients and they're like, I think I'm in menopause. Can we check my hormones? And I say, well, what hormones do you want to check? Because if you're in perimenopause, hormones are doing this. If you've had a year with no periods, then your hormones are this. So we don't need to check any blood levels. And we generally don't check for even once women are on hormone replacement therapy, because we're managing based on symptoms. Mm-hmm.
Yes, sir.
So, part of this conference has been about precision medicine, and a lot has been about data. And as a musculoskeletal physician, there's benefit beyond the menopausal symptoms from both estrogen and progesterone on supporting the musculoskeletal system throughout life. And data is important. And so, when we look, so we have women who, they get breast cancer, even men, there's a range of what we see in, patient body habitus. So if we're going to talk about data, we should be checking hormone levels. And part of it, like the problem with the blood is that it's kind of not truly as specific as what we use, which is saliva. But if you happen to have, say, extra fat in your body, you are going to convert DHEA to estrogen. So without knowing what the estrogen level is, and then giving estrogen as a therapeutic, thing, you're adding to the estrogen, and you could possibly be adding to increasing the risk of getting breast cancer. And the natural down-regulator in the body for estrogen is progesterone. So whether you have a uterus or not, if you want to give estrogen, you should complement estrogen therapy with progesterone.
Do y'all want to start that first, or no?
Everybody has an opinion. That may be what the musculoskeletal literature says. That's different than what the American College of Obstetricians and Gynecologists and the North American Menopause Society recommend.
Yeah, I mean, even without measuring hormone levels consistently in the body, the data does show that it does not increase our breast cancer risk. Now, there are other risks for breast cancer that we counsel patients on that they have the power to reduce: obesity, alcohol, smoking, all of those things. So this is not done in isolation, but it's done in congruency with other things that you need to do as a whole to reduce your risk, not only for breast cancer, which you may be at a lower risk of than health disease because of your obesity, or other cancers. So again, a collaborative, a multifaceted type of discussion I feel is important. And all too often, those conversations are not happening, one, because physicians, unfortunately, don't have time to have those discussions. But it can be done with your nurse practitioner or APP. when you have a team where that's important. So I'm all for, a collaborative care for the patient, but these things are not, although we're focusing on hormone replacement, we recognize that we take the patient as a whole in totality, and things that can be done to reduce their risk, those things are also discussed and should be as a part of their total care.
I will add that the data that we talked about here today in our breast cancer survivors, there's limit in what is the risk of recurrence when using hormone therapy to treat these symptoms. There's limited data, and the data that we have is not long-term data. So it does need to be studied more. But we do have enough to feel comfortable in improving the quality of life for women, because we know that their outcomes are actually not as good when they're suffering from these symptoms. So we do know that, and we have data, along those lines. And so I would rather my patient, we would rather, and I think the professional recommendations out there are considering this, that we would rather our patients have better quality of life during that survivorship period, because that does lead to better outcomes, and to be suffering and potentially quit their long-term therapies, their endocrine therapies, things like that. But to your point, we do need more long-term data that looks at this, and I think that we're getting there to that point where we're realizing this is important and we need to study this more.
I think just to echo that, I'm so glad that these conversations are happening. I do think we're seeing more of this, unfortunately, or maybe fortunately on social media, but I think also here in data, I mean, I have patients now coming and asking, okay, you're giving me an aromatase inhibitor. What is this doing to my long-term risk for osteoporosis? What about, is there a risk of dementia? Is that, I think patients are more tuned into these side effects. And I think on our end, just making sure we're asking the questions, asking about vaginal dryness. I promise I do try to make a point to ask about that, because patients often, as you mentioned, are really not going to lead with that. So making sure we're asking the right questions and really having informed discussions with them about the risks and benefits. Sort of the line I use is, I never want the prevention of a breast cancer that may or may not ever come back to bother you to make your quality of life terrible, because otherwise, what's the point? That's not to say I'm obviously not encouraging hormone replacement therapy, but certainly using things like vaginal estrogen and things that we know have been shown to be safe in these patients is important.
Yeah. Any other? The question is, any comment on the Mona Lisa trial? Is that what you're, oh, Mona Lisa procedure. That may be a Gillespie Bell question.
I know I have.
We do have a Mona Lisa restaurant.
Okay.
Sorry, I went straight to trial mode.
It's not a procedure that I perform. I think there's a little bit of data out there on that, but it's not a procedure that I perform. I don't know if you want to. Did you have more?
Mm-mm. What? Prolapse? Okay. Okay. All right. See, I always tell patients I'm from here to here, so like procedures that are lower than that, I'm not well versed on. So, but Dr. Gillespie Bell has informed us that it is a procedure for vaginal prolapse to lift and tighten, which can happen, yes, urogyne, yeah, I'm sure that you all see that in the gynecological realm, and that can be a certain contributor to a lot of the symptoms that patients can have, just as a result of aging.
Yeah, I mean, and typically, what the data has shown to benefit for those patients, because that is true that once they're starting to go into menopause, in addition to having atrophy, you can also have some pelvic organ prolapse, especially if they are women that had children, not even delivered them vaginally, just carried children, then they do have an increased risk for that. One of the first things that we do recommend for that is vaginal estrogen. And actually in a head-to-head study between DHEAS vaginally and vaginal estrogen, DHEAS does better for actually bringing moisture and repairing the tissue, making the tissue thicker. So we usually recommend that, and starting with pelvic floor physical therapy, those things have been shown to help, not just for incontinence, but just even that sensation that things are starting to fall.
Thank you. See, I'm learning all kinds of new things. Any, yes? Yes.
Hello. My name's Destiny. I'm a senior biology freshman at Xavier. This could be more of a plastic surgery question, but when it comes to breast implants and, women who survive breast cancer and would like to have that as your reconstruction option after mastectomy, has anyone looked at the use of estrogen and how that would affect that reconstruction option? Estrogen or any other hormone replacement therapy?
You want me to talk about? So after we do mastectomies and patients have reconstruction, it's not the implant that is the issue, right? Even with mastectomies, the risk of recurrence with breast cancer doesn't go down to zero. Nothing's 100% or zero in medicine, right? So you still have a risk of breast cancer if you have a breast cell that is left after the mastectomy under the flap. So it has nothing to do with the implant or where the tissue is taken from. It can be taken from the belly, the back, the thighs, the buttocks, whatever. That's not the tissue that could develop into a recurrence. It's the potential tissue that is left underneath the skin for a cosmetic reconstruction that has the potential to develop into breast cancer. That risk is still low with mastectomies, whether patients are on hormone therapy or not, hormone replacement therapy or not. It does not affect the implant. The hormones don't have any effects on the implant. Is just a plastic piece of or silicone, or no, it doesn't. Doesn't affect that. It's not tissue. Yeah. Any other questions? All right, we have 3 minutes for you all to get ready for the crawfish boil. Thank you so much for attending. We'll see you next year.
Dr. McKinney.